Check, check, check.
మనకు రాకపోయినా పర్లేదు, వాళ్ళకు వస్తుందా వీడియో? ఏసీ కూడా ఆన్ చేస్తుంది. Very good. Good OT. Big OT. Well managed.
A very good morning from SVS Medical College. A warm welcome to everyone present with us here and joining us live. This past week has been an eventful one here in SVS. We've kicked off the Arthritis Week with a walkathon held on 5th October. It was an awareness week for us here.
The patients who underwent the replacement had joined it, and it was very wonderful to see them happy and healthier with a comfortable lifestyle. Over the week, a free arthritis screening camp was conducted from 5th to 11th October, where patients were screened, educated on arthritis and preventive methods.
As we begin our live surgeries conference today, we hope today is a learning experience for everyone joining us here. I would like to invite on stage Dr. KJ Reddy, sir, Managing Director of SVS Medical College and Hospital and Chief Joint Replacement Surgeon.
Good morning. Thank you very much for joining us this morning. We're going to have a great day with live surgeries. Planned about 8 live surgeries with leading faculty in the front row. Thank you very much for all the faculty sparing your time on a busy weekday, and some of you traveling after this session. So once again, thank you for very much coming over and spending time with us. It's going to be an interactive session, as just now said. It's live on YouTube, Facebook, so you can share the link with your friends and colleagues. We're going to be variety of surgeries. Already first surgery, Dr. Sudhir Reddy is waiting in the theater. So probably going to be interactive session. We would encourage everybody to ask questions at the end of every session and enjoy the day. Thank you very much.
Thank you very much, sir. I'd like to introduce the first case we're having in surgery today. A 65-year-old female with pain in both knees since 2 years. She's having pain more in the right knee than the left knee. She's a known hypertensive patient, and on examination, we had seen FFD was absent. I would like to invite on stage the chairpersons, Dr. K. Anjanailusa, HOD of SVS Orthopedics Department, and Dr. Srinivas sir.
We'll go. And just stay for half an hour.
Can we connect to the OT, the audiovisual team in the OT?
We can hear you. Can you hear us? Hello?
Good morning, Sudhi sir. Can we hear you?
Yes, we can hear you. Can you hear us?
Dr. Jairam, can you hear us?
We can hear you. Can you hear us? Yes or no?
Sudhir, can you hear us clearly, please?
Okay, you have to call him, I think. We can hear him. clearly.
Yeah. Over to you. Please walk us through the case and then you can start the case now.
Can you hear us?
Yes, loud and clear.
Okay. And this is I think she's already introduced the case. This is a straightforward knee. Bit of valgus may not be reflected on the standing view X-ray there, but there's maybe 5 degrees of more than the natural valgus. And the most important thing I would like to know whenever I'm starting a primary is there a hyperextension deformity? Because my very first cut will depend on that. Okay, there's no hyperextension deformity, there's no flexion deformity. Okay, so slight bit of valgus, that's all. So it's only a little bit of valgus, so it's not going to affect my angle planning or bone cuts much. Okay, so just straightforward knee. I'm going to start. Can we start?
Good morning, Dr. Sudhir, Dr. Anjaneyulu and Dr. Srinivas Reddy here,
Sir, good morning.
chairing the session. Can you project the X-ray picture, please?
Yeah. Okay. Can you zoom in, please, on the X-ray? So you can see it's a fairly straightforward arthritis case, more rare on the lateral compartment than the medial compartment in the short film that you see there. Slight valgus. In the standing view, of course, you see the weight-bearing line going through the middle of the knee, but I think that view is in quite a bit of external rotation, so I'm not really going to count on that much. Okay, so it's a slight valgus, straightforward knee, no severe deformities, not too many osteophytes, should be fairly straightforward. Okay, no other surprises as such. Any comments, sir?
Yeah, thank you.
Right.
Can proceed with the
Okay.
operative session.
Sure. Tonica, please.
Is it a obese patient or an average build?
No, sir, it's an average built patient. Okay. So my thumb is on the tibial tuberosity. I'm a subvastus surgeon. All my surgeries, everything is subvastus. So my incision is just slightly to the medial to the tibial tuberosity, so that patient does not have, when they kneel or touch their knee on the floor, the scar is not hypersensitive. So incision through skin and subcutaneous tissue. Will you see the capsule? Forceps, please. Raise the flap of skin and subcutaneous tissues. Okay. So as I said, I'm a subvastus surgeon, so not sure. I don't do a medial parapatellar at all. So I hope that's okay. Okay. So here, this is the skin and subcutaneous tissue flap. I incise the deep fascia over the muscle. Okay, and I leave the fascia with the skin and subcutaneous tissue face flap. So this is a vastus medialis. I'm not sure you can see that. Okay, is it possible to show? No. Okay, I think the camera, the angle of the camera is positioned at the foot end of the patient, so you may not be able to see very clearly how I'm just clearing this vastus medialis. My finger is around the vastus medialis muscle, so I lift the vastus medialis muscle with my finger. Can you see that?
Yeah, very clear.
Yeah.
the muscle belly.
Yeah. So it comes off easily, and then it is a horizontal about an inch incision of the capsule where it is inside onto the capsule to the medial border of the patella. Okay. So it's a horizontal half inch, 1 or 2 centimeters, half inch. Okay. And then, so that is the incision. Maybe you can see that. Sorry. Can you focus, guys?
Okay, can the camera be adjusted to the top of the knee?
Yeah. Can a camera come here? Or
Meanwhile, can you tell the advantages of the subvastus
yeah.
over the
So,
conventional
yeah, yeah.
medial parapet?
No, that camera is too far. Really, they can't see. I don't think they can see that camera. You have to come nearer and show from above. And to right also. Sir, subvastus approach preserves the entire quadriceps mechanism in its natural place and natural shape. Okay? So I have always done subvastus approach for the last 15 years, every bit of my primary. I have not done a medial parapatellar approach for a primary in the last 15 years. Not single case, whether obese or however severe is the deformity, I've always done subvastus approach. The advantage is you're preserving the entire quadriceps mechanism in its entirety. So the patient, the pain is quite less compared to medial parapatellar. Also, post-operative mobilization is pretty good. Actually, 80% of my patients do not require post-operative physiotherapy. We don't advise post-operative physiotherapy.
Can I have one question, please, regarding vastus? Hello.
Sure.
Vastus, we are releasing completely. The post-operative problem we have is the terminal extension of the knee. So you'll be losing the terminal view extension of the knee. Is it not a problem?
Sir, say it again. I am not able to hear you.
Vastus medialis, we are cutting completely, no? The terminal few degrees of extension you do post-operatively is very difficult to do it. So unless.
Sir,
Right.
No. We are not releasing the vastus medialis at all. I am releasing the small part of vastus medialis which is attached at the patella. About less than this is the incision I made is from here to here. In the vastus medialis from here to here. The rest of it is already free muscle. So from here to here, about 1.5 centimeter incision is what I made.
But what about the obliquus which is there? That's the function is lost if you do this, no? VMO function is lost if you do these things or no?
It is not lost because the muscle is entirely preserved. The muscle is completely preserved and inserting onto the patella.
Right. Okay. That's good. Please go ahead.
Yeah. And this is the tibial tuberosity. So I give a vertical incision from here to the medial side of the tibial tuberosity. So vertical incision. So it's almost a inverse L shape, or it's an incision like what we give for unicondylar knee replacement. And this is a synovium. This is the synovium. So vastus muscle, the vastus medialis quadriceps, I'm lifting with my finger. This is the synovium, what I'm cutting. Okay, you can switch it back synovium also if you want. I used to switch it back because to prevent additions. Give me a spike, please. Exercise incision a little bit. Okay, forceps. So this is the anterior fat pad. I don't remove entire fat pad. Whatever is that is coming in the way, we remove that. Okay, and then I start with removing the medial meniscus, incising the medial meniscus, and take that flap inferiorly a little bit. This is just so that you can suture the flap when it comes to suturing. So we don't usually do any significant release of soft tissues. In this case, it is not required at all. Okay, spike please. Spike on there. Go spike in there. Give it a try. Let me try another spike. Okay. Very good. It's same. Huh? No. So okay, we're just we're not used to these spikes, so I'm just trying different spikes. Okay, give me another spike for medicine. Okay. Are you able to see clearly? I think you
Yeah,
have.
please go ahead.
Nibbler, please.
Now the picture is quite informative now.
So this is a medial meniscus. I'm just releasing the medial meniscus. Okay. Removing the ACL. Okay. Central spike, please. One more spike. That's okay. Just release on the. Okay, I'm not sure. I think you have to. The other camera is not doing anything at all.
Sudhir,
Yes, sir.
you are always avert the patella or just subluxate the patella?
I never avert the patella.
Okay, okay.
After the bone cuts, we just sublux the patella.
Okay, okay.
After the bone cuts,
Mm.
then I avert the patella to see, to prepare the patella, to do any, to remove any osteophytes.
Okay, okay.
That's a good demonstration, Sudhir. Can you ask the cameraman to put the second camera from the top?
Yeah, so can this camera come from the top, please? Where is it focused? Okay, sir, we're waiting for a couple of minutes to get the camera adjusted.
So, Sudhir, always you use tourniquet, pneumatic tourniquet?
Most of the times, yes, sir. Unless there is a contraindication, like any arterial disease or any cardiovascular compromise, the anesthetist tells me not to use. I have in the past used to operate without tourniquet. And in bilaterals especially, I used to use tourniquet on one side and no tourniquet on the other side to see whether it actually makes much difference to patient's pain post-operatively.
Yes, yes.
But to be honestly, I used to ask my registrars to go and check with the patient which knee is more painful. To be honest, I never found much difference at all. And in fact, without tourniquet, many times the field is really bloody and becomes slightly difficult. So I just saw no point in not using the tourniquet for usual cases. And so we go ahead, we use the tourniquet.
Okay, good.
Right. Guys, cameras, you need to. Where is it focused? Is it focused there? No, there's only one camera that is focused. ఇది కూడా కొంచెము ఇక్కడికి వచ్చి హైట్ ఉంటే కనపడుతుంది కొంచెం. Slightly height top నుంచి వస్తే. And that camera, I don't think it's working or showing anything. What is being shown is this camera from the foot end. I'm just removing the lateral meniscus. Okay, we're not used to these spikes. Okay, give me another spike. Give me that spike, I'll try that. Huh? Yeah, maybe. Let me try this. This is slightly better. Guys, ऊपर करो भैया, ऊपर से दिखाओ बोल रहा है. तब से बोल रहा है, तब से 1 इंच भी हिला नहीं. ऊपर नहीं कर सकते क्या? हाँ? मैक्सिमम हाइट है तो बोलो. मैक्सिमम हाइट है ये. Next, please. a bit. Very good. So we're just waiting for the cameras to see if they can show you better.
So infrapatellar fat, usually you will cut off half of that or
Sir, just whatever that comes near.
okay.
Excuse me. Excuse me. Bring it near and show slightly from the top. If you keep it that far, what is the use? भैया पास में लाओ बोल रहा हूं huh? But the angle will not come, no, if you keep on the other end of the room. Sorry? Yeah, okay. Then you won't be able to show anything actually.
Usually you will identify infragenicular artery on left
No, sir.
side.
No.
Okay.
No. Many times, sometimes when I remove the lateral meniscus, then if I see it, then I may burn. But I have stopped using the tourniquet in TKR many years ago. I have never used tourniquet, so I don't burn it anymore.
Okay.
Okay, I'm just removing some suprapatellar soft tissue synovium so that we get a good bony landmark there. Reaction, please. So I think the most important first step is you should really get a good exposure of the knee. If you're not able to see well, spend few more minutes and get the good exposure, because that will save you a lot more time later and also a lot more complications. If you don't see it well, if your retractors are not good, you're not able to retract well, you're not able to see well, you're struggling throughout your surgery. No, it's okay. Lateral spike, please. Not sure which one we're using for lateral. Okay. So, Del, please. Okay. So, if you are not seeing well and struggling, then it's very likely that you end up with complications. Okay. So, this is my femoral entry point. This is the PCL, maybe about half a centimeter above the PCL insertion in the white sides line. I have a rice tube. Okay. I use a rice tube to suck the entire medullary canal. I attach the rice tube to here and put all the way up in the medullary canal so that it removes the fat in the medullary canal. So
usually you will do irrigate with any saline in the
no, sir. I used to irrigate with saline. I used to suck out all the fat, then put some saline and irrigate. More and more, I started reducing interventions, which I think may contribute to infection. So once I use rice tube and clear that, I don't see the need to irrigate.
Okay.
So this is fine. Right. Sir? No, it's okay. It's not much valgus, so I'm not going to change. Okay. Saying well, okay. Pins, please. Pins in 0. So this is an intramedullary femoral alignment guide, and we fix the cutting block with pins in 0 position. So if it was a significant valgus, how do I remove this? if it was a significant valgus, I many times reduce my 5 valgus to 3. I use 5 as a standard valgus in most of the patients, unless the patients are very, very short or where does the craftsman go? Huh? Sorry, where? Okay, sorry. Okay. Yeah. Okay, leave it. I think leave it. It's not a craftsman, really. Yeah. So you have to excuse me a little bit. I don't use this instrumentation regularly, so the first time, so I may be asking a few things. Okay, so it looks like we're cutting less, but we're going to cut and go ahead. Okay, and then if necessary, we may cut for more. Okay, we haven't cut anything at all on the lateral condyle. It is expected to cut less on the lateral condyle because of a slight valgus, but here we didn't cut anything at all. So I'm just going to cut 2 mm more. Right. We make a central cut first so that both the planes are the same. Okay. Sir, can you hear us?
Okay, we are able to hear.
Yes. So I make my femoral cut first, followed by the tibial cut, but you can do either way. Nibbler, please. Okay. Is the other camera working or not? Are they fixing? Is it on? Adena, ade anena antunna. Okay, we'll wait. They are trying to fix another camera, so just waiting for a few minutes.
Okay.
Any questions in the meantime, sir? Make sure it doesn't fall.
So even severe valgus knee also, you will take same incision?
Yes. Valgus, varus, obese, thin, severely deformed. In every case, I've done in a 156 kilogram man also. I've always done subvastus for every patient. Okay, I think we'll continue. I'm not sure these guys are able to fix it or not. So we'll continue. Okay, we position at the ankle, the center of the ankle, which is lateral 2/3 and medial 1/3. Okay. You put your fingers on the lateral and medial malleolus. Okay. Okay. Are you able to show? Okay, so it is not exactly facing the leg, so you may see it as if it is slightly to the lateral, but it is right in the center of the ankle. Okay, give me that. And so here it's a lateral compartment that is slightly more worn off. So I'm going to take probably about 9 from the medial compartment, from the best part of the medial compartment, which is not worn off. Okay, and check that. Okay, if I feel that is too much, I'll reduce, because I can always come back later. Okay, so make it 7, please. So I feel it is a little bit too much when I put 9, so I'm reducing it, because I can always come back.
Yes, yes.
Yeah, pens please.
That's excellent demonstration, Sudhir. Though you are, I think you honestly accepted, you haven't done many of Max Medical, but I think
Sir,
doing a great
sir,
job.
Can you repeat, sir? The volume was low, not here.
You're doing excellent demonstration.
Thank you.
Though you said you haven't done much, but we don't make out whether we've done, not done many in the past.
Okay, thank you, sir.
No, the tibial cut,
Yeah,
what you rightly said, I think we only cut what we replace it.
yeah,
So generally it's a 9 millimeters.
yes,
Sometimes you feel 9 millimeters from the medial side would be too much. If
Yeah.
it is the lateral side, because always the lateral plateau is higher than the medial one.
yes,
So as you rightly said, we adjust, take a little less than what
yeah,
is there. Otherwise, sometimes if it is not too
Yeah,
much,
yeah.
I take it from the lateral side, maybe 2 millimeter, 1 millimeter from the lateral side.
yeah, yeah. So in here, the lateral side is also, is not very well exposed, because I'm not able to expose it very well because of the retractors I'm using.
So
But,
what retractors? I think they should have retractors.
Yeah, they have. It's okay. It's fine, sir. There's no
Straight homins should be available.
Yeah. Okay.
So if you want, you can
Yeah, it's
ask
okay.
them
It's
to.
okay. We are there. Okay. So I'm actually cutting probably about 3-4 mm from the medial side.
Yeah. If the cameraman can show the top
Yeah.
of the knee little.
Yeah. So yeah, I think you can see.
Yeah,
the
we
other
can see.
camera, huh?
Yeah, we can see it. Yes. The other
Yeah.
camera, we can see the top. Yes.
Yes. Yes.
That looks good.
So, and also valgus knees always tend to be slightly lax. So I tend to cut less in the valgus knees. You can
Yeah.
always come back and cut more if necessary.
Absolutely.
So one of my retractor is protecting the MCL. Okay, but you should have a good hand control. I'm again a 100% CR surgeon. Okay, I always preserve my PCL. Okay, so I go in the center first, just before the PCL, and then one saw cut to the medial, one saw cut to the lateral.
So you don't cut the tibia on that PCL attachment.
I don't cut the tibia. I don't cut the PCL attachment. Osteotomes, please. 2 osteotome, broader one. But here I am told we only have PS available. Okay, so we're going to use PS today. So then I lift the tibia, whatever cut with the 2 osteotomes, one use as a base so that you can lever using the other osteotome and knife.
Can you just show after you remove it, thickness of the tibia you cut?
Yes. So here I just release few fibers of the PCL. Sometimes it is attached quite more proximally and may get damaged, but usually not. So from which From which camera they can see? Ah. Okay, so maybe you can see the thickness of the
Yeah, we can see.
and the light.
So not much on the lateral side.
Not much.
Yeah.
Not much. Even on the medial side, it's probably about, probably about 3-4 mm on actually.
Yeah.
Very less. Very less. So on the medial side also very less. You can see.
Yeah, we
Okay.
can see.
So we'll just see whether the extension space is enough or not.
Yeah.
Okay. It's probably not enough actually.
Yeah, that's what I was about to say.
Yeah.
Probably you may have to take a bit more.
Yeah.
Otherwise,
Yeah.
you'll have struggle in putting the insert. Yeah.
It's not enough. So I'm going to cut 2 mm more. So it's nearly there. I've been conservative with my cut. So we will just see and cut 2 mm more. That should be enough. Yeah, just checking so that should cut the TV.
Would you like to have a straight omens, Sudhir?
Usually that's what I use, sir. But
Yeah,
it's
they
okay.
should be. It should be there in the.
I
If
don't
you
think
ask
they have.
Lakshmi, I think she'll give you.
Do you have straight omens? Just removing the remnants of the meniscus. So we have cut very little femur, sir. Femur is very little, as you can see. We haven't touched the intercondylar notch, and also the lateral side is very, very little. So
Yeah.
So what we're going to do is I'm going to first revise the femoral cut.
Yeah. So generally, how much you take the femur in a normal knee?
Sir, most of these implants, they take about 8 mm from the good side.
Right. Okay.
The distance.
Because I always use PS.
Okay.
I take 10 minimum, and sometimes flexion deformity take 11. Because
Okay.
as you know, when we take the PCL out, there will be opening up flexion gap 1 to 2 millimeters more. So I tend to take minimum 9, maybe 10, 11, depending upon if we have any flexion deformity.
Okay. Okay. So I usually never take more than what is recommended, which is 8 mm.
Yeah.
Even in
This Merrill Maximi will take 9 millimeters.
even in flexion deformities, the reason being, in fact, I use Jimmer much more often.
Yeah.
If you know, Jimmer has the distal femur cutting block,
Yeah.
has a plate attached for a severe fixed flexion deformities. You remove that plate, you cut to 3 mm more.
Sure.
Uh,
And
but-
this one, femur is 9 millimeters. The size
this-
of the femoral component is 9 millimeters. So you must take 9 millimeters minimum,
Yeah.
like in tibia.
Okay. Yeah. So usually the guide allows you to cut whatever is the size of the
Implant, yes, I
implant.
think so. The
Yeah.
message is because
So-
it varies from company to company. So
yeah. So
it
this
can-
is okay. This is okay. We're able to get the implant well. Okay.
that looks good. Looks good.
So we're going
So
to
you
remove.
don't have to release anything on the lateral side, as you said at the beginning, not
There
much
is
of
there is a very little tightness on the lateral side.
Yeah.
So I may just release some capsule from the tibial attachment.
Yeah.
So in fixed flexion deformity, usually I don't cut right at the beginning, but after osteophytes are released, then if I see that still there's a lot of deformity, then I may go back and do that. Is the one we use for the later? Okay. Is the central one like that? Oh, okay. Okay. Size it, please. Okay. So now that the extension space is okay, we're going to start off with femur preparation. So make sure that the block is sitting firmly on the just cut surface of the tibia. Okay, and the most representative part of the anterior surface of the femur, not necessarily the highest, because many times there's a ridge, so you want a good cut surface there. Okay, so I've kept where I think is the most appropriate part, and it comes to between, close to B. C, close to C. Okay, slightly smaller than C. Okay, right. So, okay. Okay, my colleague tells me it's more close to C. So, because I am a CR surgeon, I'm always used to putting, if it is between two sizes, I use a smaller size, but this is a PS. So we're going to go for C. I guess they only have C implants here, no B. B is there. Okay. Okay. So I put 3-degree external rotation here. So in a valgus knee, you always have to check. Pinful, please. Sorry. Oh, okay. Pins, we leave it. Remove this. So in a valgus knee, you have to check if there is a hypoplasia of the lateral condyle and if there's a wear on the posterior aspect of lateral condyle, which will actually internally rotate your guide. So sometimes if there's a hypoplastic lateral femoral condyle, you may have to increase your external rotation. You may have to make it 5 or 6.
Yeah, that's I think a very valid point, Sudhir, because most of the time the posterior condyles are normal, but in hypoplastic
Yes.
femur,
Yes.
you have to be careful.
So this is the 4-in-1 cutting block to prepare the femur. Again, you can cut in any order, but first the anterior and posterior, and then the chamfers. I usually cut the anterior first, posterior next, come back to posterior chamfer, and then the anterior chamfer again. Need a small blade, I think, for this.
Probably use a small blade, I think, Sudhir.
Need a small blade. Yeah.
Medium blade rather.
Yes. Good. So this is a 5-in-1 because there's a slot for trochlea as well. Hold it.
Yeah, I think it. You're right, it's a 5-in-1.
Yeah. No, I'm just saying the trochlear slot also need to be cut.
Yeah.
Give me a straight arch, please. Straight one, broad one. There we go. Just marking the trochlear notch.
The designer says because of the holes that screws you are taking out and this trochlear notch,
Yeah.
the positioning of the femur is most of the time protected in the sense you tend to put the femur where you want. It doesn't go into flexion or extension.
Okay.
Because your cuts are decided, pre-cuts.
Yeah.
Your screws as well as the notch.
Yeah.
So
And
the
yes,
positioning of the implant is well.
Yeah. And also, I forgot to mention the mediolateral positioning.
Yeah.
Is fixed here because you're putting that lug holes also here.
Yeah, yeah.
Okay, and the notch is already being made for a trochlear notch.
Absolutely.
So you can't shift it medially and laterally anymore.
And in osteoporotic knees, probably what happens when you doing trialing or implanting, you can shift the positioning if you're not being careful.
Yes, yes. Malik, please.
That's a good picture with good clarity. Now both cameras are working, I
Both
think.
cameras are working good. So I just marked where the trochlear notch is, so we removed that. Okay. Rasp, please. You have a rasp. Okay. So the posterior cuts we have cut are actually quite small. That's because obviously we use a slightly bigger size than what was indicated.
Did you go bigger or smaller?
We went bigger, sir, because we were between B and C.
Yeah.
We actually use C.
Right.
Normally, instinctively, I ask for B because I'm a CR surgeon.
Yeah.
But these guys, I'm kind of taking in the guidance of these company guy. They say, okay, give me a periosteum, please. They said we should use a C because it's a PS knee. In PS knee, you should usually, you tend to go for a slightly, if it is nearer to C, you go for C in PS knee because you're releasing the PCL. In CR knee, if it is between two sizes, you go for the smaller size. Okay. So your anterior cut, again, I am not sure they can see it. Anterior cut is
we can see it, yes.
Yeah. Like what they say is like a grand piano sign or a map of Australia, and that is how it looks like here. Okay. So this is for the box cut. Okay. Impact, please. I just put one anyway. Don't know. Yeah, one is enough. One is enough. It's well. Okay. Yeah, protect it, please. I should have put a narrow blade.
Probably last implant. Next we'll start.
Box out, please. Huh? Hit it with a fire or something. Okay, so nibble, please. Knife. Right, so we cut the box, and along with the box, the PCL comes off.
That looks like a reasonably good quality bone, Sudhir.
Yes, the good quality bone. It's a fairly small box.
See, that's the advantage of villagers doing hard work and all on their feet most of the time, so they keep their bones strong.
Yes. So that's one important factor you have to take into account because if the bone is very weak, many times, you tend to damage trials, please. Tend to damage it, and also you may have to use a stem many times. Now, please. Okay, we're going to trial now. I still have a feeling we may be slightly tight because slightly tight because the cuts.
If it's tight, probably can undersize. It's not difficult because it's anterior reference one. You can put a B and reduce the size.
1 to 9.
Seems a little tight. Yeah.
It is slightly tight, but should be okay. It is tight. Okay. It's tight. Right. I think we are going to cut 2 mm more of the tibia, sir, because we did feel we cut quite less. Okay. And it is appears to be tight both in flexion as well as extension.
So you can solve the
Yeah.
problem with cutting the tibia more.
Yes. Yes. Tibia was undercut, and it shows it here.
So for the benefit of the audience, if it is tight in flexion extension, you can cut the tibia, which will increase both gaps. If it is
Yes.
tight in flexion, then you can reduce the size.
Then,
If it is tight is extension, probably you have to cut the distal femur a bit more. Is that right, Sudhir?
yes, sir. If it is the femur, distal femur will only influence the extension.
Yeah.
Will not influence the flexion gap. So if you want both, if you find that both are tight or loose, your problem is in tibia. Okay. So I have to find that. Give me a hole. Yeah. Give me the cutting block. And this one. So I had to find that the pinholes. So I'm just using this as a guide. Usually finds it. Yeah. I'm using this angel swing or a saw blade as a guide to find the plane. Okay. So of my previous cut. So I'm going to just cut 2 mm more. Okay. Yeah. I'll put it won't, it will go through the same hole. So just hold it with finger. Yeah. Okay. Okay. The nibbler, knife, part of the meniscus still left. Okay, trials, please. This is 9. Still a little tight, but I'll just see. Okay, little tight on the lateral side. So I'm going to do some lateral release and then come back. How does this fix? Okay. Remove this, please. Yeah. Okay, okay. Engage, leave. Okay, spike, please. Straight to home and Sundama. Okay, central, please. Okay, mop, please. Mop. Knife. What's it? Okay. So I am just going to first release along the margin with the knife, and then use my periosteum to do some periosteal release on the later. So one of the, of course, criticisms of subvastus approach is you can't see the lateral compartment well. That's not really true. You know, you can see lateral compartment very, very well in all of these, all the way. Not sure if you can see what I'm doing.
We can see you, Sudhir.
Okay.
Or just wanted to, next door, Uday Prakash is getting ready. So once you do trial,
Okay,
we'll go to him and come back to you once you put the implants in.
right.
So you're going to release, then do the trial.
Yeah,
Now,
Yeah.
so shall we move on to the next OT?
please, sir.
Yeah, okay. Can we ask a cameraman to go to next OT to cover Dr. Uday Prakash? Dr. Jairam is there. Can you take them, Jairam? So
I don't know whether this was a posterior or a.
so meanwhile, we will.
Looks like it. Hello, can you hear me?
Yes, we can hear you.
Okay, KJ, we have started. So we just exposed, taking the incision through the skin.
Yeah.
But before we do that, do you want to see the X-ray?
Yes, we want to see you first, your team, and
Okay.
Dr. Uday Prakash is one of the leading hip surgeons. He spent a lot of time in UK. He's the director of Uday Amni Hospitals, my good friend, and he's come all the way to demonstrate your difficult. I think he must be cursing me because I gave him a difficult revision. Yes, Uday, you can briefly show
Okay.
us the X-rays and take
Thank
us
you.
through.
Thank you, KJ. Pleasure to be here. I must say the theaters are very nice, very well kept, very clean. Staff
Thank you.
have been superb, and the patient was ready. And all I had to do was just take an incision. So here we are. We've taken an incision. We've taken an incision through the fascia lata and down to the vastus lateralis. Can you see that?
We have to, yes. Now we can see.
Yeah.
That hip was done by me about 20 years ago.
Okay, so I'll come to the X-ray just now.
Yeah.
But just to the exposure, so
Sure.
it's very important that we raise the fascia lata and give us a good gap in between the medius and the fascia lata, so that we can have a good closure later on.
Yeah. So
And
this is you're doing which approach you're doing, Uday?
I'm doing a posterior.
Posterior, standard posterior approach.
Scissors,
Yeah.
please. Yeah, so we're doing a posterior approach. I'm just elevating the fascia lata from, and this is the gluteus maximus. Yes, you can see. I
Yeah.
can see the gluteus medius underneath that. I'm just cutting some adhesions here, so I can put my Chandli retractor easily.
Yeah, that's important. Otherwise,
Yeah,
the Chandli keeps
Chandli
sliding off. Yes, if you don't
Correct.
have a proper support.
So it's very important that the Chandli is placed in a position which is 90 degrees to your incision. Otherwise, it slips away. And it doesn't need to be really extremely tight. It's just enough to give you a reasonable exposure. I was just telling you boys that respect the soft tissues. It is as much a soft tissue surgery as much as bone surgery, because if the soft tissues are not respected, they will get infected.
Yeah.
So
That's excellent exposure.
Yeah.
We can see
So-
clearly the anatomy.
Let me come to the X-ray. Yeah. I hope you can see it clearly. I don't know whether the audience have a copy of that in their.
Yeah, we can see. We can see from the OT itself.
Okay.
Yes. Yeah.
Um,
Bit zoom in bit more, cameraman.
Can you zoom in onto the left side? And zoom in onto the cup at the top where the ball is.
Yeah. Don't move the camera.
Can you see that?
Yes, we can
Now
see.
there's
clearly.
this is a cemented hip. It was done about 20 years ago by KJ and it has done its job. Now the time has come to change it. So you can see there's a lucency. Actually, the poly has not worn out much. He's a male patient and he's, despite the 20 years, the poly has not worn out. But there's a lucency around the socket. And you can see that there is a little bit of protrusion, a very thin medial wall, but there's good cover.
Yeah.
And this should really come out quite easily with a little bit of help. Now, if you look at the stem, it has sunk. The proximal femur is broken. Can you zoom on to the right X-ray?
Surprisingly, it wasn't painful. I think most of the time, Uday, we think it's maybe combination of a traumatic and maybe loose. If any long-standing prosthesis has a periprosthetic fracture, we should seriously think it could have been a loose prosthesis which has broken. What do you think?
Yeah, I mean, normally these people have some symptoms prior to them breaking their femurs, and this one looks like a low trauma, low impact spiral fracture through the really loose part of the proximal femur.
Yeah.
And the stem is sunk. There is hardly any cortex, as you can see, and on the lateral view, this is displaced. The stem is still within the distal femur, but obviously not weight bearing right now. So I'm expecting a reasonably straightforward removal of stem, but then the proximal femur doesn't have much use because of how thin it is, but we should try and preserve it and put some cables around the stem, around the femur if possible.
Sure.
At the end, very carefully remove the cement without breaking any femur further. So my plan is that we remove the stem and then do a distally fitting Wagner type stem, which Merrill has now. It's called the monomod. I believe it is very similar to using a Wagner stem.
Yeah.
I've not used a monomod before, but I hope we don't have any issues with it.
Yeah.
Okay. So
That's
now,
wonderful. Yeah, I'll just announce one announcement. Dr. Anjaneyulu, Dr. Srinivas Reddy was chairing last session.
Sure.
Thank you very much for your active interaction and your participation coming all the way. Now I would like to invite Dr. Chandrasekhar and Dr. Sudhir from Warangal, Chandrasekhar from Care Hospital. Thank you very much for your
Thank
time.
you, KJ.
Thank you. So they are going to moderate your session, Uday.
So KJ, I just want to ask you one question.
Yeah.
Do you think you did an anterolateral approach or a posterior?
Yes, I did. I kept the posterior intact for you.
Thank you. So I
So
can
it's
see that.
Virgin land, yes.
Yeah, so I can see that there's a good layer of fat covering the external rotators. So I'm just going to use my swab, please, a mop or a swab to just sweep the fat down here. And this is there's a big vessel here, which I'm going to catch early. Artery, please.
And just to let you know, Uday, there are about nearly 800 people in the auditorium.
Oh, gosh.
And we can, I think the
That
technology
should
we
make me
can
nervous.
see, Sudhir
Touch.
next door theater
Yes.
is trialing the knee, the last knee. It took
Okay.
a little while. So
Great.
Yeah.
I saw his subvascular approach.
yeah,
And I must say that, it's a great approach. And we've been doing now for 5 years.
yeah, I think
In
it is.
fact, Sudhir pushed us to get into subvascular and I've not regretted it.
Yeah, I think that's a good approach.
So better to catch the vessels early so that they don't bleed. And there are many around this area. As you can see, the ascending branch of the medial circumflex goes around the front of the quadrators, comes around the back of the trochanter, and you can often see many vessels here.
You know the speakers కింద పెట్టండి. ఇది అది.
Nice. Right. Forceps. Just going to take a little bit of fat pad off here so that I have easy access to the vessels. If I see any, I can catch early. So, थोड़ा सा rotate करना. I don't know whether we'll get much. There's a vessel here, artery.
Hello, Dr. Uday, Dr. Chandrasekhar here.
Hello.
Can you hear us?
Yes, yes.
Yeah. And Dr. Sudhir is along with me as well. We
Yeah,
are moderating your session.
Hello there. I just met him at the entrance.
The theater audio volume has gone down actually. So maybe if somebody can adjust
Can
that.
you hear me? Hello?
Yeah, it's better now. Yeah.
Okay, I'll try to be louder. So we're trying to catch these small vessels at the back. They tend to bleed a lot. So if we can catch them now before we go in, it would be nice. Catch, please. Okay. So I'm going to go underneath the medius. We've got a Cobra retractor, large one. Thank you. Yeah, that should be. Yeah, we should be.
Looks the tissues
Might
look
be a little
pristine, I think, isn't it?
Yeah, so
That's
the tissues at the back are nice because it was an anterior approach before.
Yeah.
Hard hinge approach. So now I'm underneath the medius. And I can see the minimus underneath that.
Were there any inflammatory markers done prior to this?
Yes. I believe the ESR and CRP are normal.
Okay.
And that's a good question because I think this is what the juniors should know, that we should always suspect infection. The skin was clean. There were no sinuses. Yeah. And there was no swelling and there's no fluid that has come out since we've gone in. Not into the joint yet, but we are slowly making our way. I can see the piriformis here. So I'll catch that piriformis with a stitch.
Uday, can we take couple of minutes away from you?
Yeah, sure.
Yeah. Shall we go to Sudhir Reddy? He's cementing. So can we have voice back to Sudhir Reddy?
Just wanted to show them.
Sudhir, we can hear you.
Yes, sir, we can hear you. So I just about implanted, then took it out. Give me some more cement. Give me a little bit cement. Yeah. Can you see us?
Very much. Chandrasekhar, back.
Okay, sir. We're implanting this tibia first.
Dr. Sudhir, Dr. Chandrasekhar here.
Yeah, hi.
Hi. So was it a 9 mm poly which you had trialed, is it?
Yes.
Okay.
Yes, it was a 9 mm poly. It was a 9 mm poly. I did a bit of lateral capsular release.
Okay.
And then okay. So the tibia is implanted. I'm going to laying back, please.
Was the tightness more in extension or flexion when you trialed? The lateral tightness.
It was actually both.
Okay.
Both. So there was actually some bone from tibia also not cut completely on the lateral side.
Yeah.
So when I was looking at the lateral side, there was like some bone left. We removed that and we released it a little bit. Okay,
Sure.
and then it was okay.
For the sake of juniors, it was a valgus knee to start with. So if you notice that if there is any tightness in extension, you tend to release the IT band. So if it is tight in flexion, then you have to address the more posterior structures like the popliteus.
McDonald's. Give me a knife, a scoop. Okay. So you need to make sure you don't leave any cement at all in the intercondylar notch, because in PS, it's not tolerant to any cement in the box at all.
Sudhir, initially I was reluctant to use this knee,
Yes.
but using for the last how many years? Maybe 14, 15 years.
Oh, 14, 15?
Yes, I'm quite happy.
Okay.
And the results are good, equally good.
Hold this.
And as you
Yeah.
keep saying,
Yeah.
it is the technique more important than the implant.
Sir? Yes.
It is the technique that is more important than implant. And it's a very good design of is a copy of a Depio, as you can see.
Yeah, I think it's a copy of Depew as well as some features of Jimmer as well.
Yes, yes, both of them.
Yeah, I think we need to just.
IB.
Okay. Lift it just to make sure there's nothing. Give me mosquito. Yeah, it has features of both. Gauze, please. It has features of both Depew as well as some Jimmer features. So like one of the features I like in next gen is the trochlear notch.
Yeah.
So I feel the trochlear notch will allow the trochlear groove to be deeper.
Yeah.
So I think that is the reason why I personally feel the anterior knee pain is less.
Yeah. And the notch is not too big, not too much. Unlike Depio, we don't cut too much of a bone in the notch.
Yeah. That is another important feature. Okay, so this is only mallet is the only way to do this. Okay. I hit it. Just okay. Yeah, so I don't hammer the femur all the way completely. So I let a millimeter or two of cement mantle to be left, and then once I place the tibial insert, I extend and let it compress and squeeze out the cement as much as it wants.
Yeah. But you have to be careful. So there for the beginners, especially in osteoporotic knee.
Yes.
If they don't go too far, then probably
yes
might be in trouble.
Yes.
I think that looks excellent.
Right, sir.
Can you just show us the range of movements?
Yeah.
Probably, yes, just full extension.
Okay, so you can see how the patella has fallen back into place and tracks very well.
Yeah.
Never ever had to do lateral release the patella in my life.
Yeah, that's true.
Yeah. Okay.
That's a big advantage with subvastus.
Yeah. And if you want to prepare the patella, you can always avert like this and prepare. You can do even a patella resurfacing after implantation also. Like this. Okay.
That's excellent demonstration.
Right, sir. Now
just for information, there are more than 800 audience watching your surgery.
Oh, wonderful, sir. Wonderful.
Including
so I'll join you. We're just going to wash and switch.
Thank you very much. Big applause to Dr. Sudhir Reddy.
Thank you, sir.
We will move on to Uday Prakash.
Right.
Chandrasekhar.
I'll join you.
Yeah. Dr. Uday, we are back with you now.
Hello.
Hello. Dr. Sudhir has finished his case. So we are back to the hip now.
Can you hear me?
Yes, loud and clear.
Right. So we have exposed the socket. We're just keeping it covered till we expose the femur a little bit now.
Yeah.
So we're going to go subvastus here as well, obviously subvastus lateralis.
Okay.
So we just
You had to release the Gmax insertion, is it?
Yes,
Yeah,
yes. We have not done that yet, but
Okay.
we may not have to do it. We'll just see. We're busy trying to catch blood vessels. So I'm just elevating the vastus lateralis of the femur here. Can you see where we are? Can you sort of figure out what's going on? So that's the vastus lateralis. They've elevated that. Whoa. Periosteum. Spike. So there's a lot of fibrous tissue which is quite inflamed and bloody at the moment. So it will soon dry up a little bit. So I'm just trying to see whether there's any easy access to the stem. I can feel the fracture. Up again. Oh, I think there's just I can see the fracture here. So yeah.
Is that a second fracture? The one there was one proximal, I think, isn't it?
Yeah, this is the proximal. This is the GT here.
Yeah.
It's
Okay.
the proximal femur. This is the first butterfly fragment here. I can see this one. So we
Okay.
just need to mobilize that a little bit.
Sometimes with the cemented hips, the fracture is a blessing in disguise.
Correct.
It will help you to extract the implant.
Correct. Give me an osteotome. Yeah. Just, I think this is the fracture line. I'm just going to open it up a little bit.
Yeah.
Yeah. Fibrous tissue is there. I can feel the stem. Yeah. You can see it's elevating. Stem is completely loose inside. Sometimes you've got to extend the fracture a little bit as a
ETO.
Yeah. So I think I'm going to do that. Give me a saw, please. Saw. So that's the fracture. Can you see the
Yes, we can see that.
forceps? So that's the fracture. This is the lesser trochanter. I'm going to extend the fracture here so that I can just flip the whole fragment anteriorly, and that'll give me a good access to the acetabulum as well as the femur.
Are you planning for any prophylactic wires distally?
Yeah, we'll have to wire everything up later on.
Yeah.
Mop. So it's just that the inflamed tissues can bleed a little bit. You can't help it, but soon things settle down. Saw blade. Okay, we're just waiting for the saw. Until then, maybe you can give me maybe the osteotome might work. Is it open? And we'll just expose it a little bit more. Perhaps we might not need to do that. Let's see.
Yeah.
Diathermy. Let's see if we can get a better exposure here. So I have to. We got a hook or something? Yeah. I'm just releasing a little bit of the psoas here. You can see this is the head of the
Yeah, we can see that.
yeah, we can see
Yes.
that.
Yeah.
So actually I'm not going to get a, I think it's better if I elevate this fragment and leave this bottom fragment posteriorly, and then so I will use the saw.
Yeah.
Reduce करके? No, I think once we so I'm just extending this fracture here.
Yes.
Osteo.
For the sake of juniors, ETO is a very useful method for extracting, especially cemented implants in a revision situation, because otherwise you'll end up doing an uncontrolled, damage to the fracture femur. This is more of a controlled, exposure of the intramedullary canal.
No, use the suction. Otherwise, you'll fill up the mops very quickly. Little wash, please. So you can see there are free cement fragments.
Yes.
Sorry, what's your name? Karthik is removing them. They're just coming out. And actually, the stem will also come out. We're just waiting for saline now. So this has been my experience with cemented hips. Many of the stems that have got a shoulder like this, and the way it's been designed is not really a proper cemented implant. It's got serrations, and it's, we know over time that these things fail, and the kind of stems that have really stood the test of time are these double tapered, highly polished Exeter type stems. So I would highly encourage everybody to stop using the vac machine finish stems. So they're not smooth, and the collar is just like it gives you an initial stability, but later on much of it just hinges on the shoulder, and the hip comes loose.
Yes.
Of course, cementation is the key with anything. Nibbler, please. Cementation is the key, and you must do at least a second generation or a third generation pressurized cementing technique. Otherwise, these things will come loose. Everybody must have a cement gun. There's no excuse for not having the cement gun because they're quite cheap. And retrograde cement filling is the key. We should not try and push cement from the top. It does not work. Please do a good service to our patients. They don't deserve the first generation cementation in this day and age.
True. I mean, the success rate of cemented depends on the quality of cementing.
100%. You can give a Ferrari to a Hyderabadi street kid. He cannot blame the car, right, for a crash. No saline? Please give me saline. So we'll just give it a little wash so that everybody can see what's going on.
We missed that, but is there a distal cement plug as well for this?
I'm not particularly bothered. It's going to come out anyway.
Yeah.
So you can see this is the stem, and I'm just going to have to just pick it out like this.
Yeah.
So it's in my hands now. It's a it's a modular stem. I mean, the intention of the designer was to give it stability in rotation, and the taper helps with the wedging and the hoop stresses will, increase the fixation as the patient weight bears. But in my experience, these things don't work. So I think it's better to use a highly polished stem.
Yeah.
1 minute. Nibla. So we'll go back to the acetabulum. Once we remove this, the obvious cement bits, you can see the whole.
Yeah.
So Dr. KJ did a nice cementation from retrograde up. There's a lot of cement, but over time these things do fail. Nothing to do with the surgeon. So there's a lot of cement here distally to proximal. Okay, so we've removed most of it. It just came out. And there's a lot of membrane now, but actually, ideally, you should be sending membrane for histopathology and microbiology. This doesn't look infected to me. This is a classic aseptic loosening. There's no clinical or even intraoperative evidence of infection, but you can never be sure with these things. So it's always better to send samples, a couple of femoral samples, a couple of acetabular samples. We've already sent some fluid. So now I will expose the cup. Actually, might need a self-retainer, a good self-retainer. So we've got the medius here and it's hinging nicely.
Yeah.
The front, I need to expose that a little bit more now. So never be afraid of doing an osteotomy, because that's what saves you ultimately. A knife, please. Forceps. A little bit of membrane and capsule that I have to, mostly fibrous tissue really. Try and keep the capsule. Bit of cement here. Something to cockers or something. Yeah, thanks. Now just expose the knife, please. Expose the, I kept it here. Thank you. Expose the cup a little bit more. There's a lot of cement here. Cement, bone. So you must try and get your new cup down to the teardrop. I mean, it's not always possible, but your aim is to figure out where the teardrop is. So I'm just exposing, doing a kind of an episiotomy here, opening up the inferior capsule, making sure that I have enough exposure before I safely remove the socket. So be patient, don't be in a rush. Do bit by bit. So exposure is the key. If you don't expose well, you'll end up with a bad result. So exposure is the key. And this is the first thing you must learn. Everything will fall into place. Once you've got a good exposure, you will know exactly what to do. So I'm sorry, I'm being very basic here, panel, but I think there are a lot of juniors here that need to understand.
That's the whole idea of this course.
Yeah. What's that? No, you don't suck clot. If you suck clot, then it will bleed more. Leave the clot as it is.
Does the cup appear well fixed?
Pardon?
Is the cup well fixed?
No, I'm exposing it so that I will get an idea how well fixed it is. But I have to change it anyway. No, I can feel it's loose, it's moving.
Yeah.
Even with the blade, it's moving. थोड़ा सा periosteal छोटा सा ही ऐसा nibbler. So you can see there's a lot of soft tissue coming out. So nature is wonderful. It tries to stabilize whatever is moving inside the body. A lot of fibrous tissue, which is a good response. That's what kept him going for years. So all this scar fibrous tissue, I'm trying to remove to expose the acetabulum. Yeah. So just be a little patient. It does take a little time to get a safe exposure. Not in a big rush. Although I do have a flight to catch, but that's at 7 o'clock. Yeah. But I promise you I won't take that long.
Certainly not.
So all these loose bits are coming out. So I think this is all loose tissue, which should come out, should come down to bleeding tissue, which is healthy. This could be a bit of response to polywear, not a membrane. So there is I can feel the anterior wall. I think it's sunk in a little bit. Suction here. So if I can get a Homans, I think I should curved one. Yeah. So I'm going to put this. No, I'll make a little incision first. Knife, please. In the anterior capsule. So I'm going to make an incision round about say 10 to 11 o'clock.
Yes.
And then I'll put my Homans or a Cobra there on a stable base. Okay, so that will give us a much better exposure.
Yeah.
Can you see everybody?
Yeah, we can see that.
So now the acetabulum is much better exposed. There's a little bit of a bone here.
Yeah, in
Nibbler?
between the Homans and the cup.
Yeah.
Yeah.
Nibbler, please. See if I can just mostly hard fibrous tissue. Let's see, guys. Knife. Not, not to ये दे दो. Okay. So watch, please. So ideally, you need a little curved osteotome. Have you got revision osteotomes? Curved ones, the acetabular? No.
If the cup were to be well fixed, any tips and tricks, sir?
It's not well fixed, it's loose.
No, if it were to be fixed, I mean, in a
Yeah, there are many methods of removing it. You've got the Zimmer explant we can use, or you can just ream the socket out.
Yeah.
So this is quite loose. There's a big gap, but it still won't come out easily because of the keyholes that Dr. KJ would have made. So these keyholes will prevent from the thing easily coming out. You've got to break that cement.
One more technique is putting a screw inside, that 3.5 screw.
Yes, good idea.
Drill hole and
Yeah, I think it'll come out. I may not have to do that.
not in this case, but I was hypothetical situation where if it was to be fixed.
Generally, I find this not necessary. I'm just getting a good sort of, it's loose. So Bristow, please, let's see if we can come out like this. No, don't lever on the bone. You'll break the bone. So these are little things that the junior should understand. They should try and not lever on the bone. Little bit is fine. Yeah. So you can see that the cement, lots of keyholes.
Yeah.
And Dr. KJ did exactly what is there in the book. But these things do fail over time, and everything is there. You've got a nice cement mantle over there. So
Yeah, that's an excellent demonstration. That's the key, removing the implants with minimal bone loss,
yes,
as minimal bone loss as possible.
correct. We should.
Yeah.
I mean, there's a little bit of bone loss bound to be there. I need to get a stable sort of base onto which I can put my Cobra retractor.
Yeah.
So it could be more like 11 o'clock, more than 10. So there. So, yeah. And I can feel the anterior wall is very, very loose. There's hardly any anterior wall.
Yeah.
A little bit of anterior superior wall. There is a good, reasonable amount of posterior wall. So I think we should get an uncemented cup, hopefully. Yeah.
Is there any bone graft there available there in case, just in case? Because there was a little bit of
Yeah.
protrusive as well.
I don't know whether we have bone graft here, but no. Or maybe Bristol or something. Yeah, something to remove the membrane. We can even ream it out. Nice to do it in a controlled fashion. There's a big membrane. You can send that for histo and micro. Suction. So anterior wall is, I don't know whether you can see, but very loose. There's just a membrane here.
Yeah.
So there's good wall here, but there's no wall. Yeah, there's very little wall anteriorly. So we won't get, I think, but what gives you stability is the pubic, the access to the pubic bone from here, superior pubic ramus. If that is good, then you're okay. Cob jaisa kuch hai? No. Something, yeah, we can use a scoop. Let's see. I can possibly just ream it out, but it's nice to take it as a big layer. Yeah. Yeah, receive. More mops. So posterior wall is there, rim is there.
Yeah.
Superior wall is there. So I think we should be okay. We'll start with a 50 Rima. 50 or 54, whatever, 50 maybe. Yeah, so I'm just very gently reaming the soft tissues, not pushing anywhere, just to get an idea as to how much bone we have. Now, Nibla. So I hope we get a reasonably stable base for a cup.
Yeah.
Cementing a cup in this situation is not a good idea. And
correct.
So we'll try and get a nice uncemented cup if possible.
I think column is intact, isn't it?
Yeah, column is intact. Medial wall is very thin.
Yes.
So we need to get a nice peripheral fit. And there's no probably a jumbo type cup.
Yes. What's the maximum cup they have got?
60, no? What is the biggest? 60.
60. Okay.
They should be prepared for more. Ideally, tantalum wedges and augments and all that should be available.
Yeah.
Let's see how much. Right, give me a 54.
Is that a multi-hole cup? Which
Yeah, I think they have a multi-hole, no? They don't. Yeah. Just 3 holes, huh? Nice to have inferior holes also.
yes.
ये चल जाता. I think we knife. ये छोड़ देना यहाँ पे. There's a loose bone there. Okay. 56. It's going to be a slightly high cup, I think. 58. Sixty is the last. No. This is 58. Give me a 60 trial. Knife. Pura. Yeah. Get a little bit of fit. Action. Pull. So I'm going to have to leave it here like this, slightly lateralizes, holding on its own. I'm getting
Yes.
a little bit of a fit.
Yeah.
So little I'm pulling out is not coming out. So I think we'll go for a 60 cup. It's not going to be great, but we'll try and get as many screws as possible into it.
Yeah.
Open, yeah. Yeah, open. So we'll have to make sure that this patient doesn't wait there for at least 2 months or 3 months, so allow integration.
I think bone graft would have been
Nice, yeah.
would have been very nice in this case.
You don't have any dried bone? Bombay bone? Nothing. Yeah. Hmm? Bone? Bone wax? No. Bone substitute? I think we get a peripheral fit, and there's enough superior bone here, which is good. Then bottom bone here is good, ischial, over ischium. And then here over. So we should get a 3-point fixation, hopefully. Huh? No wash. You right? Nibla?
Is the medial wall still intact?
No.
It's not.
So that's why you have to believe in your peripheral fit and in integration before you start loading him. So there's no anterior rim, this posterior wall is there. And posterior superior is there, superior is there. So I think we should get some fit here. Let's yeah. I'm going to leave it there and get a couple of screws.
That seems to be reasonable,
Yeah.
catch, I think.
Yeah. I can move the pelvis.
Yeah.
Yeah.
Because with the Merrill design,
Yeah.
the actual cup is much thicker than your trial.
Yeah. 30 there. Yeah.
And it's impossible to get a press fit with these implants.
Correct. 30, 35 bhi de sakte. 35 though. A couple of good screws should do it. I'll get an initial fix. I think primary stability is very important.
Yeah.
And then osseointegration over the next few weeks will hopefully do the trick. I'm getting a reasonable hold.
Yeah. Long step. At least 4 centimeters bypass avali. Ekkadaithe fracture undo.
Good bone at the top.
Yeah.
Yeah, and a good initial fix. So I'm happy with that. I'm going to try and get another one if possible. कौन सा डालेंगे यहाँ पे? I think this नहीं वो देना depth gauge. I think it might be into no it might be good actually. No अच्छा 35, the biggest one. 40 also will do, yeah. Right into the just I think towards the notch, so it's going into that dome. So initial good host bone contact and integration, that's the key. If the guy doesn't weight bear early, then I think you should get away with it. Depth gauge, no? Yeah,
Okay.
there's good bone all the way.
Yeah.
Yeah.
Dr. Uday, a small request from the auditorium here.
Yeah.
If you think there is some time in between, maybe we can do some case presentation.
Case presentation from my side.
No. From here.
Yeah.
Just I mean your presentation will be shown up on the screen.
Yeah.
In box.
Yes.
But
Carry on,
just to
yeah.
save some time,
Please do, please
we
do.
thought
Yeah.
we'll go ahead with a couple of case presentations.
Yeah, just to say, even this
Yeah.
crew is very good.
Sure, thank you.
Okay, carry on. We'll see you later.
Yeah, sure. So you're still live. We'll be seeing on in the,
Okay.
in the corner.
I will try and not swear. इसमें भी डाल देंगे ला screw. As many as possible, really. They should have had a multi-hole cup. मालूम revision है, लेकिन मैं भी बोल मैं
Maybe the theater audio can be muted for now. This for the technical team.
I would like to invite Dr. KJ Reddy sir to felicitate Sudhir sir for doing an excellent live surgery in the morning. Now I would like to invite Srinivas sir for coming on stage. For thank you for moderating the session. Please join Anjaneyal sir as well. I would like to invite Chandrasekhar sir and Sudhir sir also to join us for the momentum. Would like to invite Jagan Mohan sir also for now Jagan Mohan sir will present interesting cases also. So I would like to invite Anjaneyal sir and Srinivas sir to join the panel for the case discussion.
Good morning, sir. Thank you for giving this opportunity. Congratulate Dr. KJ Reddy, sir, for conducting this live workshops. Live workshops will help you to learn more, both as a faculty and delegates. We learned already a few tips and tricks. In the gap, we will show some interesting cases for discussion sake. This brief about myself, and I got 165 male with a bilateral knee osteoarthritis, limitation of activity of daily living, range of motion is around 5 to 120 degrees of range of motion. Past medical is only hypertension and well-controlled diabetes. These are the X-rays, which are the weight-bearing X-rays, AP and lateral view. Shows left is more severe than the right, severe varus knee with some medial tibial condyle lysis is there, with the subluxation of the tibia. So this is the thing, as Chandu, what you do, Chandrasekhar, Dr. Chandrasekhar, this is a severe varus deformity. You prefer what type of implants, sir? You do a CR or PS or stemmed implants or hinged implants or anything?
I'm normally a CR guy.
Yeah.
But in this case, since the deformity is so significant,
Yeah.
I mean, we don't have the weight-bearing views,
Yeah.
full-length views.
Yeah.
But
this is a weight-bearing view, but we don't have a scanogram.
yeah.
We don't have scanogram, but
So-
this was the weight-bearing views, severe varus deformity.
In these cases, I would go for a more constraint
Constrained.
rather than relying only on a CR knee.
Oh,
Because we have to address the bone defect. Apart from that, balancing these knees is difficult.
okay.
And most of the time, the PCL will be quite attenuated in these cases.
So you
unless
go
you
for a
release
PS with a,
PS would be a preferable choice.
with a stemmed tibia.
With stem tibia, yeah.
Stem tibia.
If the defect is more than 1/3 of the condyle,
Yes, sir.
Yes, Mohan, Jagan Mohan,
Yes, sir.
is there any role of trabecular augments?
Limited insurance. This surgery has cost huge amount, so he wants to wait some more time.
Thank you,
The
sir.
cost constraint, sir.
Thank you.
In this case, soft tissue is a problem rather than the bony defect.
Yes, yes,
So you have bypassed that with a stem anyway, the
Yes,
defect part,
yes,
and the soft tissue laxity has been taken care of by your hinge.
yes.
So there's no need for any reconstruction options for the bone.
No,
I mean,
no,
like
no.
sleeves or
What he
anything.
says, sir, if your proximal tibia has gone completely, this tibial base plate and stem is what you call wind viper effect may get it. So to get it proximal fixation, we may use the cones and sleeves to augment the tibial base.
We're going back to theater, sir. Yeah. Yeah. Sure.
Thank you, Jagan Mohan sir, for an excellent case demonstration. I think we'll switch over to Dr. Pradeep sir's case now. Dr. Jairam, can you hear us from the theater? Dr. Pradeep,
Uday,
we'll go back. We'll just.
we're going to Dr. Uday's case or?
Okay.
Yeah.
Hello?
Hello?
Can someone from the theater respond to us?
Yeah,
please?
hello. Hello. Hello, hello. 1, 2, 3, check.
Hello?
Hi, Dr. Chandrasekhar.
Pradeep, hi.
Yeah, hi.
Hi.
You can hear me now?
Yes, very loud.
Yeah, I think now we are yet to put on the tourniquet, the switch on the tourniquet.
Yeah.
In the meanwhile, why don't you see Dr. Uday's thing, and once I expose, we can come back.
Sure. So you'll be doing a medial parapatellar approach.
Yes, that's right.
Fine. Yeah.
So over to Dr. Uday sir's theater now.
Yeah.
Can you make it the big screen from the Dr. Uday Prakash sir's case?
Start చేసేద్దాం.
Can we switch over to the other theater, please?
అటు వెళ్ళిపో, అక్కడ ఉంది. పక్కనంటే పక్క. So which is the 265 here? Normal is how long?
Yeah. Dr. Uday, you're back on the screen now in the
Okay.
auditorium. Can you
No,
hear us?
But how long is the normal? 190. Okay. Okay. Yeah, we are back on. Can you hear me?
Yeah. Dr. Uday, you're
Yeah.
live now.
Okay. So we started reaming the femur.
Sure.
This is 12, but where is 265? 190? 225? Yeah. Okay. So there's a lot of bone destruction, almost, let's measure it. Have you got a ruler? Scale, yeah. So I think we need to go for the longest stem.
Yes.
Because much of the proximal femur is gone. It's very patulous, even at the tip of the. You can see at the tip of the stem.
Yeah.
Where it's loose, it's very patulous.
So we need at least 4 centimeters of scratch fit.
Yeah, we need at least 4 centimeters. Almost I can see 18 centimeters are completely patulous. So we need to go a little bit beyond that. So 225 we can get away, but I think let's see.
Have you got Siam there?
Yeah, we'll use that. We'll use that at the time of trialing. So 225 is the tip of the trochanter, right? Red is yellow and green, right? But that 225 is here till the tip. Okay. So
I think let's have a curate.
What size reamer was that?
That was 12.
12. Okay.
Remember, they only have to 17. I think we might get away with it.
Is that the thickest they've got? 17?
Yeah.
Okay.
But like the cup, hopefully we'll get away with it.
Yeah.
And just remove, there's a lot of membrane that I've been, curating out. It's important that we get a good raw bone that will encourage bony healing. So we had to use a drill to go through the plug.
Yeah. I personally found it quite difficult to remove these distal plugs sometimes.
Yeah. So what I do is I go through a 6.5 millimeter drill, and then we put a reverse curate. It's a revision instrument. If you have revision instruments, that can help.
Sure.
So this is 265, no? Okay, next. Let's see if I can get away with a 225.
Ready? Yeah?
I'm sorry.
I'm saying we might be able to get away with a 225 stem, which is a 225 millimeters long. Curate? Is it on drill or ream? No, ream. It's always be on ream. Easily it's going, no? To the tip is here. Yeah, 15. Otherwise, we'll go for a 265 smaller one. Is 265 straight or board? Straight. Okay. So this is 220. Yeah, but where is the? Does that come up a little bit, or is the base is here? I don't know. Only with a trial we'll know. I think we can trial a next one. I think good context. Distally. My suspicion is that because it's slightly superiorized, you might get away with a. Give me a 216, 225. Wash. Thank you. So we'll do a trial with a 16, 225. Just to get an idea of the length and whether we need to go for a 225 length or a 265 length. Curate. Small one. So there's reasonable bone distally. Hopefully we should get a scratch fit. So I use the tibia as my landmark to get the anteversion. I think this is going to be,
Low.
Yeah, it's very low. So 14, no?
Give me a 17, yeah. If the 17-25 is too small, then we'll have to
Yeah.
go for a longer one.
Are you getting a good fit with 17?
No, I tried a 16,
Yeah,
but I'll try 17 now
okay.
because it's sinking a lot. So it'll be a very unstable reduction. So I'm trialing a 17 now. So 17 looks a bit better.
Yeah.
It's going quite a lot. So I don't think 17 is a good idea either. Let's just do a trial and see where we are.
Maybe a good idea to get a C-arm now, just to check
Yeah.
where we are now.
Sure. Standard. No, standard. Standard 36 head, we'll try. Yeah. Yeah. पीछे करो उसको. अच्छा. Okay. I think it's not bad, but it's. देखो. Huh? Where's the? अरे. Where? अच्छा. ठीक है. Huh? Oh, shortly था. So it's it was quite an easy reduction.
Yeah.
You don't pull. So it's coming out quite easily. Oh. No. I think we can do a plus. Biggest plus. 7 or 7.5 or something. Okay, we'll try plus 7. Yeah. Pull a little bit. Yeah. We can do a C-arm shot. Wash. Wash. I think if you see. This is the fractured area, and this is the fractured fragment here. So it needs to go down a little bit. Have you got a valsalum or something? I think यहीं पे है वो. Just reduction. Have you got a valsalum? Valsalum, yeah, reduction. Yeah, so this. So unfortunately, what happened is that the other leg is hidden and is well flexed. And it's difficult to get an idea of, it looks okay here.
Yeah.
It looks okay here in length, but I think it is still very short. Maybe at least 2 centimeters short. But we'll get a C-arm to see if you are in the center of the shaft, if there's anything else going on. Okay, so yeah, table a little up, huh? Up, table up.
Yeah.
You can we'll do a lateral.
Dr. Uday,
First-
I think we'll have to carry on with the other case in
Yeah.
the Dr. Pradeep's TKR.
Yeah, we'll come back.
So we'll be switching over to the other theater.
Yeah.
Thank you, Sudhir sir, Anjaneyar sir, and Srinivas sir for joining the discussion. I think we'll move on with the next case with Dr. Pradeep sir. Over to Dr. Pradeep sir's theater now. I think we'd like to invite Dr. Ramesh sir and Jagan Mohan sir onto the stage to moderate the session.
Hello? Hello? Am I audible? The auditorium?
We can hear you, sir. Please.
You can hear me?
Yeah, we can
Yeah.
hear you well. We are giving it to Jagan Mohan sir and Ramesh sir for the.
So we just
Moderation.
opened the skin and the subcute. Now, this is, I mean, before you want to see this, can you just show the X-ray? It's a varus knee, pretty much straightforward. It's got about pre-anesthesia, the deformity was about 10 degrees of fixed flexion deformity, and varus about 10 degrees, partially correctable. Yeah, and we are operating on the left leg. Okay, show me now.
Hi, Pradeep. This is Dr. Jagan Mohan Reddy and Dr. Ramesh sir is here.
Hello, sir.
Hi. So you exposed the knee and you are doing medial parapatellar approach. I
Yes,
think?
medial parapatellar approach. Before I cut open, I do the open the joint. I mark my retinaculum here with 2 cautery marks, if you can see, and that is to only have a anatomical closure after the surgery when we close.
Okay.
We can use methylene blue and stuff like that also, but then
Yes. So you are cutting the retinaculum medial patellar with a diathermy, not with a knife.
no, not with a knife. I
Okay.
prefer diathermy.
What is the additional advantage, sir?
It's just a personal choice.
Okay. So it may control the bleeding, anything,
Uh,
especially in the medial side.
yeah.
If you release the posteromedial, if you use the cautery, especially at the capsular level, it may
Yeah.
cauterize the vessels also, the less chance
Yes,
of post-op hematoma.
Yeah, could be that could be an added benefit,
Yeah.
but then I don't see it documented anywhere.
You can start one RCT, randomized control trial on that.
Yeah, once I do the arthrotomy, just clearing the lateral plique of the patella. Forceps.
Hello, Dr. Pradeep.
Yes.
Yeah, did you check that deformity 10 degrees varus and
Yes.
flexion deformity was correctable under anesthesia or is a fix?
After anesthesia, the FFD got corrected completely, and the varus deformity also could be corrected completely. But without anesthesia, it wasn't.
Yeah, that
correct.
under anesthesia it was correctable.
Yeah.
Okay.
You can either invert or keep it inverted. But if it is any difficulty, I don't really force it to invert the patella once we open it. And as Dr. Sudhir rightly said, I don't take out the complete fat pad, but whatever is going to come in my way of exposure and implantation, I would like to take it out. And the plan is to go ahead with the PS knee.
Dr. Pradeep,
Yes.
if you doesn't take up the total fat pad, do you feel any difficulty in reaching the posterolateral component?
Sorry?
To exercise the meniscus.
Sorry?
If you doesn't remove the total fat pad,
Yeah.
do you find any difficulty in reaching the posterolateral
Yes,
compartment?
yes. Definitely, that will keep obstructing, and then it will hinder the lateral meniscus excision completely.
Then how do you overcome that?
By exactly taking out, I take out the medial meniscus, and when I come to the lateral meniscus, I'll show you what I do.
Sure, sure.
Sir,
And
there
here
are,
we have to be careful in going too medial because there's MCL attached, very close proximity to the medial meniscus. And
Sir,
now I have taken out the fat pad here, as you see. Now I use a small Homans. Sister, one small Homans. Yeah.
Dr. Pradeep, I think there are three schools of thought. One is don't touch the pad, or
Yeah.
subtotal fat removal, or total fat removal.
Yeah. I'm not surprised. It's only
Yeah.
3. I thought it will be even more.
Yes,
So-
but they said in the group where you remove the complete fat, there is a retropatellar fibrosis is more common. Patella, what you call low level of patella may occur.
Yeah. So
Patella
here
maha,
I'm coming
patella
here with the, as I said, how I take out the lateral meniscus is first I take out the anterior horn, the anterior root, sorry, and now this is free, and till the bone, till the rim, and now I again take a cockers or a nibbler to hold it tight.
So there is a one beautiful instrument is available for especially for meniscus, sir.
Yeah.
Whatever good cocker you use, it will slip off.
Yes, exactly.
There is one instrument called mother-in-law.
Oh, really?
Yeah, it is like a claw with a crocodile claw.
Okay.
If you put it, it will hold it nicely. It won't come off.
Fine. Here important part is the genicular artery is very close, so we better use only the coagulation part, so that, and most of the time you will be able to see, but I'm not sure on this camera you will be able to see.
Yeah, we are able to see.
So here on the blindly also you can just cauterize it on that part where the genicular is there and prone to bleeding once the tourniquet is off.
Sir, Dr. Pradeep, sir, sorry to interfere.
Yeah.
This can be done once you cut the tibia. You will get a lot of room is there, easy to take off meniscus.
As a medicine goes, multiple ways to
Yes, correct, sir.
treat a thing.
What you are telling is absolutely correct. 2 + 2 is 4 in mathematics.
Exactly.
But in medicine, 2 + 2 is not 4.
Exactly. Sometimes it really gets when you are used to a particular style and then somebody else is doing a different style, you will feel like you should be telling the style you are used to, which is very.
Can you rotate the camera bit, sir? It's a little bit oblique image.
Yeah. Is it okay now?
No, other way.
Which camera you said you want?
Primary camera. Yeah, this is better.
This is better?
Yes.
This is better now?
Yeah, otherwise audience will get giddiness, sir.
So, okay,
And,
now.
maybe
Homans.
chance of epilepsy also.
So one homans is on the left, the medial, and one on the lateral part.
Yes.
And here placement of this homans on the lateral part is to be put mainly on the quadriceps side, not on the patellar tendon side, because the leeway you get on the quadriceps side is much more than the tendon side. Then tendon is more likely to get injured if there is any inadvertent pulling of the retractor or the homans. This is a PCL I'm extracting, and there's hardly any ACL left.
Sir, camera is coming from the top, sir. It's possible to come from the bottom.
Yeah,
Same thing. If you show from the
नीचे
bottom
करो।
foot end,
उसको नीचे कर लो पूरा।
caudal end.
हाँ, नीचे करके, अरे भाई, कैमरा को नीचे कर लो, कैमरा को नीचे करो। हाँ, वो एंगल और नीचे और नीचे और नीचे और कंप्लीट। अभी इसको इधर घुमाओ। ये मेन कैमरा नहीं होना चाहिए, ये मेन कैमरा। हाँ, is this okay now? Hello? Hello? Hello?
Yes, sir. Yes, audible.
Yeah. See, now I'm just taking out the cruciates. There's hardly any PCL left, and there's no ACL at all. Yeah. Now you can see almost the tibia is almost subluxated. Now I want to just dislocate the tibia in the front. I do the tibia first. Grip it nicely. And this way. Yeah. Thank you. Here, in case you are having any difficulty, you can always, at this stage, you can take out the posterior root and the posterior medial corner release so that will facilitate your dislocation. Now, is it clear that the tibia is completely dislocated? Jig. Hello?
Yes, sir. Yes.
Yeah.
Yes.
Now I'm applying my extramedullary jig and I don't see the foot position. ये पैर दिखाओ. Zoom out करो. I don't see the foot position. I just make sure this, as Dr. Sudhir has rightly demonstrated in the morning, that this has to be in the center of the ankle. And these are at the malleoli. So this has to be at the center of the ankle.
And you will check the slope, sir, now? You
Yes,
put
I'll do that.
3 fingers and something like that.
This has to be in the center. And I just arbitrarily am putting my jig in a position where I would like to be. And now I check the resection level and the slope. Generally, in this case, I would like to resect about less than 2 mm of my affected condyle, that is the medial condyle. And I think I'm right at the spot. Now I see the slope. Now the slope, when I put this jig, the angel wing, it should match the natural slope. That is what I try to match and make sure that it is not in a reverse slope. Now, after I confirm this, I take a pin or first pin, put it, because it is a medial sclerotic bone, I put the first lateral pin.
Hello?
I put the lateral pin first, and now I use a drill to put the other pin on the medial side, because that will help the jig not move. Otherwise, if the jig moves while you are using a mallet, the alignment can change. Now, once this is done, I take out this. I put this guide, which is going to show me 3-point guide, where I'm going to check my axis of the mechanical axis and the anatomical axis by putting this to the jig. Now I have attached this to the jig. I'm going to just drop them down, and I make sure this guide and this guide and the center of ankle are in one line. So that is, instead of only one, which I can try to manipulate, if there are 2 reference points, the third as the middle of the ankle, it becomes much more foolproof to understand that this is in alignment. Any questions?
Dr. Pradeep.
Yeah.
How much tibia cut you are taking? Like
about 2 mm of the affected condyle is what I have calculated.
Okay. Do you always take undercut or same cut in the tibia?
Sorry?
See, what is the implant size? It is 8 mm. Tibia.
Tibia? I didn't get the question.
No. Is it generally they say 8 mm from the tibia? Because
No. I don't go with the measured resection completely.
Okay.
Because in a lax knee, 8 mm can be too much.
Okay.
And in a tight knee, 8 mm can be too little.
Yes.
So this being completely correctable deformity and fairly straightforward, I'm taking about 2 mm of the affected condyle.
Okay.
And making sure all your vital things are protected with the homons. On the lateral, the quadriceps extensor mechanism, and the medial MCL. I'm going ahead with the once this is done.
Dr. Pradeep,
yes.
You didn't put any crosspin, sir?
No, I didn't put. I secured that thing with a. I think if you have seen, I have used the.
You put a
cocker
or
Yeah.
Alice. But in spite of that, sir, while vibrating, because our blades are not single-use blades,
Yes.
they are not sharp enough, it will vibrate.
That's a very good point. But I made sure the saw system is pristine and a new blade is used.
Okay,
And the bone is also not very troubling.
not
It's-
stony hard.
Yeah, not stony hard. That's a very good point for cases where we are the saw is going to have a tough time. As you can see,
And show me the thickness, sir.
yeah. Yeah, you can
You
see
can
this.
ask, sir.
It's about 2 mm on this side. This is the affected condyle, if you can see.
That is on the medial side.
This is the medial side, yes.
Yes.
And this is the lateral side.
Lateral, I think it looks bit.
About
thick,
6
sir.
mm, 6 mm to 7 mm is what? You have a caliper?
Yes,
Okay, they don't have a caliper, but then that is what is my feel. You need to trust me.
but your eyes are more sharper than caliper.
No, I don't think so.
Sir, in case of tibia vera,
Nibbler.
hello,
Yes, yes.
can you hear me, sir?
I can hear you, sir.
Sir, in case of tibia vera
Yeah,
or in case of high tibial osteotomy,
yes.
how do you correlate mechanical axis and anatomical axis?
Mechanical axis as the cora angle, if it is too much of a more than 20 degrees, as it is said, and that is if it is far away from the joint, then we need to do a corrective osteotomy as well. But if it is less than that, we can correct the deformity at the tibial cut itself.
Okay, thank you, sir.
Now I need to check the alignment again with this 3-point reference. The approximate size, I would take the size, and this is number 2. Just go completely, see the tibia and lateralize it properly. And yeah, and this is the, as you can see, this is fitting right here. Can you zoom the, yeah. And I'm again dropping the rods. It is perfectly coming in middle of the ankle. Zoom out, please. Yeah. Can you see this? Now, I spend a lot of time, at least half of my time in the surgery is gone on the tibia, because that is going to work as my reference point for my rest of the surgery. As a non-robotic surgeon, I say that this is my template, which is going to influence my next course of surgery. Yeah. Now we need to take all this off. I retain the tibial pins only to make sure, one, it helps the tendon here, that it doesn't get any injury in the course of the surgery. And the medial pin, I just leave it there, just in case I need to revisit the tibia. I just leave it there till I confirm my gaps. Now I just get a rough estimate of my flexion gap. Lift the limb, please. Yeah. It is looking enough. That is my flexion gap, which I'm seeing, and this is my extension gap. Now I'm going to work on my distal femur nibbler, distal femur cut to determine my extension gap first. Sister, I just need a straight nibbler.
Sir, Dr. Pradeep, sir, you now routinely take osteophytes before cutting?
Yeah, before cutting, I definitely remove the osteophytes so that they give me a better exposure. That is all the reason.
And also your jigs will sit nicely.
Yes, yes, exactly. That's a good point.
Spend some time, sir.
That is the about 7 mm to the PCL insertion.
Sir, for the benefit of new audience, sir, what is the entry point?
The entry point about 7 mm from the insertion of the PCL.
Yes. Above and medial.
Above and medial.
Yes.
I just get a grip with a cautery mark.
Yeah. Especially in the varus knees, if the medial femoral condyle is sclerotic, if you put a drill, it will slide off, sir.
Yes, yes.
Can you give some technical tips how to overcome the sliding of your?
That is very important, because in case it slides out in a place where it's going to hit the vascular structures posteriorly, it's going to be a problem.
Yeah.
So we should always make sure the grip is nicely. Now in this case, I could get the grip well with a cautery mark.
Yeah.
Otherwise, you need
So, Pradeep, please carry on. We just will go to the other theater.
Sure, sure.
Dr. Uday Prakash sir is ready to do a trial. Over to Uday Prakash sir.
Yeah.
We'll come back, sir.
Yeah, sure, sure. I'll go ahead with the.
Go a little bit slow, sir.
Yeah, yeah.
So we won't miss any important points from you.
Sure.
Sir, Uday sir. switch to the other theater where hip is going on. Hello?
Yeah, you are still with me, I think, Dr.
Yes,
Jagan.
switch to theaters, hip
the way-
theater.
Voice.
Yeah, we are ready, I think, yes.
No, I need more AC. Yeah. Yeah, can you hear me?
Yes, sir. Uday,
Okay,
sir?
so we managed to get a nice fit.
Yeah,
So we've got you can see this is the osteotomy we did. This is also the fracture,
yeah,
but that gave us a nice view of the distal femur. We took out the bone plug very safely. We drilled it, and we now got a number 20, 225 stem trial in place. You can see this is a minus head.
Yeah.
And you can see there's 225 written here. So now we're going to do a reduction.
sir, you
So
checked
that's-
with the image intensifier, sir?
Pardon?
You checked with the image intensifier?
Yes, we did.
Yeah,
You can see the image over there.
Yeah,
Can-
yes.
Can you see that?
Yes, yes.
Yeah, so it's bang in the center. And we did a lateral also, which I don't know whether they have kept it, but because this is a straight stem, the lateral shows that the stem is a little anterior in the femoral bow. Okay, so now this is the reduction. Can you see the reduction?
Yes,
The
sir.
zoom in
We see the
camera?
reductions are very
Yeah.
stable.
So this is I'll just take away yeah. So now we've got full flexion, full extension, and then almost 70 to 80 degrees of internal rotation,
Okay.
very stable,
Yes, sir.
and almost 45 degrees of external rotation.
Sure.
So I'm very happy with this reduction.
Oh,
Okay.
yes,
So
sir.
now we'll put the
That's
real
good.
stem, and hopefully and then we'll have to cable the fractures back. Hook. So this should come out with a little, yeah. So we're getting a nice clunk, which means is the right length
Yes.
and stability. And I'm using the tibia as my guide to get an antiversion, which is about 15 to 20 degrees.
Yes.
So we'll remove this. The real stem is open. So what I've done is, because the bone is a little porotic, I have only reamed to 19, but I'm going to put a 20 stem. But if there's any difficulty in putting the 20 stem, I will remove it and then I'll ream a little bit more with the 20. Because the bone is porotic, I'm going to ask the patient to be partial weight bearing for about 2 to 3 months, ideally. Maybe it's a bit of an overkill, but because this acetabulum doesn't have too much bone, I'm going to allow it to integrate.
So what will be your post-operative protocol for the rehabilitation, sir? No weight bearing for 2 months?
Yeah, at least.
And you will made sit or no?
No, what I do is I tailor my post-op regime according to the feel I get during surgery.
Oh.
So here I'm happy with the stem. The cup, we got a fantastic fit also with the 3 screws. But because we are dealing with relatively less bone stock in the acetabulum, I'm going to allow nature to integrate with it, and then we can go for, because I won't have direct control on the patient, so I'm just being extra careful.
Okay, sir. Okay.
Maybe he can come down to see me after about a month or 6 weeks. But until then, I'll keep in touch with the local doctors. Suction, please. Suction. Okay, is the stem ready? Are there any questions about the revision? So this is a Vancouver 2C. There's a significant bone loss around the stem, and it's a very easy classification to remember. The one is a fracture, which is either GT or LT around a well-fixed stem. 2 is ABC. A is well-fixed stem, and B is a loose stem, and B3, sorry, and is it should not be a. It should actually A1, and then B1, B2, B3. So this is a B3, which means we've got a loose stem with a loss of bone stock. That 1 and 2 always confuses me. B and 1, which is 1 and B. So we're trying to now the stem is out. Fitting no. Okay, so let's use that.
Sir,
Once
can we switch over to the other OT, sir?
Okay, we've got the real stem in.
Even you're not given the adapter you have. There's one adapter you have. That's a good instrument actually. Hello?
Yeah, Pradeep sir, we can hear you.
Yeah. So I just took my distal femur cut, and then now once I have done the second important step, first being the tibial cut, second being creating my extension gap. Now this is, as you can see this is a 9 mm insert, sorry, the spacer, and it's a rock solid and no varus and valgus instability or opening of the thing, and it is quite snugly fit, and there is no FFD. This is very, very important in people, in patients with pre-op FFD. We should never, and especially the primary osteoarthritis, we should never be accepting any kind of a FFD in such cases. In rheumatoids, okay, fine, maybe if it is a 10 degrees or 20 degrees, we can accept a little, 1 or maybe 3 or 4 degrees. 1/3 of the deformity is what is generally said in inflammatory arthritis as they stretch. But in primary osteoarthritis, I don't want any FFD left. And the one test to do that is, after you put the spacer inside, zoom out please. And I'm without any support here in the leg being straight. I'm just pushing the leg. If at all there is a FFD like this, once I'm giving the thrust, it would flex. I'll show you this again once we put the implants. Now, once I'm sure about this, I'm taking out my pins on the femur. I just want to clear my supracondylar area for better visualization when I'm going to size my femur. Hello, am I there?
Yeah, we are very much here, sir. We are very clear also.
So as I said, first is tibial platform, second is extension gap, and the third is flexion gap. If these three go right, the knee will live long.
Sir, one question, you always practice the tibia first and then femur cut?
Yes, always.
Do you see any advantage in that?
Because I am totally, tibia acts like my navigation.
Oh.
So everything I related to tibia.
Oh.
There's a remnant of the medial meniscus. Once I'm done.
Pradeep sir.
Yes, sir.
For revision systems,
yeah,
we always start with the tibia. Tibia will take as a reference point.
Yeah.
For the primary knees, the one how you train, whether you train first or a femur first, you can do it.
Generally, what trend is people who are cruciate retaining, they do the femur first.
Yeah.
And generally, who are PS surgeons, they generally, that's what I've seen, but it doesn't mean that it's a kind of a rule or something.
Yes.
Yeah, size up, please. Retract or take a Homans on both sides. It's a Homans. Carefully putting it beneath the MCL and here and now నువ్వు అడ్డం వస్తున్నారా? This is the sizor with 3 degrees and 5 degrees, 6 degrees in this, and as flush as possible to the bone. Make sure.
Sir,
there-
here you take posterior referencing, sir, or anterior referencing?
No, no. Here, once I get my, this is anterior referencing.
Yeah.
Cautery. I just mark my 3 degrees here. 3 degrees.
So
Yeah.
luckily, the
I
modern systems got inbuilt rotation, sir.
Yeah.
You don't need to draw the white side
Yes.
line, transepicondylar lines, or
As this
posterior
being,
condylar reference.
demonstration surgery, and
Yes, yes, sir, yes. So
explain.
that's a white side line, I think.
Yeah. This is the white side line,
Yeah, lowest part of the trochlea, that is a transepicondylar
yeah.
line.
and now my pins should be matching that
Yes.
mapping which I have done.
You prefer 3 degree or 6 degree, sir?
That depends. That's the reason I initially I marked it at 3 degrees.
Yes,
If that was coming less,
yeah,
then I would have rotated it more.
more 3 degrees. But you never internal rotate.
No. And it's the size is showing as B to me, which looks,
And the blades, posterior condylar blades.
yeah, it
should
is flush to
touch.
the bone.
Yeah, touching, sir.
Yeah, it is flush to the bone.
Excellent. Yes, sir. Sir, for the beginner, sir, first we will fix the jig, sir, use the bottom 2 screws, bottom 2 holes.
Okay, here, you mean here.
If you fix it, first you touch the condyles.
Okay.
Fix it. So then you play.
Yeah.
Then play up and down. Use what is the size you got, sir?
B.
3.
And now
It's-
once I put this,
Exactly 3 or 3 to 4.
no,
sir,
it
or
is
2 to
B,
3?
B.
Exactly
It
3.
is just above the B.
Above the 3, but you choose 3.
No, it's B for Bombay.
B. Yes, ABC. Yeah.
Yeah.
Okay.
Now here I have to check quite a number of things before I pin the jig to take my cuts.
Yes.
First thing is I should make sure that there is no notching which is going to happen.
Okay.
And because it is an anterior referencing, it is less likely that that would happen.
Yeah, but still there is a chance.
Yeah,
I
there
think.
is a chance.
Yes.
And they have a beautiful adapter which you have, but then they don't have it now. In case
Yes,
you
sir.
wanted to shift,
Yes.
you can do that, but they don't have it here to
Correct. In this
demonstrate.
system, not, sir. Not possible.
Yeah.
Sir,
No.
Can
In
you
this
put
system, it is possible,
can
but
you
they
put
didn't.
one angel wing, sir, on the
Yes, yes.
and show me, is there any notching is there or not?
Yeah.
Where it is exiting?
Can this be shown?
So camera
one.
from top, please.
Yeah, that one. Yeah, no way.
So I think no notching, I think.
No.
Yes.
And now you need to, that is one thing we need to see. And you
Yes.
should determine that your cut is also, I mean, your posterior offset is also getting restored.
Yeah.
And then your mediolateral placement. Now this should be you should lateralize your femur, and
Yes,
then
sir.
it is
This system
optimal.
got a additional advantage, sir. You can move the jig either medial or lateral. You can
Yeah.
there's a lot of room is there.
Yes,
Yeah, you can correctly, nicely sitting.
yes. Once this is done, slowly tap the,
Sir, if is there any mediolateral mismatch, how do you tackle, sir?
now,
Yeah,
if there is a mismatch now,
no, the jig, anteroposterior is fine. Mediolateral, if it is overhanging or underhanging, how you will manage?
1 second. This
Persona got that option is there, but yeah,
one second. The while hammering the thing lifted off. 1 second. You need to give me this pin pull. Now give me the lug holes, please. The screws for the lug holes. Okay.
sir, if you are putting lug holes means you are committed, sir. I think.
Yeah, I'm committed.
Committed, yes.
Take out this. Yeah. So you're asking me about
How you will overcome the mediolateral
one
size
second.
mismatch?
My mask has come down. కింద లాగండి.
You prefer a little bit overhanging on the lateral side, sir?
ఇప్పుడు just put a plaster there. Yeah, thank you. Yeah. So if there is a mismatch, generally Zimmer, I never faced that problem.
Yeah.
And that's the reason, sorry, in Max, I never faced that problem. In Zimmer, there was a problem. So they came out with the feminine knee counterpart. So in this Max company, I never had that problem of anterior medial and medial lateral mismatch. Yeah, now another right angle, please. Now here, one more thing I wanted to say was, before, suppose there was a mismatch of my flexion gap to my extension gap and I have a doubt. So what I do is I don't put the lateral pins and the lug holes. I just play with the pilot holes. I take my flexion cut, that is a posterior cut, and then check my flexion gap is right or not, and then go ahead with the proper placement of the jig with what I'm doing now. Am I clear?
Yes, sir.
First, I take the jig in a little aeroplane mode, that is a little erring on the anterior side. Now, once I'm confident that there is nothing there, then I take my anterior chamfer. And then I revisit my. Can you see that now?
Yes, yes.
Yeah. Now, can I have a smaller blade, sister? This is number 2. This is a little big. Yeah.
Now you are cutting posterior condyle, sir?
Yeah, posterior condyle and then followed by the posterior chamfer.
Sir, after cutting, show me that posterior condyle, sir.
You're not able to see that?
Yeah, this is a posterior chamfer.
Yeah.
No, we want to see that bony pieces of the posteromedial condyle and posterolateral
The
femoral
cut pieces, you mean?
And
You mean the
bony pieces?
Yeah, I'll show you. Oh, okay, that's fine. Hold it. Leave that. You cannot investigate that. Okay. Action. Make sure this is like this. Yeah, lug holes, please. Pins out. Spacer. Okay, now where is the nibbler?
Yes, sir.
Or cocker? Yeah, now the bony pieces here you can see. Hello? Hello? MSc. చూపియాలి Hello?
Yes.
Yeah. Can you
Pradeep,
see the
yeah.
Can you see the bony pieces which I have?
No, show me, sir. We are not that sharp as you, sir. Just show me that excised bony fragments. No, just we want to say more posteromedial. That is, I think, posteromedial.
No, this is,
Yeah, good thickness.
Yeah.
Posterolateral will be less thickness.
Yeah, less thickness.
If you are taking posterolateral more, means you have internally rotated the component. That's only the point to show to our audience.
Yeah.
Dr. Jay Kishan is here, sir. He's keen to ask for questions.
Yes, please.
He has prepared hundreds and thousands of questions, sir.
Yeah.
We are restricting. We have given rational. You should ask only few questions per candidate.
This is the trochlear groove, and now I'm ready for the box cut.
Do you use file, sir?
Before that,
File to sharpen.
No. I want to see the flexion gap now.
Yes.
Now, take this out. Lift, please. Soft tissue.
Flexion is tight, sir.
No, no, soft tissues.
That's okay. Yes, good.
See, you
Nice
can lift, please. Flexion. Soft tissue here.
lollipop.
Yeah.
Sir, when you put
Now
a
you
trial,
can see this.
you feel that lollipop sound, sir? Nice sound.
Yeah, that is during the trialing, not
No, no,
the
this
space.
also.
Yeah. Now this is the, as you have taken the chamfers, you can do the same thing with this.
Yes.
And now we are done with the third important thing, that is the flexion gap is also done.
Yes.
Now all you need to do is take the box out and
Sir, but I want to add a few
Yes.
more points, sir. Here,
yes, please.
you tried nicely. If you are doing a CR, we are done. But after taking of the PCL,
Yeah.
there may be a 2 to 4 mm of flexion gap will increase with the
Yes,
with the
that is the
PCL
reason-
bone cut.
That is the reason we take out that in the PCL in the starting itself.
Okay.
So that I don't want that to happen
Okay.
now after I take my cut,
Okay.
because now taking out the PCL will increase my flexion
Flexion
gap.
gap, yes.
Because this table, sister, I need a smaller blade. 1 second. Take a Homans. Yeah. And this in this system, in case there is any, this is the second look where you can have the posterior chamfer look, where
It goes.
if there is any possibility of extra bone remaining, you can remove it at this stage.
Correct.
Yeah. I've been needing a curved osteotome now and a cockers. Nibbler. Irrigation.
Sir, I will check any osteophytes, sir, on the posterior side.
Yeah, yeah. I'm waiting for an osteotome.
Yes.
A curved osteotome. Yeah. There's hardly anything,
Anything, yes, yes.
but still it is
Yes, still
important to
worth
check.
to check and worth to release a little bit of capsule
Yeah.
to the back. That will help you in extension.
Yeah. Now this is the trial now. B left.
B left PS femur.
Yes. Now once the lugol's are matching, I'm
Yes.
confident. I take the mallet and
Use obviously gentle force, sir.
yes, gentle. That's the reason
Gentle, yes.
if you can see, I'm holding my
Yeah,
hammer here,
yes.
not here.
Yeah. You prefer to use the handles, I think, yeah?
Now,
So always use the handles for both femur and tibia to place in a correct position.
yeah,
Normally not to flex the femur component. Keep it in extension and gentle taps, especially females, osteoporosis, there is a risk of femoral condyle fractures.
yeah, tibia is fixed. Sorry, the femur is inside. Now I'm
Nicely sitting.
nicely sitting and flush all through.
Yes.
Now I need to flex my knee and lift the femur a little with a very gentle force. The insert is inside.
Sir, what is the size of the poly, sir?
9 mm.
9 mm.
That's
okay.
what I was trying with the spacer also.
Yeah.
That
Okay.
was also 9.
Yeah.
So it has to be 9. Now once I'm confident about my gaps, my alignment, my whole surgery, I take out these pins now.
Sir, can you show from the lateral,
Yeah, I'm-
sir, from the lateral side,
Yes, sir.
whether you got a full extension?
Yeah, I will show. बाबू उधर लेके उधर ले लो वो हाथ में ले लो नहीं तो उधर जाके नीचे नीचे से दिखाना ऐसा सीधा हुआ है
Yeah, side से बताओ.
और थोड़ा पीछे जाओ हाँ।
Raviteja is correct. Side se batao means you have to come from the lateral side. I am poor in Hindi, that's why. You are also poor in Hindi, I think.
Yes.
नहीं सर थोड़ा बहुत आता है.
Now, as you see,
Yes, sir.
I am trying to push my limb axially. I am giving an axial force. Can you see that?
Yes.
And if it is in any fixed flexion deformity is still remaining, the knee will go into flexion.
But from our view, maybe this looks like little bit flexion lags.
No,
extension
actually
lag.
the camera is almost at the roof.
Okay.
You need
Okay.
to उसको हाथ में ले लो ना.
Yeah, your eyes are better than camera, sir.
हाँ
Okay.
अभी हाथ में ले लो.
So it's a full extension, sir.
Yeah. Yeah. Now I am trying to push my limb axially. I am giving a force.
Yeah.
And when I'm doing this, the whole transmitted force is directly going to the hip. If there is an FFD here, then suppose it's like this.
Yeah.
Now I'm going to put. Now it's going to.
Okay, it will
Flex.
buckle the it
Yeah.
buckles the knee.
So yeah, that is the sign of getting complete extension.
Excellent, sir. Any flexion tightness, sir? No.
No, no.
No lift off.
No, I'll just show you.
Any anteroposterior laxity?
I'll just show one second. My mask came off. Yeah. Yeah, put another one, no? Atisheshi. Yeah. Now you can see that first, now once you are done with your extension gap, nice stable. Now I'm showing you my patella, which is nicely falling in its place without any problem.
Yeah. Do you do a thumb test, sir? Single stitch test or
Yeah,
thumb test? for
without any
patella?
stitch only, it is well
It
in
is,
place.
Yes. No, sometimes if it
Yeah,
is
yeah.
subluxing, you put one stitch and check it.
That is important, especially if this is not sitting in place.
Yeah.
We need to
Especially
even
if
take
you
out the
are-
tourniquet before we actually take a call on the patella
Yeah.
thing.
If you interrotate the femur, risk of subluxation.
Yes. So this is the good stability in flexion, extension, and all through the range of movement.
And
And now I'm ready to go for the tibial preparation and cementing.
no lift off, I think. Yes.
No lift off.
Excellent.
So excellent presentation, Pradeep sir. Can we now move on with the case presentation and come back?
Sure.
To see
Maybe while I cement, you want me to come back?
Yeah, please.
Yes, sir.
Please let us know. We'll jump back and.
Yeah.
We will learn the cementing technique, 4th generation cementing technique from you.
Sure.
Do you have vacuum mixer, sir?
I don't think so.
Okay, now I would like to invite Dr. Siddharth for a case presentation. I would like to invite Dr. Jagdishwar Rao sir to come onto the stage as a panel member and we'll carry on with the discussion.
Thank you, sir. Raviteja, sir, we got eminent doctor here, Dr. Narsimalu.
Would like to invite Dr. Nalsimul sir also onto the stage.
Yeah, is our Usmania product, Usmania Medical College and General Hospital. Sir, please. Sir?
Hello, everyone. I'm Dr. Siddharth, and I thank KJ Reddy sir, Team Merrill for having me here today. So this is a brief, interesting case which I want to present. 60 male, you can appreciate the obvious deformity in the right knee, which is valgus. In this particular case, it is 30 degrees of valgus. It was correctable up to 10 degrees. The MCL was lax, but the endpoint was okay on the stress test. So usually we see valgus deformity in rheumatoid arthritis, inflammatory arthritis. So it is important you get ESR CRP done. So in this situation, they were negative. So I'll show you how his gait was when he met me. So this is what he came to me with, obvious deformity. The pathology is on the right side. What do you want to offer? So this is his gait. So gait assessment is very important. Not just the knee, you have to look at the foot as well. Sometimes there is plano valgus deformity in the foot. It's hyperpronated. So So gait is very important in
But
terms of,
Siddharth, you said plantar valgus,
sir,
plantar valgus deformity.
sometimes in the foot it is
Yeah,
common.
but here it is looks
It's
like
not,
a cavus.
it's not.
a
Yeah, it's
deformity.
cavus.
Yes.
Absolutely,
On
sir.
the right side.
Absolutely. So in this case, it's cavus, but sometimes more often than not, you will see planovalgus deformity in the feet.
Yeah, valgus and plantar valgus are both are sisters.
Yeah,
They go together.
They go together.
together.
They go
Here, probably these are the what you call step sisters.
Right, sir.
So valgus in the knee and
Cavus
cavus in the foot.
Cavus in the foot. This is rather uncommon, but you see a valgus knee with a planovalgus foot. So this is his assessment before we go in for a total knee replacement. The MCL, all I want to see is the status of MCL. Why is it important? Because it dictates the constraint that you have to take in total knee replacement. So he had a flexion of up to 100 degrees. I'm palpating the MCL. The MCL looks okay to me. It is lax, it is stretched, but it is still intact. It is not broken. So that is very important. So how to approach this case? So this Mulaji et al. Is published in Journal of Arthroplasty 2013. So correctable valgus, fixed valgus, valgus plus hyperextension, valgus plus FFD, and incompetent MCL is type 5 and type 6. So this is an important classification. Although there is Ranawat's classification, where the valgus knees are classified into 1, 2, and 3, mild, moderate, and severe, but that is not very informative. This is more informative, and this also helps you to plan the case. So in this case, you have an intact MCL, but still I want a backup of LCCK or a hinge in the theater because it is stretched, it is very much lax. Because it is intact, I'm going to go in my mind with a primary total knee, maybe with a stem. So I would want to show the X-ray. So two SS are very important. One is standing scanogram, one is skyline view. Unfortunately, I couldn't do that in this case, but in the beginning stages of your career, you also should think of two.
What is the use of skyline view, sir?
Sir, in valgus knees, the patella tracking is an issue sometimes.
Yeah.
So it helps you to see how the patella is articulating with the femur in the skyline view. I haven't got it done. I haven't got the scano done, but for the beginners, I would like to.
I don't think this skyline view plays a major role here.
Right.
You can take a scanogram and AP and lateral view. If it's in doubt, you can take a Rosenberg view.
Right, sir.
Anyhow, the in valgus, you have a hyperplasia of the lateral, you will have a lateral subluxation.
Absolutely, sir.
Obviously, it is there, sir.
Right. So why is scano important? This is not the scanogram of this particular patient, but scanogram will dictate you, and it will help you to draw a mechanical axis. It will help you to draw the anatomical axis. You can calculate the valgus cut angle, which is not the 5 degree that we do in a regular knee replacement. In valgus knees, you have to get the valgus cut angle down, maybe through 4 degrees or sometimes to 3 degrees also. You can calculate that with the scanogram.
Hello. The knee looks completely disorganized. Don't you think it's a neuropathic joint?
No, sir.
Yeah.
No, sir.
Only one ligament is, I think it's little intact.
Right.
Or otherwise,
It is not.
complete thing is wobbling. And you see the pedal is high riding pedal there. Lots of osteophytes. And
Right.
walking with the reformed
Right,
foot
sir.
also.
So
It looks as if it's a neuropathic joint. What do you think?
no, sir. Neuropathy has been ruled out for this particular patient, sir. But I would keep that in mind. I would keep that in mind. Like you said, neuropathy is a probable cause if you come across a case like this. But in this particular case, it was not neuropathy. Right. So the approach, you can either do a middle parapatellar, but I'm a subvastus surgeon. I do all my knees with subvastus approach. Even in this particular case with 30 degrees of valgus, I would still not think of.
Here you have chosen orthoplasty, orthodesis. Choose one.
Arthroplasty.
Arthroplasty.
For me, it's arthroplasty.
Do you think it will be stable with this orthoplasty?
Yes, sir.
The bone
I
stock,
think-
all things.
Yes, sir. I think so, sir. So I've planned this case.
Sir, orthodesis has no role in modern areas, sir.
Right.
Unless if it is a failed orthoplasty, only orthodesis.
It's only in salvage situation. I
Sir,
would think.
here it is a gross valgus.
Right, sir.
If we go subvastus approach,
Right.
it is difficult to expose the lateral structures.
Sir, it is difficult to expose. I agree with you.
Yeah.
I agree with you. But
Lateral parapatellar
I was
approach
keeping that in mind. But I felt the knee was little lax for me to manage the lateral exposure. I never thought lateral exposure would be challenging.
That is a concave side on the lateral side.
Absolutely.
you have a tight structures, obviously,
Right,
even
sir.
though it is lax on the middle side.
Right, sir.
Lateral is fully tight. At least you should go middle parapatellar approach, I think.
Right. Sir.
You may be an
The
expert
point
hands,
is rightly taken, sir.
but
But
if you take a Keblish approach or lateral parapatellar, unless you do regularly,
right, sir.
don't dare to attempt the lateral parapatellar approach.
One of my bosses, I've asked one of my bosses when he did lateral parapatellar approach, he told me that he only did it once. And that also he did by mistake. Right. And completely you cannot appreciate the anatomy. If you're not familiar.
Yeah, here almost all the ligaments have gone except one ligament which is intact. Even all things have gone. The stability will be there. Suppose
I didn't get your question, sir. Sorry.
No, the ligament, the complete thing is disorganized. No proper thing is there. No global except one which is there. The way, the way you have examined now, you can show all side movements are there, freely moving.
We'll see how things go, sir. With arthroplasty, we'll see how things go. So, sir's question is, you don't have any ligament except MCL. How can you do an arthroplasty in this case? Am I right, sir? So we'll see how we have done it. We'll see how I managed. So this is the exposure, subvastus, standard cuts in the femur, standard cuts in the tibia. I cannot see any extension gap. I'm not happy with the extension gap. So I went +2 with the tibial cuts.
So here it's a severe valgus.
Right, sir.
Bit more vigilant while cutting the femur. A very, very high chance you may internally rotate.
Right, sir. Absolutely.
Because of the lateral femoral condyle is hypoplasia.
Right. Sir.
Experienced surgeon like you can do. Beginners, they should spend more time.
Right.
They should take 3 or 4 referencing points.
Right,
Right side line, transepicondylar line, or line from the tibia.
Absolutely, sir. Absolutely.
You should not take the posterior condyle as a referencing point here.
That exactly is in my next slide. So you've finished it off for me. So
Yes, sir.
slightly medial entry while you enter the femur and 4 degrees valgus cut instead of 5 or 6 or 7. It keeps my stretched out MCL at a biomechanical advantage. In this particular case, I didn't have extensive hypoplasia.
Siddharth, your valgus angle depends upon the valgus deformity of the knee joint or any other parameter?
Sir, I take a standard 5-degree cut in all my various knees.
Yeah.
In a valgus knee, if I get a scano done, I can calculate it.
Yes,
if I
that's
don't have
correct.
the scano, I try to take it 4 or sometimes 3.
Yeah.
Sometimes 3. Right. In this particular case, there was no extensive hypoplasia of lateral femoral condyle posteriorly or laterally. Tibial cut is standard. In this case, I had to take a +2 cut. This is exactly what Jagan sir was talking about. If you have a lateral femoral hypoplasia, it could be hypoplastic distally, it could be hypoplastic posteriorly. If you have hypoplasia posteriorly, you can internally rotate the femoral component, and that is very much counterproductive. So always keep in mind about hypoplasia. And if you have it, you have to increase your external rotation of the femur. So the most important thing in a valgus knee is soft tissue release. And soft tissue release is, when it started off, when people talked about soft tissue releases, it was quite extensive.
Yes.
Krakow, Ranawat, they spoke about big releases, but here simple stab incisions are more than enough. Ultimately, what you want to have is balanced knee with good ligamentous stability. So soft tissue releases, how you program and how you go forward. In this particular case, there was a big contained tibial defect after the tibial cut. So I managed it with 2 screws. And this is what I did. Final result, subvastus, total knee with a stem of 15 mm diameter, 100 millimeters in length. So this is him at 2 weeks.
Can you please go back to this previous slide, sir? What is the diameter of the screw? 4.5 or 3.5, sir?
3.5 screws.
You should have used 4.5.
I can
It is a little bit longer.
Absolutely,
screw.
absolutely.
A
Absolutely.
short screw, just it acts like a raft.
Absolutely.
Just give a support
Absolutely.
of your bone cement.
Absolutely.
Yeah, you can take some bone chip also where you cut that
Right.
chamfer cuts.
Right.
You can put the bone there.
Right.
Otherwise, well designed, well executed this. Why you put so long tibia steps, sir?
Sir, actually, I can get away with the shorter stem as well.
Yeah.
But this case, I went with it because I prepared for it.
Why,
So
sir?
it's just a preference, sir.
No. There is a 2 advantage and disadvantage.
Shorter
sir.
the stem, better it is.
Yeah.
Shorter
No. It need not be. There is a calculation 5 times the diameter where you are thinking.
Right.
But if you put a too long stem,
It can impinge on one of the cortices.
we don't have offsets here in India.
Right. True.
We don't have a tibial offset stem. If you keep a long stem and put a tibial base, it may not sit properly on the tibia. It may lift it up in either side.
Right, sir. True.
That is maybe the thing.
Right.
Yeah, and also the tibia is not a tube, sir. It may go and hitch the cortex. It may be a stress riser in your future things. It is an uncemented stem or cemented stem, sir?
Sir, it's uncemented.
Very nice.
So this is him walking at 2 months.
Siddharth, just 2 minutes. We'll switch back to Dr. Pradeep Sir Theta. He is cementing the implants, and then we'll continue with our remarks. So can we switch on to Dr. Pradeep Sir Theta?
Nice, sir. Nicely walking.
Can we switch over to Dr. Pradeep Sir Theta, please?
Excellent. Excellent.
Hello. Yeah.
We can't see.
I'm just putting the tibia.
Sir, after your knee replacement, patient has become more younger and younger, sir. I don't know why.
You're talking to
Maybe
me,
you have
Dr.
given good
Jagannath?
quality of life. That may be the reason.
Thank you, sir. Thank you. Thank you. Thanks a lot.
You have given some nuts and other things, sir, for diet and anti-aging pill. Yeah, Pradeep, sir.
Yes, sir.
Yeah, you did cementing of the tibia.
I'm doing it now.
Yeah. Is a Palaco cement?
Yes.
Excellent. Cement antibiotic loaded?
Yes.
Yeah,
Palacos R plus G is what I was told.
Pradeep,
Yeah.
we are doing a PS now, sir. You put already real poly there.
Yes. I do it a monoblock kind. No, don't lift. Just
But
keep
while
it
inserting the tibia, it may scratch or it may damage the poly.
Put thumbs here and then thumbs. Yes. Just say there. So while insert, this is the monoblock technique, how we do.
Okay.
The advantage of this technique is, as you saw in the morning, there was a little difficulty in getting the poly.
Yeah. So that's why, sir, in PS, what my preference is, but first put a femur, sublux it, and put a tibia, put a insert, and reduce it.
Yeah, that also can be done.
Yeah.
But here in porotic bones, if we try to lock the poly by banging it after putting the lock the poly on the table on the patient, there are instances where you had got periprosthetic fractures also.
Yes.
So here, this is a very smooth way of doing it. I cement my femur all across.
Yes.
Properly.
And do you keep the cement in the implant also?
Yes, I've already done that.
Yes, very nice.
Not getting into
Sir,
the
do you
box
put any,
either.
if it is a sclerotic bone, you put some multiple holes in the middle femoral condyle and middle tibial plateau to get a good digitization of the cement?
There was no
sclerosis
there.
Excellent.
And now just identify the lug holes.
Sir, you
just
won't
make
use
sure
you
we
won't
need
use
to...
the handle, sir?
No. I don't use the handle because that can come in the way. Now I have put my femur like this behind the post. Now I'm going to flex the knee and match the lug holes.
Yes.
And gently press it and extend it.
Yes,
That's it.
You won't use the punch, sir?
Now I'm going to use the punch.
Okay.
Once I secure the position, now I'll be using the punch.
Use the punch. Okay.
And again, here also we should be very careful not to apply a lot of force, because if you apply a lot of force, you'll be having an intracapsular neck fracture.
Intracapsular?
Neck.
Yeah, that's the only thing, sir. I have not heard about it.
No, it is.
We'll get a periprosthetic fracture not far away. It is miles away from you, sir.
It is well documented because the axial force is directly acting on the...
If you have any incidents, sir, please write a case report.
No, there are multiple. There are multiple. in the
Telangana
literature.
Orthopedic Journal.
Pradeep sir, thank you so much. I think it is wonderful. I think the
excellent, sir. Excellent.
Thank you so much.
Yeah. So we'll catch for case presentation. So Siddharth, can you please show us the post-op of your patients, and then we'll switch on to Dr. KJ sir's bilateral knee replacements. I think the theater is ready there.
Yes, sir.
Dr. J. Krishna Reddy and Chandrasekhar sir also in the theater.
Raviteja, we are going to the theater or case report?
No, he is going to show the last post-op x-rays. Sir.
One x-rays.
Half a minute, and then we'll move on to the theater.
Raviteja, suddenly audience have disappeared.
No, I think I'm towards the end of my presentation anyway. So
Table down, కొంచెం.
it's not working, I believe.
It's working.
So can you hear me?
We can see the slide.
No, I think
Ravi. Jairam. Handle ఉందా?
so. I think the audience has got the message, but I want to finish off with this slide. So always look down because you're standing on the shoulders of your teachers. These are my mentors. The man to the extreme right is not at all a knee surgeon. He's a shoulder surgeon, but he's my favorite teacher for as far as orthopedic
Looks
principles
like
are concerned.
both are abroad, sir, from
Yeah,
abroad.
yeah. First, he's Professor Kim. He's from Korea. Professor O also is from Korea. In between is Dr. Uday. He's busy doing revision hip today.
Yes, sir. Yes.
So thank you everyone.
Excellent.
Thank you,
Excellent,
Siddharth,
Siddharth.
for your wonderful case presentation. I'm sure youngsters like us would definitely look up to this kind of cases. Now, with switching on to the theater, please continue with the surgery. Let's move on to Dr. KJ sir's bilateral knee replacement with
Jay Prakash and Jay Krishna Reddy and
Jay Krishna Reddy sir and Chandrasekhar sir.
Chandrasekhar.
Can you,
both
can you
we
hear
are doing
me?
the same case, sir?
Can we
Can you,
connect to the
Ravi,
theater,
can you hear
please?
me?
Sir, we can hear, sir.
Yeah, I think I have to have it on the patient demand, but actually it's
Yes.
We can see you, sir. We can
Yes,
see
sir.
your,
Chandrasekhar is going to continue.
but your voice is a bit low.
You can see, I think for the.
Can you increase the volume in the theater, please?
Can you hear me?
Yes, sir.
Yeah. So that's it. I think that's the patella ligament and tibial tuberosity.
We are
Everyone is
hearing a
showing
bit,
in a different way, so I show my way.
your voice is a bit low, sir. Please, someone from the audio visual, can you increase the volume from
Can
the
you put the mic
theater?
little low? Or can mic? Can you hear me now?
Yes, yes, sir. Now,
Better?
100%, sir.
Yeah, okay, good. So I think incision, that's a tibial tuberosity. Incision should not be on the tibia, I think bit long, should not be on the tibial tuberosity because that will have a painful scar. And you should not go beyond maybe 2 fingers below the tibial tuberosity, that's the tibial tuberosity. Otherwise, you will damage the saphenous. Now, medial cutaneous branch of the saphenous nerve. So straight to the deep fascia. I am happy to have Dr. Jay Krishna. I'm proud of him, my student. With me for how many years you're with me?
10 years.
10 years worked with me. He's a big man, bigger than me now in Yashoda. So I think it's important to just isolate the patellar ligament, as you can see, and the medial side. So go in, not many planes into the joint. Ravi, next moderating the patient.
We cannot hear your voice clearly, sir. For some reason, it is going up and down. Someone from the audio visual team, please help us.
Audio, can you just check it? Can you hear me now?
A bit lower, sir.
My you can see,
Hear you now.
hear you. Ravi, can you hear me?
Yes, sir. We can hear you, sir.
So I think a little chip on the thickness again. Yeah. Is that better? My mic is better now?
It's actually going up and down, sir.
Oh, I think probably the audio team should see whether it's
Yeah, now it's stable.
stable. Okay, good.
Now it's stable.
Sir, how much medial release you do, sir? How do you decide how much to do?
Hear me now?
Can you please, can someone from audio visual team please check?
Take this one off. Take this one. This is shield mask. Can you hear me now? Put it on.
Yes, sir, we can hear you.
Yeah. Yeah, that's a good question. Because medial release, after starting robotic surgery, we do not release much. We just release to expose the medial part. So initially there is no release.
How much, sir? Like
Just to go to the posterior.
coronal plane?
Proximally, just go to the posterior medial corner of the tibia. Just expose the tibia. Otherwise, as you know, as such not release, just developing the plane between the MCL and the tibia.
Oh.
As you can see, there's a difference between the release and developing plane. Just put my curve laser. And always use Homans. Don't use the Langen bags because it will damage. So that's the, you can see like this. And that is the notch. There's an osteophyte. I'll show you. You take the osteophyte so that you expose the PCL and make that area a little rough as well so that your drill doesn't slip. Okay, take that. Drill to me. Put that now. And you can see that is the PCL attachment. Just adhere to the PCL attachment. Expand the mouth and go inside. Sorry. And I use the TS sacrificing. So I take about 10 millimeter distal femoral cut because this is a Genesis one, Smith and Nephew. The femur is 9 millimeters. So we cut only what we replace, but because I use PS and there is about 5 to 10 degrees flexion deformity. Yeah, but so probably I take about 10 millimeters. And as you can see, I use a drill to make a drill hole so that it doesn't move and put the pin. Gone. Sometimes what happens, it will be blunt. I won't be able to move. So you can move the jig while putting the pins in if you're not being careful. Take the jig out. Remove. Exactly. Okay, so again we check angel wing so that you're not cutting too much. So I'm just entering the notch. This side osteophyte is there, about maybe 10 millimeters I'm cutting. So that's not too big. Okay. That's the distal femoral cut. And make sure you run the saw again. Sometimes what happens, if it is a hard bone, it will slide off. Pin out. I do what is that? Yes, so
Sir, why you do the femur first, sir? Any advantage rather than doing the tibia?
Major section. So what happens is I know how much I'm cutting. Just restore. Knife, please. Important that you cut the anterior horn of the lateral meniscus so that you put your measuring guide in, and I finish off with the femur first because I know how much it comes. So I don't have to. Okay, flat. Yeah, flat. And Sudhir was saying in the beginning, you must be careful about being flat completely. And size coming. 4. Size is coming 4. exactly 4. So we plan for size 4 Genesis femur. Size 4, please. And this 4 cutting block. Okay. No. Pin, please cross pin. Just put one cross pin. Can you hear me? Ravi, can you hear me?
Yes, sir. Yes.
Hello?
Yes, they can hear me.
Yep. So use the medium blade for rest of the cuts. Okay. So that's femur is done. That's the bone block. Let's see.
Sir, KJ sir,
Yeah.
jig looks bit different, sir, with the previous Sudhir Reddy's jig.
This is the Genesis one.
Oh, Genesis. Okay, you are doing okay. Okay. Yes, 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 sir. Okay, sir.
And female patients, I think, from sometimes probably. Hammer.
Sir, do you hear me, sir? KJ Reddy, sir?
Yeah, yeah. Go on. Yes, I can hear you.
Sir, is there any advantage preparing totally femur and going to tibia?
No advantage. I've been doing it.
No, sir. Generally, we do
Gaps
tibia
going
first
to come.
and go for the femur.
Yes, no, I do this way because in a major design, you were doing a PCL retaining one, you have to balance it. But in a PCL sacrificing one, cut the ligaments. So easy to balance. And you don't have to worry too much. I'll show you in a minute. But if you're okay. Let's go hold it. I did not cut the notch. I just finished the rest of the cuts. The advantage being, it makes your life easy and saves time. Taking the meniscus out. And the tibia. Make sure it's about, of course, 3 degrees. Most of the time, can you see the bottom? You should be able to insert 3 fingers easily. That's one of the other check. And you should be center of the ankle, second metatarsal. And you take from the normal side about 9 millimeters, the amount of tibia, you going to replace it. Okay, and double check with your angel wing so that you not taking much. Can you see? Not taking much, about 2 millimeters, less than a millimeter from the medial side. And you also check the slope appropriately. So probably you slope is probably natural slope. You're not going to replace it, but you're not grossly deviated. Okay.
Sir, what is the slope total you are taking here? That is a 3 degrees from the jig and
3 degrees slope.
3 degrees with the implant?
See, every implant has got its own slope.
Yeah.
So you previously we used to think we had to restore the natural slope,
Hmm.
which probably may not be right, because every implant has got its own slope. So you
Yes.
have to follow the implant.
But the normal tibial slope is around 9
10 degrees, 8 to 10 degrees.
8 to 10 degrees. But we are not taking the 9 to 10.
So, see, if you put the implant, the 3 degree slope, it will be around same degree. Okay. And one more tip is make sure you take all the tibia all around out. At this stage, probably I'll just check. Lift the femur up, lift the femur up, and my 2 fingers goes well. So I'm cut reasonably well, so I don't have to cut it again. Pins out. And that's an osteophyte. Once you cut this, you see the how much is it? Too little. Huh? Okay. I think 2 looks good. So you always match the advantage of Genesis knees, even if your knees, it's medial lateral surfaces are unequal. In the sense, lateral is less, medial is more, which is a natural thing. Prepare the brush. Tibia. There. Okay. You have to be careful in hitting in osteoporotic tibias. Okay. So now I prepare the tibia. Now get up. Any remnant osteophytes from the back of the femur, take a curved osteotome and try to, you can see coming out. That will improve your range of movement, especially high flexion. But you have to be careful. Just lift up this side. Good. Mostly osteophytes. We had about 10 degrees of flexion deformity. We'll see whether we can need any box. That's good. This time. Okay, then we will complete the preparation of the tibia. In the middle. Good. Okay. No, the one direct hits because it's a cancellous bone. One more. So prepare the notch. Sit down. Okay. I'll hold it. I'll hold it. Okay, good. Much. Doctor.
Any company uses which you feel better.
Okay, once again. Okay, doctor.
Repeat is, I mean, regular repeat is, but not contain Smith and Nephew or Jimmer. Nowadays, people extensively.
Okay, pins out. And I strongly believe all approaches are good. All I mean, PS or retaining are good, provided you do the surgery properly. So, osteophytes are there, the back of the femur. Now I do the trial. See, Very good. Okay. Give me 9. So 9 trial. That looks good. So there's a little flexion deformity which needs replaced. That 9 stable, both valgus and varus, 90 degrees is the. I'll just close. 90 degrees is stable, and you can go up to 120 degrees.
What is the poly size, sir?
9 millimeters.
9 mm.
It has been shown.
Yeah.
It has been shown. It has been shown that 9 or 10 polys do better than thicker polys.
Thicker.
14 or 12 polys because of the wear rate is more in a thicker poly. That is the is hip and femur. So releasing capsule posteriorly, you have to be very careful. And one tip, put your finger back of the knee and close to the bone and release the this one capsule from the back of the femur. Bristow. And with the Bristows close to the bone, on the bone. That will do the job. Now I think Dr. J. Krishna going to plant it and we'll continue with other. Yeah. Okay. Thank you very much. Questions?
No questions, sir.
Thank you very much.
So KJ Reddy, sir, it is a marathon surgery, sir. You finish it in 15 minutes. We learn how to do a takeover in a perfect manner at a short period of time.
That's what I said. I know this is called measured resection.
Yes.
So you know exactly how much to
Implants open.
resect. And we've been debating about retaining, sacrificing. Both are equally good, provided you do well. You will leave more ligaments in. You have to be very careful. Retaining, you have to be balancing, you have to be perfect. Otherwise, what happens is instability, patient dissatisfaction is more.
So
Even in this century, 19% of the not the last.
Sir, do you do any templating, sir? Templating
we should do ideally initially, but what happens is most of the time you need templating for conventional. Unlike hip you have to template.
Yeah.
Most of the sizes are available on the shelf, so you have to template unless you find a difficult knee or post traumatic whatever previous surgeries were done. Then you have to template. Otherwise, routinely I do not template it.
Templating. Okay, sir. Thank you.
Thank you. I will join you in the auditorium.
Thank you, sir.
Thank you, KJ sir, for wonderful demonstration. Now we'll move on with the surgeries now. Dr. J. Krishna sir, please walk us through the steps that you're taking it forward from now on, please.
Yeah. Can you hear me, Ravi?
We can hear you, sir, loud and clear.
So we just washed, removed the debris.
Yes.
And implants are taken. We are mixing the cement now.
Sir, do you use a pulse lavage? I think.
Yes, we use the pulse lavage.
Yeah.
Can I get a dry mop?
Sir, you are putting first femur.
First tibia.
First tibia.
Yeah.
Then femur. Then poly.
Then poly. Yes.
Okay.
If I do CR, it's other way. First tibia, then poly, then femur.
Femur. Excellent.
Sorry.
Drill. Drill. Just drill blade. There's a little bit of articular surface here. Yeah. Hold on. You know. Yeah. Like.
Hearty welcome to Mr. Srinivasa Gowda garu. Thank you for attending this orthoplasty course today. Would like to also have Venkat Reddy sir and Krishna Reddy sir to accompany the stage.
Thank you.
Mosquito. Mosquito on cement ball punch again. Punch again.
తుడు ఫాస్ట్ గా తుడువయ్యా.
Good afternoon, everybody. A warm welcome to Srinivas Garu from SVS Medical College and Hospital. I would like to invite Dr. KJ Reddy, sir, Managing Director of the hospital and college, on stage. I would also like to invite Srinivas Garu on stage.
Dr. KJ Reddy sir, please assist Minister Srinivas Garu onto the stage. We'd like to invite Dr. Ram Reddy sir, Venkat Reddy sir, and Krishna Reddy sir onto the stage. like to invite Professor Jagdishwar Rao sir and Anjaneyal sir onto the stage. We'll do the inauguration. Minister Garu to please do the lighting lamp.
ఆయన మాట్లాడిన తర్వాత అదే ఈ రోజు జరిగింది చెప్తాను తర్వాత ఆయన చాలు కప్పి అంతే కదా మాట్లాడతాం. Good afternoon. Respected dignitaries on the dais, especially our beloved Minister Garu, Srinivas Gaud Garu, is part of our SVS in all good programs. He's been associated with us for a very long time. Our well-wisher, good friend, is like one of our brothers. Thank you very much for coming over. In spite of your busy schedule with CM, you had a meeting with CM, so it's a break in between the meeting with CM. As you know, they are very busy with elections. I would like to briefly say that we have been doing this World Arthritis program for the last 1 week, and we screened quite a few patients, selected for non-operative as well as operative treatments. And we have screened quite a few hundreds of people for operative, non-operative treatments. As we said, only 90% of the people do not need surgery, 10% only need. And there are about 7 crore people suffering with arthritis in India, 30 crores in the world. And 1 week we are doing this program. Today we have planned 8 operations. How many? 5 have been done and 3 more to go. We had excellent about 600 delegates, all our students and everybody. We had most of the recognized faculty who have come for in participation and done surgeries. Thank you very much for all the faculty and the delegates. And this program is going live on YouTube, Facebook, and all social media. Oh, thank you very much. Thank you very much. And we would like to continue these programs. And now I would like to request Minister Srinivas Gaud Garu to say, give the message.
Respected our brother Chairman Krishna Reddy Garu, Venkat Reddy Garu, Ram Reddy Garu, and Medical Director KJ Reddy Garu, Dr. Anjaneyal Garu, Dr. Jagdishwar Garu, Professor, Dr. Joshi Garu, Chandramouli Garu, and good morning to everybody. Good afternoon. Just now I have seen your operation, live operation. I am very proud to you, sir, because you are all brothers are totally depending on the medical college, improvement of medical college and medical field. చాలా గర్వంగా ఉంది. మా జిల్లాలో పుట్టి ఒక మారుమూల గ్రామంలో పుట్టి మారుమూల గ్రామంలో ప్రజలు ఎదుర్కొన్నటువంటి ఆరోగ్యపైన సమస్యలు చాలా మంది చనిపోవడం చూసి వాళ్ళ కుటుంబంలోనే వైద్యం అందక ఒకరు చనిపోవడం, భవిష్యత్తులో అలాంటిది ఎవరికి జరగకూడదు, మెడికల్ సేవ ప్రజాసేవ చేయాలని చెప్పి లక్ష్యంతో ఒక మెడికల్ కళాశాల పెట్టి ఈరోజు అత్యంత అద్భుతంగా హైదరాబాద్ సమీపంలో వన్ ఆఫ్ ద బెస్ట్ మెడికల్ కాలేజ్ ఇన్ తెలంగాణలో పేరు తెచ్చుకొని అనునిత్యం నలుగురు కూడా ఒక్కొక్కరు ఒక భాగాన్ని పంచుకొని ఎట్లా ఇంప్రూవ్ చేయాలా, ఇంకా అకాడమిక్ ఎట్లా ఇంప్రూవ్ చేయాలా అని ఒక్కొక్కటి చేస్తూ, ముఖ్యంగా కేజే రెడ్డి గారు ఆర్థోపెడిషన్ సర్జన్లో ఇండియాలో కొంతమంది ఫేమస్ డాక్టర్లో వారు ఒక ఫేమస్ డాక్టర్. ఈరోజు వరల్డ్ ఆర్థరైటిస్ డే సందర్భంగా లాస్ట్ 2 years బ్యాక్ కూడా ఇక్కడ మనం ప్రోగ్రామ్ చేసినాం, చాలా పెద్ద ప్రోగ్రామ్ చేసినాం. మళ్ళీ ఇప్పుడు ఒక మంచి సెమినార్ ప్లస్ యూట్యూబ్లో కూడా ఆపరేషన్ చేయడంలో డైరెక్ట్గా పబ్లిక్ లైవ్ కార్యక్రమాలు ఇచ్చి ఈరోజు దాదాపు 10 నుంచి ఒక 20 మందిని ఆపరేషన్ చేయడానికి ఇక్కడ ఏర్పాటు చేసి వివిధ జిల్లాల నుంచి ఆర్థోపెడిక్ సర్జన్స్ అందరిని పిలిచి ఇక్కడ ఏర్పాటు చేస్తున్నందుకు మిమ్మల్ని అందరినీ కూడా మనస్ఫూర్తిగా అభినందిస్తూ, గతంలో పెద్దగా అవగాహన లేకుండా ఆర్థోపెడిక్ మీద చిన్నప్పుడు నేను కూడా చూసేది ఈ మహబూబ్నగర్లో బండమీదపల్లి ఆశన్న అని ఉండేది. ఆశన్న ఎవరికి కాలు ఎరిగినా డాక్టర్ల దగ్గరికి ఎవరు పోకుండి డైరెక్ట్ బండమీదపల్లి ఆశన్న దగ్గరికి వెళ్తుంది. ఆశన్న ఎట్లుందంటే ఆశన్న యాదవ్ మంచిగా గోసి గీసి కోసుకొని కింద కూర్చొని వచ్చిన వచ్చినట్ల కాలు ఇరిగింది అంటే ఒకసారి నేను చూసిన లైవ్ పాదం ఇరిగి వచ్చింది అనమాట. పాదం పెట్టి కచ్చకచ్చక దొక్కేసింది అనమాట. దల దొక్కేసి పెట్టి కట్టేసింది. మంచి కూడా అయింది అనమాట. అట్లా ఏ కాలు ఇరిగినా చెయ్యి ఇరిగినా మొత్తం ఆయనే వైద్యం. మహబూబ్నగర్ జిల్లా వాళ్ళు కాదు, తెలంగాణ ఆంధ్రప్రదేశ్ ఉమ్మడి ఆంధ్రప్రదేశ్లో కూడా ఎక్కడెక్కడో జిల్లా వాళ్ళు కాలు ఇరిగిందంటే కార్లు వేసుకొని వచ్చేది, ఆశన్న కట్టు కడుతుందంటే మంచిగా అవుతుంది అనమాట. అటు నాటు వైద్యం ఉండేది. రాను రాను చాలా ఇప్పుడు అడ్వాన్స్ టెక్నాలజీ వచ్చింది. అప్పుడు ఇరిగిపోతే కట్టేది, అరిగిపోతే కట్టేది లేదు అంతే. కానీ ఈరోజు అరిగిపోతే కూడా ఇంప్లాంట్స్ ఉన్నట్టు వచ్చినాయి చాలా. జాన్సన్ ఇప్పుడు కొత్తగా మెరిల్ కాంపిటీషన్స్ చాలా వచ్చినాయి. ఇప్పుడు చాలా మంది ఎదుర్కొన్న సమస్య ఏంటంటే మోకాల సమస్య. ప్రతి ఒక్కరికి స్టార్టింగ్లో ఆర్థోపెడిక్ అంటే ఏ ఆర్థోపెడిక్ ఏముంటుందిరా, ఏం వేస్ట్ అని ఎట్లా అనుకుంటుంది. కానీ ఇప్పుడు ఆర్థోపెడిక్ అంటే కంపల్సరీ ఆర్థోపెడిక్ డాక్టర్స్ ఎంతమంది ఉంటే అంతమందికి వర్క్ ఉంది. ఇప్పుడు పని ఉంది అంత. ఫ్యూచర్లో కూడా పాపులేషన్ ఎంత పెరిగితే అంత మంది పేషెంట్లు. 55 సంవత్సరాలు దాటిందంటే చాలా మందికి చిన్నప్పుడు కూడా ఆర్థరైటిస్ వస్తుంది, చిన్నప్పుడు. అది వేరే డిఫరెంట్. అది జనరల్గా మోకాళ్ళవి, కీళ్ళవి, నడుము నొప్పి, మెడ నొప్పి ఎవ్రీ 100 మెంబర్స్లో ఒక 5 to 10% కంపల్సరీ ఏదో ఒక ప్రాబ్లం అయితే వస్తుంది అన్నమాట. కనుక స్టార్టింగ్ ఎంఎస్ ఆర్థో అంటే చాలా పెద్ద తక్కువ వాల్యూ ఉండేది. ఇప్పుడు ఎంఎస్ ఆర్థో అంటే చాలా వాల్యూ అనేది పెరిగింది అన్నమాట. చాలా అవసరం. ఇంకా ఎంత చాలా అడ్వాన్స్ కూడా వస్తాయి. ఒకటే నేను రిక్వెస్ట్ చేసిందంటే, మీరు ఆపరేషన్ చేస్తారు ఎప్పుడు అరిగిన తర్వాత, కానీ అరగకుండా ఉండడానికి ఏం చేయాలనేది దయచేసి అది ఎక్కువ అవగాహన వచ్చేటట్టు చేయాలి. అరగకుండా చిన్నప్పుడు ఒక ఎగ్జాంపుల్, మేము గ్రామీణ ప్రాంతాల నుంచి వచ్చిన వ్యక్తులు. మేము ఎద్దుల బండి ఉంటుండే. బండి కిర్రని శబ్దం వస్తుండే, ఏది గుట్టలాగా ఎక్కుతుంటే కిర్ 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 అని శబ్దం వస్తుంది. అప్పుడు ఏమి వస్తుంది, ఆ డీజిల్ కాలిన డీజిల్ నల్లగా ఉంటుంది ఆయిల్. ఆ కాలిన డీజిల్ ప్రతి ఎద్దుల బండి ఉన్న వాళ్ళ దగ్గర కాలిన డీజిల్ ఉంటుండే అన్నమాట. ఆ కాలిన డీజిల్లో 2-3 బట్టలు వేసి నానబెట్టి ఉంటుండే. కొన్ని బండ్లకు కూడా బండ్లకు పైన ఎక్కడో దగ్గర కింద ఆ ఆమ్దమో నూనె అంటారు, ఆమ్దం నూనె ఏం చంద్రమౌళి సెట్ కందెన అంటారు, నల్ల కందెన. ఇప్పుడు ఆ కందెన రంగుల పండుగ ఆడేటప్పుడు చూస్తున్నారు అక్కడక్కడ కలర్లు ఆడతారు చూడు, హోలీ అప్పుడు అది పోతే అంటిస్తే రాదన్నమాట. కొందరు వాడుతుంటారు ఊర్లలో అట్లా. అయితే కందెన బట్టలు వేసి ప్రతి బండిలో ఉంటుండే, ప్రతి బండికి ఎద్దుల బండికి వెనకలు కట్టేస్తుంది. ఎప్పుడు కిర్ర అంటుంటే ఆ చక్రం మధ్యలో ఆ ఐరన్, ఒక రాడ్ ఐరన్కు చక్రం ఉండదు కదా, ఆ ఐరన్లో వేసేస్తారు. వేయగానే అస్సలు శబ్దం రాకుండా ఒక్కసారి వేస్తే మళ్ళీ వారం రోజుల వరకు ఉంటుండే అన్నమాట. అట్లా అది ఎండిపోయింది అనుకో కిర్ర 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 శబ్దం వస్తుంది. ఇప్పుడు కూడా నేనేమంటున్నా అంటే ఇక్కడ కిర్ర కిర్ర అనకుండా ఎప్పుడు లైవ్లో ఉండేటట్లు అది ఉండేటట్టు ఏం చేయాలనేది మీరు చేయండి. ఇవాళ డాక్టర్లు ఏం చేస్తాడు, మొత్తం అరిగిపోవాలి, వాడు నా దగ్గర రావాలి, నేను వేయాలి, అరగకుండా అయిపోద్ది అనేటటువంటిది సైన్స్ టెక్నాలజీ వస్తుంది. టెక్నాలజీలో అరగకుండా పోవడానికి కూడా ఉంటున్నాయి, కానీ మనం తెలుసుకుంటలేము. అరగకుండా ఇది చేయాలి, ఇది తినాలి, ఈ టాబ్లెట్ తినాలి, ఈ ఫుడ్ తినాలి అని కూడా చేస్తలేము. అరిగినాక వచ్చే కన్నా ప్రివెన్షన్ ఈజ్ బెటర్ దాన్ క్యూర్ అన్నట్లు మనం ప్రివెన్షన్ వైపు కూడా, మీలాంటి వాళ్ళు ప్రివెన్షన్ వైపు కూడా అరగకుండా ఏం తినాలా చిన్నప్పటి నుంచే, బై బర్త్ లేదంటే గర్భంలో ఉన్నప్పటి నుంచి కూడా. ఇప్పుడు మనం గర్భంలో ఉన్నప్పుడే డెలివరీ కాకపోతే 3rd, 4th మంత్ నుంచే హార్ట్ స్ట్రెంత్ కావడానికి టాబ్లెట్ ఇస్తున్నాం, లంగ్స్కు ప్రిపేర్ ఇస్తున్నాం, ఇమ్యునేషన్ మన పుట్టిన తర్వాత ఇమ్యూనిటీ పెరగడానికి కడుపులో ఉన్నప్పుడే మనం అన్ని స్ట్రెంత్ చేస్తున్నాం. అట్లా మనది ఒక రీసెర్చ్ ల్యాబ్ కూడా ఉంది, SVS పెద్ద రీసెర్చ్ ల్యాబ్. అది ఇండియాలోనే బిగ్గెస్ట్ రీసెర్చ్ ల్యాబ్, చాలామంది తెలియదు. అక్కడ మనం కరివేన్ దగ్గర ఉన్నది. మనమే గుర్రాలు, పాములు, తర్వాత ఎలుకలు, కోతులు రకరకాలతో ప్రయోగం చేసి మనమే అవి దాని ద్వారా రీసెర్చ్ చేస్తున్నాం మనం. కనుక ఇవాళ రేపు ఎన్నో అద్భుతాలు, ప్రాణం తప్ప అద్భుతాలు మనం సృష్టిస్తాం. ఓ డాక్టర్స్ మేము అక్కడి నుంచి వచ్చిన మళ్ళీ ఫోన్ మాట్లాడుతున్నాం, ముచ్చట పెడుతున్నాం. అక్కడ లైవ్ ఆపరేషన్ అయితే తెలియదు కదా, అదైతే మాత్రమే మాట్లాడండి. దయచేసి లైవ్లో మీరు ఏమైనా అడ్వైజ్ చెప్తుంటే మాత్రం మాట్లాడండి. ఫోన్ ఎన్నో కనుక్కుంటున్నాం మనం, ప్రాణం తప్ప. ఈ మధ్యకాలంలో యంగ్ కనపడడానికి కూడా, అంటే 80 ఏళ్ళలో ఉన్న వాళ్ళు 30 ఏళ్ళ కనపడడానికి కూడా కనుక్కున్నారు, సక్సెస్ అయిందని కూడా మనం చూస్తున్నాం. అట్లా కనుక అటువంటివన్నీ కనుక్కుంటున్నప్పుడు ఈ నీ స్ట్రెంత్, తర్వాత మధ్యలో అది ఏమంటారు సార్, అది గుజ్జుని ఏమంటారు, కాట్లేజ్ మెయిన్ కాట్లేజ్ ఎప్పుడైతే పోతుందో రఫ్ అయిపోతుంది. రఫ్ అయిపోయిన తర్వాత స్టార్ట్ అయిపోతుంది. లేదు ఇంప్లాంట్స్ చేస్తే కూడా 10 years అని కాకుండా ఒక 20-30 years స్ట్రాంగ్ అని కనుక్కోండి. మరి 10 years తర్వాత మళ్ళీ ఏనికి రాదంటారు, ఏపీసుకోవాలన్నా వద్దా, మళ్ళీ ఏపీ రాదంటున్నప్పుడు చూద్దాంలే 60 ఏళ్ళకి వేసుకుందాం, 70 ఏళ్ళు బతుకునేమో అని 60 ఏళ్ళకి పోతాడు. మధ్యలో వాడు పుసుకోమంటాడు, లేకపోతే సఫర్ అవుతుంటాడు, చాలా సఫర్ అవుతుంటాడు. కనుక దీని మీద ఇంకా రీసెర్చ్ చేయాల్సిన అవసరం ఉంది, ఇంకా అడ్వాన్స్ టెక్నాలజీ చేయాల్సిన అవసరం ఉంది. వరల్డ్ వైడ్గా ఎక్కడ అడ్వాన్స్ టెక్నాలజీ ఉందో దాన్ని మన SVSలో దయచేసి ప్రవేశపెట్టాల్సిన ఇది ఉంది. SVSకు హైదరాబాద్ నుంచి వచ్చిపోయినప్పుడు సంతోషపడుతుంది సార్. మీరు ఎక్కువ ప్రాక్టీస్ అక్కడ చేస్తున్నారు, ఎక్కువ మీరు ఇక్కడ చేసి పేషెంట్లు ఇక్కడ తిప్పాను. హైదరాబాద్ నుంచి SVSలో చేసుకొని పోతున్నాం, SVSలో రెస్ట్ తీసుకున్నాం, SVSలో ఉండి వచ్చినాం అనేది రావాలా. మీరు ఎక్కువ అపోలోలో చేస్తున్నారు, మొత్తం అపోలోకి పేరు వస్తుంది, మా SVSకి వస్తలేదు. సగం ఇక్కడ కూడా చేయండి దయచేసి, ఇక్కడ కూడా చేస్తే మాకు పేరు వస్తుంది. కనుక ఈరోజు హైదరాబాద్లో లేనివి మహబూబ్నగర్లో ఉన్నాయి. హైదరాబాద్లో ఉన్నాయి, మహబూబ్నగర్లో ఉన్నాయి. హైదరాబాద్లో లేనిది ఏదంటే ఇప్పుడు మొన్ననే మేము 26,000 ఎకర్స్లో జంగల్ సఫారీని స్టార్ట్ చేసినాం. ఒక 8-9 ఇయర్స్ మేము స్ట్రగుల్ చేసి చాలా బోర్లు, సోలార్ బోర్స్ చేసి, ప్లాంటేషన్ చేసి, సీడ్ బాల్స్, డ్రోన్స్ కెమెరా ద్వారా సీడ్ బాల్స్ చేసి చాలా చెట్లు పెంచినాం. దట్టమైన అడవి అయింది ఆ ఉదండపురం రిజర్వాయర్ నుంచి. ఇప్పుడు ఎప్పుడైతే అడవి అయిందో అంతకుముందు కుందేలు కూడా ఉండకుండే ఇప్పుడు 11 చీతా వచ్చినాయి, టైగర్స్, తర్వాత ఎలుగుబంట్లు వచ్చినాయి. డిస్కవరీ ఛానల్లో వెహికల్ 2 తెచ్చి స్టార్ట్ చేస్తాం అక్కడ. హైదరాబాద్ లేదు అది. ఇండియాలో బిగ్గెస్ట్ ఎకో పార్క్ 2097 ఎకర్స్లో ఇక్కడనే ఉంది, స్టార్ట్ చేస్తాం. తర్వాత ఇండియాలో బిగ్గెస్ట్ ఎనర్జిక్ పార్క్ లిథియం ఎనర్జిక్ పార్క్, అది మహబూబ్నగర్లోనే 400 ఎకర్స్లో స్టార్ట్ చేసినాం. ఒక అమరాజ గ్రూపే 10,000 ఎంప్లాయ్మెంట్ ఇస్తుంది, స్టార్ట్ అయింది అది. తర్వాత తెలంగాణలో వన్ రోప్ వే మన్యంకొండ వర్క్ స్టార్ట్ అయింది. అట్లా చాలా ఒక 10 టార్గెట్ పెట్టుకున్నాం. 10 హైదరాబాద్ లేని ఉండాలా, తెలంగాణలో లేని ఉండాలా, ఇండియాలో లేని ఇండియాలో టాప్లో ఉండాలా అనే దాని మీద పెట్టుకున్నాం. మీరు కూడా మెడికల్ రంగంలో కూడా ఏదో ఒక ఫీల్డ్లో ఇక్కడికి వచ్చి పోవాలంటే ఎట్లా చేయండి. రీసెర్చ్ ఇన్స్టిట్యూషన్ కూడా ఇంకా స్ట్రెంథనింగ్ చేయండి. మా వంతు సహాయ సహకారం మీకు ఎల్లప్పుడూ ఉంటుందని చెప్పని. డాక్టర్ అంటే దైవానికి ప్రతిరూపమే డాక్టర్. దేవుడు ఎట్లుంటారో తెలియదు, కానీ ప్రాణం పోయేటప్పుడు డాక్టర్ నిర్లక్ష్యం చేస్తే పోతుంది, జాగ్రత్త వహిస్తే ప్రాణం ఉంటుంది. అంటే మీ చేతుల్లోనే ఉంటుంది. ఆపరేషన్ చేసేటప్పుడు ఫోన్ వచ్చి నేను పట్టాను అనుకో పాయ కింద, ఆపరేషన్ చేసేటప్పుడు బతకాలనుకున్నాం అనుకో బతుతాడు. కనుక దయచేసి మీరు ఇంకా ముందుకు పోవాలని, SVS ఇన్స్టిట్యూషన్ ఇంకా ఫ్యూచర్లో ఇంకా గొప్పగా ఎదగాలని చెప్పి, మన మెడికల్ రంగంలో ఇంకా ఎన్నో విజయాలు సాధించాలని చెప్పని. హైదరాబాద్ అనేది గతంలో ఒక జిల్లా అనుకునేది హైదరాబాద్. ఇప్పుడు నా టార్గెట్ ఏంటంటే హైదరాబాద్ ఒక జిల్లా కాదు, మనం అనుకుంటూ జిల్లా. ఫారిన్ నుంచి ఎవడొచ్చినా కానీ హైదరాబాద్ ఎయిర్పోర్ట్లో దిగి అక్కడ ఉప్పలు పోవాలంటే 2 గంటలు పోవాలి, బీచ్ వెళ్ళాలంటే 2 గంటలు పోవాలి, ఇక్కడ పోవాలంటే గంట అవుతుంది. హైదరాబాద్లో ఇది కూడా గంట. అందుకే జడ్చల్ టు మహబూబ్నగర్ కూడా రోడ్ బాగా చేస్తాం. ఇంకా అవతల ఎయిర్పోర్ట్ ఇక్కడ కూడా మళ్ళీ ఇంకో లైన్ వేస్తూ ఉన్నారు. మెట్రో స్టేషన్ కూడా షాద్నగర్ వరకు శాంక్షన్ అయింది. ఇన్ ఫ్యూచర్లో మా టార్గెట్ ఐటీ టవర్ వరకు చేయాలని ప్లాన్ చేస్తున్నాం. అప్పుడు 30 మినిట్స్లో మన ఎయిర్పోర్ట్ వెళ్ళిపోవచ్చు. అక్కడ ఐటీ టవర్ టు మన దీనికి కూడా బైపాస్ కూడా 100 ఫీట్ రోడ్ కనెక్టివిటీ ఇస్తున్నాం, కొత్తది. మళ్ళీ ఇప్పుడు ఈ రోడ్డు ఉత్పూర్ రోడ్ కాక ఇటు నుంచి పోవడానికి కూడా ఇంకోటి ఇస్తున్నాం. కనుక ఇది ఒక హైదరాబాద్లోనే ఉంది అనుకోండి, మెడికల్ కాలేజ్ హైదరాబాద్లోనే ఉంది అనుకోండి, హాస్పిటల్ కూడా హైదరాబాద్ ఉంది అనుకోండి. ఫ్యూచర్లో మన ఒక 375 మెంబర్స్ హైదరాబాద్, మన తెలంగాణ, ఆంధ్రప్రదేశ్ డాక్టర్స్తో ఒక కాన్ఫరెన్స్ చేసినాం మేము. వరల్డ్లో కొంతమంది డాక్టర్స్ని యాడ్ చేసి విదేశీ టూరిజం, మెడికల్ టూరిజం డెవలప్ చేయాలని చెప్పి. ఎయిర్పోర్ట్ నుంచి ఇప్పటికీ యశోద, అపోలో వస్తున్నారు కదా, ఇక్కడ కూడా మహబూబ్నగర్లో కూడా చేసేటట్లు చేయాలని. ఇక్కడ కొన్ని హోటల్స్ స్టార్టర్ ఐటీ టవర్లో, ఇక్కడ బస్ స్టాండ్, పాత బస్ స్టాండ్, మన పాత కలెక్టరేట్ దగ్గర కూడా చేస్తున్నాం. అట్లా ఆల్ ఫెసిలిటీస్ ఉంటాయి. చుట్టుముట్టు రాష్ట్రాల వాళ్ళు కూడా ఇక్కడ వచ్చేటట్లు దృష్టి పెట్టుకొని మీరు ముందుకు పోవాలని చెప్పని. మీ కార్యక్రమం గురించి నేను సార్ సీఎం గారి దగ్గర ఉన్నా. జస్ట్ ఈ కార్యక్రమం చెప్పిన మా అన్నోళ్ళకి టైం ఇచ్చిన. నలుగురం కాదు, మేము 5 మంది అన్నదమ్ములు అనుకుంటాం కూర్చున్నప్పుడు, ఎప్పుడన్నా దావత్లో కూర్చున్నాము. అయితే మరి మా తమ్ముడు రాలేదనుకుంటారు, రావాలి ఖచ్చితంగా అని చెప్పి వచ్చిన. మళ్ళీ మీది ఏదైనా బాధ్యత అప్పచెప్తే ఖచ్చితంగా వాళ్ళకు నేను నా సహాయ సహకారాలు అందిస్తానని చెప్పని. బయట స్టేట్ వాళ్ళని కూడా ఇక్కడ వచ్చి చదువుకునేటట్లు కూడా ఏర్పాటు చేయాలని. మన వాళ్ళు కూడా ఎక్కడైనా బయట చదువుకునేటట్లు SVS వాళ్ళకు స్టూడెంట్స్, పూర్ స్టూడెంట్స్ ఉండి చదువుకోవాలంటే కూడా వాళ్ళ గురించి కూడా నా వంతు సహాయ సహకారాలు అందిస్తా అని చెప్పని. మహబూబ్నగర్ జిల్లా ప్రతిష్ట, మహబూబ్నగర్ ప్రతిష్ట ప్లస్ రాష్ట్ర ప్రతిష్ట, ఈ కాలేజ్ ప్రతిష్ట పెంచే వ్యక్తులకు ఎవరికైనా నా అంత సహాయ సహకారం ఉంటుందని చెప్పి మరొకసారి మీ అందరూ కూడా తెలియజేస్తూ, గొప్ప డాక్టర్లుగా ఎదగాలని చెప్పి, మంచి పేరు తెచ్చుకోవాలని చెప్పని మళ్ళొకసారి మీ అందరి మనస్ఫూర్తి కోరుకుంటూ జై తెలంగాణ.
I think, thank you very much. I think it was, we really very privileged, proud to have you. మీరు అన్నట్టుగా ఇప్పుడు హైదరాబాద్ నుంచి పేషెంట్స్ వస్తున్నారు. ఈ రోజు చేసిన ఆపరేషన్లు కూడా హైదరాబాద్ నుంచి వచ్చిన వాళ్ళు ఉన్నారు. ఎంఆర్ఐ స్కాన్ కూడా చాలా మంది వస్తున్నారు. సో మీరు అన్నట్టుగా హైదరాబాద్కే ఎస్విఎస్ వన్ ఆఫ్ ది బెస్ట్ సెంటర్స్ గా చేస్తాము ముందు. అందుకొరకు మీ దగ్గరికి వచ్చి మీ హెల్ప్ తీసుకుంటున్నాము. ఇప్పుడు
ఒకటి ఫ్రీ అన్నందుకు వచ్చారు వాళ్ళు, ఇవాళ డిస్కౌంట్ అన్నందుకు వచ్చారు కాకుండా అందరూ కాస్ట్లీ పేషెంట్ రావాలి. అక్కడక్కడ కొంచెం అడ్వర్టైజ్మెంట్స్ కూడా పెట్టాలా, ఎయిర్పోర్ట్ దగ్గర బయట అక్కడ ఎస్విఎస్లా మీరు ఎన్ని ఆపరేషన్ చేసిండ్రు, ఎన్ని 50,000 10,000 20,000 ఆపరేషన్స్ చేసిండు. 20,000 సక్సెస్ఫుల్ ఇన్స్టిట్యూషన్. మీ ఫోటో పెట్టి ఇన్స్టిట్యూషన్ పెట్టి పెట్టాలి. హైదరాబాద్లో మెయిన్ ప్లేస్లలో చెప్పుకోవాలి మనం. ఏదైనా కానీ జాన్సన్ అండ్ జాన్సన్ పబ్లిసిటీ చేస్తున్నందుకే జాన్సన్ అండ్ జాన్సన్ పడుతుంది. ఇప్పుడు మెరిల్ అని చెప్పి పెట్టినందుకే మెరిల్ పడుతుంది. జాన్సన్ అండ్ జాన్సన్ మెరిల్ ఎవరు చెప్పకుండా ఒకటి డాక్టర్ చెప్తే కాదు, మనది కూడా మనం చెప్పుకుంటేనే అవుతుంది.
నేను ఇప్పుడు కృష్ణారెడ్డి గారు ఫెలిసిటేట్ చేయమని, మినిస్టర్ గారిని ఫెలిసిటేట్ చేయమని వెంకటరెడ్డి గారు అండ్ రామరెడ్డి.
మళ్ళీ మన శ్రీనివాస్ గౌడ్ గారు తప్పకుండా మళ్ళీ గెలిచి ఈ ఎలక్షన్ లో గెలిచి మనకు ఆరోగ్య శాఖ మంత్రిగా రావాలని ఆ భగవంతుని కోరుకుంటున్నాను. విష్ హిమ్ ఆల్ ద బెస్ట్. హెల్త్ మినిస్టర్ గా రావాలని మనం కోరుకుంటున్నాము. చాలు.
లేలే ఎందుకు రావాలి అని అడుగుతున్నామంటే, మొన్న మాకు ఒక సర్ప్రైజ్ ఇన్స్పెక్షన్ జరిగింది. సో ఒక ఇన్స్పెక్టర్ 10 ఏళ్ల కింద వచ్చిన ఆయన వచ్చిండు. ఎందుకు అడ్రస్ అడగడానికి లేదు వాళ్లకు. సో వచ్చి మన జడ్చర్ల దాటిండు. ఆయన దాటి రోడ్డు చూసే డ్రైవర్ రాంగ్ రూట్కి వచ్చిన వెనుకరా, ఇది కాదు మహబూబ్నగర్. నేను ఎన్నిసార్లు చూసినా ఇక్కడ ఒక్క చెట్టు లేకుండే, ఒక్క రోడ్డు లేదు. ఇప్పుడు ఇది ఎట్లా ఉంటుంది అని చాలా పరిశాన్ చేసిండు. ఖచ్చితంగా బలవంతంగా ఇడికొచ్చి, అరే ఏంది ఇంత మారిపోయింది మహబూబ్నగర్, మా ముందు చూస్తే అది ఏదో అమెరికాలో ఉన్నట్టు అయిపోయింది మా రోడ్డు. సో మేము చాలా థ్యాంక్స్ మీకు. వాటరు, చెట్లు, ఎక్కడ చూసినా పచ్చదనం. రోడ్లు, మన బైపాస్ అంటే అది మనకు పెద్ద మన వరం లాగా అయిపోయింది. సో చాలా చాలా బాగా చేశారు. మళ్ళీ వచ్చి ఇంకా బాగా చేస్తారని మేము కోరుతూ ఆల్ ద బెస్ట్. అండ్ మీరు పర్టికులర్గా వచ్చినందుకు చాలా థ్యాంక్స్. మా ఇన్స్టిట్యూషన్ తరఫున, మా డాక్టర్స్ తరఫున ఆల్ ద బెస్ట్. మరి
పెద్ద స్క్రీన్ పెడుతున్నాం అసలు.
Can we have the screen back, please? Live. Signal. Audio visual. Theater. Can we have the screen back, please? Hello, can you hear us, sir? Hello, can you hear us? Dr. Chandrasekhar, sir, can you hear us, please? Audio visual guys, please. Hello. So JK sir, can you please walk us through where are we right now?
దగ్గరకు వస్తుంది మాస్క్ ఆడియో రావట్లేదు
Hello, can you hear us?
yes we can hear you
Okay.
Yeah.
Are we starting the next knee, sir?
yes
Okay, sir, please.
we just we are just deflating the right side.
Okay, sir.
It's a bilateral knee, so we're ready to start the left side now.
Okay.
So we've actually repeated a second shot of antibiotic
Okay.
because my principle is if any surgery goes beyond 2 hours, then you need to give a second dose prophylactic antibiotic.
Yeah. Definitely, that's well taken points.
Yeah. And before inflicting the tourniquet, I'm going to give the shot of antibiotic now.
Okay.
So it's more or less symmetrical arthritis to the other side. It's a
Okay.
medial compartment arthritis. So if we can show the X-ray, please. So there's not much of fixed flexion deformity. There may be a varus about 5 to 10 degrees max.
Yes.
Okay. There are some osteophytes on the medial side and the lateral side as well. So tourniquet ready now? Yeah. Can you inflate the tourniquet, please? Tourniquet. Yeah, inflate. Glove change, yeah? Can you change your glove? Yeah, change.
So you take the midline incision, sir?
Yes.
So there's a latest paper that came out, I think 1 or 2 years ago from Japanese Journal of Orthoplasty talking about lateral incision, which says that less denervation and patients can kneel and will not have any pain. So does that kind of really add value to our practice, or still I think midline incision is the way to go?
Well, again, you need to have long-term data with regards to that. And at the same time, it's a learning curve. Okay.
Yeah.
So you have to follow the steps, what you are comfortable with, what you've been trained in. Okay.
Yeah.
So I don't know about this paper. So what is the evidence for that? I mean, is it showing significant advantage?
Yeah. So it's a randomized control trial comparing the midline incision versus lateral skin incision. So in that, after 1 year, patients had a better kneeling and also in terms of denervation, also it was less.
What do you mean by lateral? Can you hear me?
Yeah, we can hear you, sir.
I mean, ఇక్కడ touch.
Uh, 10 seconds లోపల దాన్ని అవుతుంది కదా 100 చేసి So you go with medial parapatellar, sir. Sir Chandrasekhar, sir, can you hear us? Sir, can you hear us?
Can you hear me?
Yeah, please.
Okay. Normally I do a subvastus or a midvastus approach.
Okay.
But for the sake of the live surgery, I'm doing a medial parapatellar.
Okay. So do you remove the anterior fat pad?
I do routinely, yes.
Okay. So some surgeons believe that taking the fat pad off might lead to anterior knee pain. So, but I think there's no big difference in the randomized control trial. So as you rightly said, it doesn't make much difference whether you leave it or you remove it.
The question is adequate visibility. Especially with anterior cortex.
So we can't hear you clearly. I think it's a bit low.
Visibility is.
Yeah, we can hear you.
Visibility is more important. Different. I do a release in with the knee in extension. You're already in extension. With regards to while the right knee was being done.
Yeah.
So with regards to the medial soft tissue release, normally I restrict myself up to the equator in the coronal plane.
Okay, sir.
Unless it's like a significant varus with a severe varus where you have to go beyond the
Audio visual guys, can you please check? Sir's voice is going up and down.
Nibbler. Can I have a nibbler, please? So I'm just going to external rotate. So while doing this, we have to externally rotate the tibia.
Yep.
So that we can relax the patellar tendon and
okay,
less chance of patellar tendon avulsion. Okay.
Okay, sir.
Right. Can I have spikes, please? And normally I don't invert patella.
Okay.
One more spike. Is everything clear now?
Yes, we can see you clearly.
So because I'm normally a CR guy, but I think there's CR available today. So we're going to do a PS. So I will ACL and CL one.
So, like any particular preference why you go with CR, sir?
That's what I've been trained with, and I've had good results with CR. But if you look at the literature, there's no difference between CR and PS.
Yeah, you're right, sir. There's no difference between whether it's PS or
Yeah.
CR. And you start with the femur or with the tibia, sir?
Then the tibia, I do a modified gap balancing technique.
Okay.
So I make sure that I get adequate extension, knee extension first.
Okay. So you remove the osteophytes on the medial side.
Yeah. I've removed some of the osteophytes. So to check the gap after I've done my distal femur and the proximal tibial cut. Okay.
Yes.
So what I do is I normally mark the Leo Whiteside line, which is the deepest point of the trochlear groove. And then roughly check where my transepicondylar axis is.
Yeah.
Can you see that?
Yes, sir. We can clearly see that. So it's perpendicular to the transepicondylar.
With my distal femur cut entry hole.
Yep.
One second. Make sure that the cutting jig is flush with the distal femoral condyle.
Yeah.
Okay. Primary. Okay, and I have the angel wing. So this cut, a primary cut should normally go through the notch.
Yeah.
So if you are able to get through the notch, that means your cut is adequate enough.
Yeah. Okay. So that is 9 mm cut, sir?
Yes.
Okay.
A corner. Corner. Take a line back here and retract the skin. Lakshmi. Okay. Malatune. Yeah, give me the pin. The bunker line, please. Yeah. Okay. That's fine. Give me a nibbler, please. Remove those osteophytes. Like that.
So you go with the extension gap first.
Yes.
And then the flexion gap.
You have to sublux properly. Yes.
Generally, you don't put tourniquet, sir, or you use tourniquet in all
actually,
cases?
the tourniquet was inflated, but for some reason it's
okay.
Bleeding quite heavily. Yeah. So I'll just cut the posterior root of the lateral meniscus. So that will help with subluxing the knee completely. Okay. Yeah.
In what way it will help us, sir?
So no, for subluxation.
Yeah, okay.
Is everything clear there? That's it. Don't do anything. That's motion. Teja, is everything clear?
Yes, sir.
Yeah. So there was one more question which was asked about the tibial slope.
Yes, sir.
With this particular design, the Gen 2.
Yes, sir.
Basically, there is an inbuilt 3-degree slope in the implant.
Okay. Yes, sir.
Okay. So on the tibial base plate itself.
Yes.
And also there is an inbuilt slope in the insert as well.
Okay, sir.
So both of them add up to 6 degrees.
6 degrees.
Okay. So on top of it, if you put around 3 degrees, so that comes to around 9 degrees of slope.
9 degrees of slope.
Posterior tibial slope. Okay.
Okay.
కొంచెం లూజ్ చేయండి. ఎంత ఉంది అది సీతారాం గారు చూడండి పెట్టండి అడ్జస్ట్ చేసేవారు. Hold the foot in this position. So while doing the tibial resection, I keep it at 90 degrees. 9 mm.
So you take at 8 mm cut on the
9 mm cut.
9 mm cut.
With reference to the lateral condyle. Because that's the least worn out area. Yeah, okay. Happy with that. So that's touching the highest point of the lateral tibial condyle. And this is pointing towards the center of the ankle. Is everything clear there?
Yes, sir.
Okay.
You can clearly hear.
So one more check. Can I have the this thing, angel wing? We'll just check through how much we are resecting on the medial side.
So we'll make sure that is in line with the medial tibial plateau.
Yes, correct. So I'm pretty satisfied with the amount of cut there. Okay. Osteo.
So do you think when you use manual jigs, would it kind of give the accurate cut that we want? Do you see sometimes a bit of play can change the slope or make the cut?
It can actually change because there are surgeons who sort of undercut it. So it depends on how you play along with your this thing hand. Forceps here. That's one perceived advantage with technology.
Yes, sir.
But having said that, I don't think there is much difference in terms of functional outcome between robotic and manual.
Yeah, you're right, sir. I think even the midterm results that have been published also talks about more of short-term benefit rather than long-term benefits. But definitely, I think in terms of cutness, accuracy of cuts and all, I think this like play and the change of thickness would not be kind of seen in the robotics.
Okay, easy. Yeah, take it off. Okay, can I have the spacer block? So this is a 9 mm spacer block.
Yes, sir. We can see that.
Still a little bit tight on the medial side.
Yeah.
I'll just do a little bit more, please.
Yeah, sure.
So that it will be balanced in extension.
Yeah.
Which I think if I remove them, it will stop the tenting of the MCL and the tightness on the medial side.
Yes, sir.
So this is the modified gap balancing technique, curved osteotomy one.
So you release on the medial side as well as the posterior medial corner.
Yes, yes. So that we will be able to achieve full extension and also balancing in the medial lateral plane.
Yes.
Okay. So that has opened up a little bit.
I think now the spacer box looks like it's going through.
Now we are happy with the extension there.
Yes, sir.
Can you see that?
Yes, we can see that.
Yeah. In extension, okay?
Yes, sir.
Progress through the case. Okay. So
Yes.
we'll remove the femoral pins now.
Yes, sir.
Because my distal femoral cut.
Yes.
I don't think I'll check distal femur.
So generally, if the extension gap is a bit tight, you don't usually recut the tibia, sir, or you just made
No,
sure.
no. If the extension gap is tight because we don't know about the flexion.
Yes. So you always try to release and make sure it is balanced.
Yeah, unless it is tight both in flexion and extension.
Then you cut the tibia.
Then you have to address the tibia.
Yes, sir. Yes.
So at this stage, it is reasonably okay. So even if the extension space feels a little tight later, you can achieve that with posterior release.
Yes, sir.
If there are any posterior osteophytes.
Yes.
After you have completed your femoral cuts.
Yeah.
You will be able to address that.
Yeah, you're right. This is an anterior referencing system.
Yes. They have both anterior and posterior referencing.
Okay.
This is a posterior referencing.
Okay.
Pins. Now it is flush. Okay. Size atento chindi. Take a line back, retract here. Trios. It's coming to 3. What size? 4. It's coming to 3 actually here.
Yes, sir.
Okay. So this. Pin puller.
Would like to invite Dr. Srinivas Thati sir onto the stage to moderate the surgery. Dr. Chandrasekhar sir, Dr. Srinivas Thati is
Hi,
here.
Srinivas.
Yeah, he's joining the stage.
Yeah. Hello, Srinivas.
Hi, Dr. Chandrasekhar. How are you
Hi,
doing?
how are you?
I'm good, thank you. How's it going?
Yeah, not too bad. Thank you. So one more check again to check how my anterior cut is. So it has measured size 3. This is Gen 2 system which we are using here. Yeah, I'm happy with the anterior cut there. It's not notching. So take one more Langen back there and retract it. If they can show on the top here, we got a perfect grand piano there.
Can someone zoom on the top, please? I think it has to come from.
Can
further.
someone show the grand piano sign here? Here. I think you need to take off. Is that clear?
Zoom in, please.
Can you zoom there?
Yeah, we can see that, sir.
Nicely flush with the anterior cortex.
Yes, we
And
can
the good
appreciate
grand
that.
piano sign.
Yes, we appreciate that.
Right. So flex it a little bit there. So after I do my anterior cut, I'll take the posterior cut. ఇక్కడ skin touch. ఇక్కడ lying back. Yeah, thanks. Puller. Curved osteotomy. hold the foot. Infiltration ఏమైనా local coccus. Lift the femur up. Touch. Lift the femur, please. Perfect. Nice. Suction. It's a little bit bloody because of the tourniquet.
Yes, Dr. Srinivas sir was asking the same, sir. He was wondering whether the tourniquet is applied or not, but as you said,
No, it's been applied. Yeah.
I do without tourniquet, all my TKRs, majority of them.
Okay.
So I was thinking,
But
you are one of us.
But do you inflate it before cementing, or you just don't apply the tourniquet at all?
No tourniquet at all.
Okay. So do you face
My
any-
tourniquet is the anesthetist.
Okay.
I would request the anesthetist to keep the systolic around 100.
Yeah.
That makes a huge difference.
Actually, there is
Sir,
good evidence to show that not using a tourniquet actually helps with postoperative pain. Maybe take a line back here.
Certainly, a lot of benefits as a non-tourniquet surgeon, I can say. But yeah, that is debatable. But if you look at the evidence,
Yeah.
there is a very good evidence to say that post-operative pain is comparatively less. The swelling will be less. And there are some
that.
studies to show
Yeah.
early mobility is also better. I think recently there is a lot of shift from tourniquet to no tourniquet surgeons.
Yeah, a lot of surgeons have actually shifted to without using a tourniquet now. Going to remove the remnant part of the PCL. Okay, so I'm pretty satisfied with my flexion gap as well.
Yeah, looks good.
Retract properly then. Okay. Just checking my mediolateral placement of the trial. Yeah, pin please. Alex.
Rotation wise, do you go with 3-degree external rotation or do you change according to your the
Well, most of by default, if it is a manual, yes, 3 degrees. Mallet. Pike talga. Lift please. Retract there. Retract there. Lift. Yeah. Nibbler. Trial istara. Yeah. Yeah. Okay. Nicely sitting flush all around the femoral component.
Yeah.
And the same with the tibia. It went in quite nicely. Okay, can you see that?
Yeah, looks good.
Yeah, take it off. Let's see how my extension space is. I'm pretty satisfied with my extension space as well. You're able to get full extension there. Okay. Mallet even.
You haven't taken any of the medial osteophytes right yet from the tibia, or you have?
I did at the beginning itself.
At the beginning itself. Okay.
I removed tip and the femoral osteophytes at the beginning only.
Okay. Yeah, looks pretty good.
I'm able to get full extension, and as you can see, the tracking is good.
Yeah, you don't have to use any thumb. Yeah.
So I think we can with that. I'll remove.
How do you assess your tibial rotation? Do you do any marks on the tibia?
Yeah, when I prepare the tibia, I'll show that. I haven't done the tibial preparation as yet.
Okay.
But as you can see here, there's no lift off. So it's not tight in flexion.
Yeah, yeah.
So if it is tight in flexion, the tibial component tends to come out.
Correct.
So it is pretty stable even with complete deep flexion as well.
Yeah.
So it is not tight in flexion, not tight in extension. We are able to get full extension gap. So full extension, I mean. And it is stable in medial lateral planes.
Yeah.
So on the whole, I'm quite satisfied with my cuts now. So I don't need to do any more releases as such. So it's just a matter of preparing the tibia and cementing them. Tight spike. Normally evert the patella. So some of the surgeons may find it, the assistant, they find it little different. It's not difficult, but different. Mop event. Yeah, little bit. Small osteophyte is there, which I will remove. Flex. Push it. Yeah, nice. Yeah. Can I have the other spike, please? Yeah, remove that. Yes. Very good. That's good. If you flex it and then push it a bit further, that's it. Ante. Give me the pin, please. So you were asking about the tibial rotation. Normally what I do is, I reference it with the lateral side. Can you hear me?
Yes, sir. We can hear you.
So I look at the posterolateral corner of the implant. If it is flush with the lateral posterolateral part of the tibial condyle or not, and then check the anteromedial corner of the tibia as well. As you can see, it is nice and flush with this corner.
Yes.
And then the third checkpoint is the tibial tubercle. I don't do any marking as such, but as you can see here, it's at the junction between the medial 1/3 and the lateral 2/3 of the tibial tuberosity.
Yes, sir.
So if you are able to, perfectly align it with the posterolateral and the anteromedial parts of the tibia, that means your rotations are fairly correct.
Yes, sir.
Okay, go ahead. Okay. Can I have a saw? Very. So that's why I tend to, and with this gent, it narrows, the keel. So what I do is normally I just a little bit initially, and then use the keel punch.
Chance of stress fracture, sir?
Yes, yes. Because if you try to bang it on the sclerotic bone, it can easily crack. Okay. Extract, sir. Can I have a 2.5 drill, please? And usually I put drill holes on the medial side, which is sclerotic. That's for the cementation.
Yes, sir.
Okay. Cement open just come. And with regards to implantation, I do it slightly differently in when it comes to PS. What I do is, because I'm a CR used to putting tibia first, even with PS, I put a CR poly first and then finish the femur, let it set completely. And then once it is set, then I sublux the tibia and insert the actual poly.
Okay, sir.
Yeah, wash this. Yeah, components. Yeah, 9. Okay, fine. Yeah. Any more questions? Section.
You do patella or only you're a non-patella resurfacer?
I never resurface the patella.
No resurface the patella. Okay.
I mean, in the UK, my consultant used to always resurface the patella.
Right.
But so far, touch wood, I've never had any patellofemoral problems.
Okay.
And again, there is increasing evidence to show that there's not much of a difference
Correct.
in the anterior knee pain.
Correct.
Whether you do or do not resurface the patella.
Yeah. So what are your main precautions to prevent anterior knee pain when you do replacements?
I mean, what I would is take as limited fat pad as possible. Only whatever is necessary. Yeah, mix. That's one thing. And the other thing is with regards to your incision, make sure it doesn't go onto the tibial tuberosity, but slightly medial to the tibial tuberosity.
Correct.
Cocktail ichcheda. Naku trial poly will see CR trial poly. Yeah, well, let's put the spikes. And again, what I've noticed, that if you don't evert the patella, there is less chance of patellofemoral problems.
Right. Yeah, I think there are so many things in knee replacement which are debatable.
Yeah, of course, it is debate. I mean,
from starting from CRPS, patella resurfacing, no resurfacing.
See,
eversion,
again, all these are level 5 evidence. Okay.
Correct.
Yeah, most of these are all level 5 evidence only. So, if somebody says that this is the thing, then I would take it with a pinch of salt.
It's all technique, right? It's how you are used to the technique and how slickly can do.
The knees, what I believe is good soft tissue dissection and balancing, I think, is more important.
Absolutely.
Yeah, lift it up, please. I'm just going to infiltrate some cocktail into the posterior capsule.
Yeah. What do you use for the cocktail?
What they've used, they've mixed them. It's a Ranawat cocktail mixture.
Right.
Okay. So lift chain. Let's see if there are. Just a final check. I'm seeing if there are any osteophytes. I'm pretty satisfied. There's absolutely no osteophyte posteriorly.
Good.
Can I have change of gloves? Pettis.
What type of cement you're used to?
I'm used to Palcos.
Palcos, okay.
Cement which they're using here. It's in. Like it's in. Try. Trial polygon. Dry mop. Mop. Make sure your tibial surface is completely bloodless.
Correct. cementation of the implants is very important. As long as we get a good cement mantle,
Yeah.
the fixation of the implant will be good. If the mantle is not good, the risk of loosening is pretty high. Early failures can happen. Irrespective of what technique we use, cementing is something every joint replacement surgeon should be perfect with. You agree, Chandrasekhar?
Yeah, I can't disagree anything more than that, because especially earlier we had one cemented hip revision.
Okay.
I think it was there for 20 years. So
Yeah.
if you do a proper cementation, even cemented hips can last quite long and they can match with the uncemented ones.
True. So you're done with the tibial cementation?
Yeah.
Okay.
There and lying back here.
That's very nicely done, Chandrasekhar, without any blood marks onto the cement. So any blood on the cement can increase the risk of lamination within the cement.
Correct.
And that can result in failure, early failures.
Matching. I can see again, if they can zoom it or not, the femur is articular of the tibia. Can you see that poly there? The trial, I mean. Correct. That's what you should be aiming for. Zoom chesara ikkada. Can I have a saline gauze ivandi? Quick. Saline gauze. Srinivas, can you hear me?
Yeah, I can hear you.
Yeah. If they can zoom here.
Yeah.
Zoom onto it here. Retract chain. So it's in the middle there. You come from the top. Is it possible?
Not seen.
Okay.
Yeah, now we can see.
So right bang in the middle.
Yes.
Okay, and nicely balanced mediolaterally. All right.
Correct.
So that's full extension.
Yeah.
Okay. And mediolaterality is there.
Yeah.
Okay. So what I will do now is wait for the cement to set.
Yeah.
Remove any excessive cement in the notch meanwhile. And then once it is completely set, I just sublux the forward and then insert. So that way, less chance of what I feel, because I'm putting my posterior against the femur, the femoral component.
Correct. Yeah, sometimes leaving a bit of cement in there for a PS, I don't think that's a good thing to do.
Yeah.
So you got to have the clear notch.
Maybe cement at the back as well.
Correct.
Not only that, I'll be sort of putting my spike against the femur rather than on the bone, especially in osteoporotic bone.
Yeah.
You will be struggling sometimes to insert the poly.
Correct.
Different surgeons have techniques, but this is my technique.
Yeah, absolutely good. So for the juniors, it's very important that the cement, you have to give enough time for the cement to set properly. If the cement is not completely set, and if we see some doing early closure without cement completely gone off, that can again result in early loosening or early failures. And so it is absolutely important that the cement goes off completely, and then only you can do the rest of the job.
And I feel that axial load gives one of the best pressurizations.
Correct.
Similar to what you do in your cemented hips.
Yeah.
Where you sometimes, after with the cement gun,
I use my thumb to actually pressurize the cement in the femoral canal.
Yeah,
Gives one of the best pressurization. So
true.
this is how is it? Cement? Cement at soft. Okay. Yeah. I think just a couple of minutes and it will be set completely. Brother, ikkada kuchu. Amma, ikkada kuchu. Edana. Can you go for hand? Ma cheyi itu తీసుకురావద్దమ్మా. కింద చాలు. 2 minutes ఆగి ఇచ్చేద్దాం బిఫోర్ క్లోజర్. డన్నా? ఓకే. ఏది? యా, కొంచెం సాఫ్ట్ ఉంది. ఓకే, మినిట్ ఆగుదాంలేండి, వదిలేసి. ఏమైనా సిమెంట్ ఉందా ఇక్కడ? ఏమైనా లోపల హార్డ్ అయిందా? ఓకే, ఫైన్. సెక్షన్ spike. చిన్న గాస్ తీసుకోండి. చిన్న గాస్ సరిపోతుంది ఇక్కడ. జస్ట్ అగైన్స్ ద ఫీమర్. లెఫ్ట్ ప్లీజ్. సెక్షన్. యా, పట్టుకో. Wash event. Hello.
Sir Chandrasekhar sir, can you hear us?
Yeah.
Yeah, so we have Dr. Jay Krishna sir and Dr. Siddharth here.
Yeah.
Probably they can ask few questions regarding the poly insertion and
Yeah, that's what. A mop event.
Dr. Chandrasekhar sir.
Yeah.
So you insert the poly after complete cement.
Yeah, once it is set, I put a CR trial insert initially for pressurization sake.
Okay.
So as you can see, it's the posterior part is completely clean now.
Okay.
There's no cement or leftover cement, blebs or anything there.
Okay.
And I'm able to subluxate it completely. If you are unable to do that, that means it is still quite tight.
Okay.
Done? It's locked now. Okay. Take off everything. Take off everything. So wait.
Can you see that?
Yes,
It
yes.
just
well
went
ready.
in. Okay.
Can you show the stability?
Yeah.
Okay.
Full extension.
Yes, yes.
Tra-
And good tracking.
Stable
Yeah.
in the AP plane. Okay. Happy?
Yes, the FFD is corrected and the VRS is also corrected.
Yeah, it is.
Yes, yes.
Yeah.
Yeah. Thank you.
I can say it's pretty stable. Tibia. Yeah. That's
So Chandrasekhar sir, did you had any experience of MCL avulsion during probably reduction of from flexion to extension after the implantation?
yes. Once I had that.
So what could be the reasons and how those can be avoided, sir? Like,
Well, one thing is one thing is don't leave it too tight. If you are trying to insert something when it's too in a tight situation, then you are likely to cause more more problem. And in that case, it was my assistant actually. So he was doing an overzealous retraction with the Homans. That was the reason in that particular case.
So how did you come out of it? How did you
Well,
repair it or anchors? You used anchors or how did you fix
yes,
it?
I did. I used an anchor and repaired it.
Okay.
There was only one such situation in my experience.
Okay.
sir, and do you put a drain after the for the closure, or
Normally I never use drains, but I think the practice of using drains over here. But in my practice, I never use drains. And in fact, now I've changed to a different unit. But while I was in Medicover, we were using this intra-articular catheter, epidural catheter. So for post-operative pain relief. So we never used drains. We always left a catheter inside for ropivacaine infiltration post-operatively for the first 24 hours. But in my current working place, usual practice is peripheral nerve blocks. They give an IPAC as well as an adductor canal block. So we are not using intra-articular catheters, but still I never use drains actually. If you are able to do good closure, good airtight closure and good compression bandage, I don't think drains would add any more advantage as such.
and do you give transexamic acid after closure of the arthrotomy, sir?
Not after that.
Yeah.
I mean, it's given before
intra-articular, I mean.
No, I don't have any experience with that. Not intra-articular.
I think, thank you so much, Chandrasekhar sir. It was an excellent demonstration and really appreciate your time here.
Thank you.
Now we will move on with the case presentation from Dr. Arun Reddy. Maybe 2 more minutes to go.
Thank you so much. Thank you for patient hearing, and I thank SVS team and KJ Reddy sir for giving me the opportunity.
Yeah, and next we are also lined up with a live surgery with Dr. Sunil Dachapalli sir. It's probably 5 to 10 minutes away, but meanwhile we'll go on with the case presentation.
Okay, thank you.
Thank you, sir.
Okay.
Can the audiovisual guys connect us to Dr. Sunil sir's theater? We would like to know about the case meanwhile, before we set up the case presentation. Dr. Jairam, are you around? Shahrukh, if you are in theater, can you please walk us through the case?
Right. Hi, this is Dr. Sunil Dashpali. Can you hear me?
Yeah. Hi, sir. Sunil, sir. Thank you for joining. Yeah, please walk us through the case.
I can't see who is there. Can I know who is chairing the session?
Hello, Sunil. This is Dr. J. Krishna Reddy.
Hi, Jay.
And we have Dr. Siddharth.
Okay. Hi, Siddharth.
And
Hello,
myself, Dr. Ravi, sir, from Apollo. So we will be taking you through the moderation session and the surgery as well. Please walk us through the case.
Yeah, sure. Now we've got this lady who can see on the scanogram. She's 61-year-old, and you can see what she already had her left knee done with a long stem in the tibia. That gives us actually a clue as to what to plan on the right side. Now it looks so sinister when you see on the right hand side, looks so straightforward. When I first saw, I thought, oh, that's straightforward. But when I saw on the other side, I was like contemplating, why did they put a stem? That's when I was trying to go through very closely. And if you look on the lateral view, not on the scanogram, but there's one more picture there, one more X-ray. There you can see the stress fracture. So probably that could have one of the reasons why they've done this stem on the left side. So I suggest all the juniors not to be very quick in their examination. Now, when I examined her this morning, the area of tenderness was far away from the knee joint actually. She was almost at the level of the hamstrings. I could feel a little bit of bony swelling there, so probably a callus. So that tells us it's not the joint per se. So always when you want to examine the patient, ask the patient to point out with a finger where the pain is. So in this scenario, she has both sides, but more on the fracture area. So as we all know from the literature, when you have osteoarthritis associated with a stress fracture, and you want to plan for a knee replacement with a stem. If it's a younger patient, probably you want to give some rest, some supplementation, and non-weight bearing, that will heal. But in this elderly age group, when they have osteoarthritis associated with stress fractures, you want to mobilize them at the earliest because you already know their bone stock is not as good. So here today we are planning for a total knee replacement with a tibial stem. That's our aim. And we have already measured the distance. As you all know, we want to be at least 2 times the width of the canal where you have the fracture. So I guess we are getting away with about a 100mm stem. So that's the plan now. And my usual approach would be medial parapetala and releasing as required. So I do a combination of gap balancing and also the bone cuts. You can hear me?
Yes, we can hear you. Is there any abnormal mobility at the fracture site?
No.
In the X-ray, we cannot appreciate much actually.
Yeah, true, Dr. JK. We don't have abnormal mobility. It's only tenderness that she has. And the tenderness is more over the fracture side, like I said, and a little bit on the joint.
Okay.
Volume. उनको volume बढ़ा दो ना.
How is the deformity? Is it correctable?
Yeah, I'm just about to show you that. We're just about to finish off draping it. Can you have a bandage or something, please? Thank you. So we are also having a CM on the standby, just in case, because you want to make sure you've achieved the appropriate length to prevent further fractures.
Yes, almost fibula level కు cut. Tibial cut. వాళ్ళు కూడా ఈజీగా పెద్ద పాలు.
Sunil sir, we know that you do robotic knee replacements as well. So, although this is a complex case, but generally speaking, would you go with a mechanical alignment or would you choose to go with restricted or any of newer alignment philosophies for in your practice?
Yeah, even in robotic, my aim would be to go for mechanical alignment because there are lots of things coming up nowadays, the functional alignment and all these things. Now, if you see my robo, it's a handheld Cori. So you have the choice as to what to do. So I would prefer mechanical alignment because it has been proved for long that it's doing well.
Yes, agree with you.
I thought you would ask me a question. Is it Ashish who asked me the question?
So I'm Dr. Ravi, sir. I have asked you.
Yeah. Okay. Hi, Dr. Ravi. I thought you would ask me whether I would go for robotic or conventional in this scenario.
No, I was about to ask, but since I know, so like, please let us know, sir. How would you go with it then?
Well, robotic, the planning remains the same, sir. Because this is like, not image based. My robo is Cori. So what we do is intro, we do that.
Yes.
And then it's quite straightforward. You're doing exactly the same knee replacement. Only thing is you are bridging the fracture.
Yes, makes sense, sir.
Hello, sir. Can you hear me, sir?
Yes.
I'm Dr. Siddharth speaking, sir.
Hi, Siddharth.
What do you think of the opposite side, sir? What do you think of the joint line?
That's a good question. First time, as soon as I saw, they just gave me the scanogram. Unfortunately, I'm not in front of the computer to calculate the angles. So what is your feeling, Siddharth?
Do you think the tibial cut is a little more than what we usually take?
Yes, I thought so. That's
because we're almost touching the fibula head.
The fibula, yes.
Yeah.
Agree with you.
Yeah.
And also the alignment, if you see,
it's still in varus.
A little bit in varus.
Yeah.
Which probably.
But I think the thighs are a little bulky for
Yes,
that lady.
yes.
She would like it that way.
Yeah, true.
She
I
would
mean, you
like
don't
it
want to overcorrect because they're used to that varus.
Right.
So you probably a little bit of varus should be fine.
Little bit of varus or neutral is okay,
Yeah.
but they don't like valgus knees.
And also, if you watch the leg on this side where we are operating,
right, sir,
it's quite short.
Right.
Short by an inch.
Yeah.
So even that's what I'm aiming at, the joint level. So I'll have to plan to bring the joint level to where it is. At the same time, once I correct the deformity, I need to see how much length I achieve. So this is important thing that you explain to the patient, because their expectations would be once you do the operation, there'll be equal length.
Right, sir.
Which might not be the case in this scenario.
Right.
So these are the common problems in US and UK, where if you don't talk to them properly and explain, then they'll be putting all the lawsuits on you. So limited discrepancy is one of the important things you want to discuss with your patient. And also the most important thing, I always suggest everybody is document whatever you talk, just put it on paper.
Right.
That's going to save you. Right. So we're almost draped. Can we have the smart, please? Smart. Yeah, just hold it up. Guys, are we ready with the tourniquet?
Do you, sir, it's Siddharth again.
Yeah, hi, Siddharth.
Do you do scanograms
Yes,
routinely?
I do scanogram for all my joint patients. Because
Okay.
sometimes, see, anyway, all the knee replacements, we should do a pelvis X-ray.
Right, sir.
So a joint
Point-
above and a joint below.
Point well taken, sir. Point well taken. All the younger colleagues should keep it in mind that let us not forget hips while you do a knee replacement.
Yeah.
Especially if the gait is odd, the way the patient walks into the room, if it looks odd, kindly get a pelvis with both hips, see what is happening.
So that makes sense. And also see, instead of doing pelvis, knee, and also ankles, might as well have a scanogram.
Scanogram, absolutely.
Which is cheaper for your patient as well.
Absolutely, sir. Point well taken.
So Sunil sir, can we just quickly wrap up a case presentation in 10 minutes before you expose the joint and start with the cuts?
Yeah, I'll start off with the meantime. I'm going with medial parapetral approach. Yeah.
Sure, sir. We'll join you back soon.
Yeah. Thank you.
Over to Dr. Arun for a case presentation.
Tuniki on, please. Madam, antibiotics in, Franexa in. Thank you. Good to go, no? On.
I would like to invite Dr. Pradeep Reddy sir also to join the stage for the panel discussion, please.
Yeah. Hello, everyone. Welcome, sir. Yeah, so I'm Dr. Arun. I'm a consultant orthopedic surgeon practicing at Continental Hospitals. Actually, it's very nostalgic being here. I'm a postgraduate student in the same college who did my MS from 2014 to 2017. I would say that I'm actually blessed to be trained under Dr. KJ Reddy and Dr. KLJ Rao, Dr. Anjaneyulu sir, and also Mohan Reddy sir. The 3 years of journey is what I am today, and what all the surgeries that I'm doing, much more complex knees and hips, the foundation has been laid at SVS Medical College. That's what I would say, including my colleague, Dr. Ravi, who is also doing extremely well. He's been my colleague and is also my colleague now. Yeah. So Dr. KJ Reddy is also my ex-boss, and I would say he's the mentor and is also one of the reason why I'm standing here in front of you. So coming to the case, so this is a simultaneous management of ipsilateral severe knee osteoarthritis and ununited tibial stress fracture. Seems a very big one, right, Ravi? Yeah. So this is what the title means. Can you see a case, where the knee is totally arthritic and also there has been a stress fracture which has gone into a complete non-union. So this is a brief history. This is a 70-year-old lady. She's unable to bear weight on the left leg and difficulty in walking since 6 months. There was a history of trivial slip and fall 6 months ago at home. She got treated by a quack. And prior to the fall, she has been suffering with bilateral knee pain since many years. So she kept on postponing her surgery because of apprehension towards surgery. She's well. So if you see in this X-ray, in December 2021, there is only a very faint line of fracture there. So somebody has just put a slab and asked to be treated conservatively. Within few months, you can see the X-ray where the small hairline crack has gone into a total complete fracture. And that fracture has now gone into this kind of frank non-union. So how do I go ahead is the important question.
Hello, Arun,
yeah.
can you go back to the, no.
Yes, this one.
Why the fibula fracture?
So this
Why
is
the fibula
yeah.
fracture?
So this is a very interesting thing. Whenever you see a stress fracture, you only see most of the times either in fibula or tibia. This is one such rare fracture where you have seen the stress even in the fibula.
Did she fall down?
No. If you see in the December 2021, you don't see a stress fracture on the fibula. But if you come to Feb 2022, now that fibula was taking the entire stress and now that has gone into fracture. So this is one kind of gross neglect. So how do I, yeah.
Yeah, Arun. What was her ambulatory status before she came to you?
Wheelchair bound.
Wheelchair bound, and what was the ambulatory status at home?
Completely wheelchair bound or with walker.
Non-weight bearing.
Non-weight bearing.
And for how long was she non-weight bearing?
Almost 8 to 9 months.
Okay. Yeah. So now the question is to see for the fitness of the patient to go ahead surgically, right?
Yes.
So one of the main things you should be looking at before touching such patients is DVT.
Sir?
Deep vein thrombosis.
Yes.
In a elderly, in a non-ambulatory patient,
yes.
that is the first thing which is coming to my mind.
Yes.
So have you done that?
Sir, yes, sir, I have done that. But also before going for surgery, do you have anything else in mind, sir? I mean, to the panel members, other than DVT, do you want to rule out anything else?
About the, I mean, general comorbids, if there are any, everything under control or not is the question.
Siddharth, do you have anything on your mind?
Get a vitamin D and correct the vitamin D simultaneously.
And
so that she doesn't land up in these situations again.
Yeah.
And rest is rust. So she has to go mobile.
Before, so what I've done is, before going to the surgery itself, you need to understand why such a frank non-union, right? So there could be it could be a metastasis right in the first place. It could either be a distant metastasis or it could be a local metastasis. So yeah. So first of all, I have done both a local MRI, CT scan, and also a PET scan. We had a tumor board meeting. They also advised to do a PET scan. Was not in my school of thought, but they advised to even to get a PET scan done to rule out the rarest of possibilities, because we have never seen such kind of frank non-unions. We have seen stress fractures, but stress fractures going into a fracture and complete non-union. So I had also ruled out both benign local tumors and metastatic tumors also, and I've also done DVT and all other things, corrected her vitamin D, which is very good point. And that's called preoperative conditioning of the patient. All that has been done. So now how do we go ahead? So should we first fix the fracture with bone grafting, or should we just do that replacement or replacement with plating? What do you think would be ideal?
So I'm completely biased because I've seen this talk of yours before.
Yes.
So I'll hand over the mic to.
Yeah.
Yeah, there's a tricompartmental arthritis.
Yes.
There's a non-union.
Yes.
And what's the age of the patient you said?
70.
So already not walking for quite some time.
Yes.
So the only best bet would be the arthroplasty option. By using what all the bone harvest, bone cuts we get, use it for the non-union and put a stem. That is my plan.
Yes, excellent, sir.
Sir, I would add a plate also to get a rotational stability. The cortex is very thin here.
Yes, sir.
Probably unicortical screws to have a rotational stability.
Excellent point, sir. That's a very interesting point, sir, that you have made. So I'll also go through that. So there are two school of thoughts. One, can you treat it like a non-union, remove the fibrous tissue, add some bone graft, do plating, wait for 6 more months. But as Pradeep Reddy sir told, that would make the patient immobile for another 6 months. And again, there is still an chance of non-union infection and all that. So my plan was to address both arthritis and non-union at the same time. Yes, it's technically very challenging because it's almost like a proximal third tibial fracture. And you're doing so, and the proximal part is very mobile to even take sockets and all that. So this is a total knee arthroplasty. So I've added some papers, sir, in this. This is by Arun Mullaji in his 10-year retrospective study. So there only yeah. So coming to this paper, this is by Sawant et al. You can see the point that he has made. If he has gross valgus, there will be tension stress on the medial side, and that will cause the fracture. Until and unless you treat the reason for the stress fracture, you will not be able to heal it. So that is only when you do a total knee replacement, you correct the alignment and put a rod, then the tensile stress will be converted into compression forces, and it goes into union. So this is what I have employed into this thing. So this is what Dr. Jaykrishna Dey sir was telling. Moskal et al. Has also performed 2 cases. He only reported 2 cases in the literature, where if you see, he has added a unicortical plate. If you see in the Moskal thing in the top. So that's what Dr. Jaykrishna sir was telling. Just put a stem. Along with that, if you had a unicortical plate, you can also get a rotational stability, right? So this is one such case presentation by Arun Mullaji. You can see the stem tip coming out of the cortex. He said that the patient is still doing well in spite of the knee stem tip coming out. So that is another case by Sawant. So decided to go ahead with my pan. So this is what, sir, I did my FDG PET, did an MRI, ruled out all metabolic abnormalities, because we don't know, it could be some kind of a high PTH hormone, serum. So I have also ruled out all those things. So you can see these images of gross, how mobile the X-ray is, the knee is. I've calculated how much stem I have to use. So with the help of the software, I have calculated. And in fact, Merrill, I've used Merrill, and is also Merrill sponsored. I'm glad here. So Merrill is the only company which is having the longest stem if you calculate from the tibial base plate. So that is why I have used the Merrill stem here. And these are some intraoperative images. I confirmed whether I could obtain the reduction or not. Then I first passed a guide wire, just like how you treat a non-union, because I cannot be able to use an extramedullary jig because the proximal part is very mobile. So I used an intramedullary guide wire, passed the reamer through the guide wire, made it center. And then if you can see this image, this is an intramedullary jig. And Merrill wasn't having intramedullary jig at that point of time. So this is from Smith and Nephew. So Smith and Nephew, because when you want to cut a tibial base plate, irrespective of the company, you can do a nice perpendicular cut. So the intramedullary jig is from Smith and Nephew. So this jig also helped me to stabilize the fracture site so that I can take good perpendicular cuts. So so this is how the post-operative looks like, X-ray looks like. So now do you want to add anything, sir? Pradeep, sir?
Yeah, I think probably it's a very well done job. One thing I would probably improve on is probably the diameter of the stem.
Yes.
That is one thing probably I can maybe
Yes.
next size
Next
or
size.
next.
Yes, excellent point.
But a very well done job.
Yeah. So Siddharth,
I think
if
I'm
you want-
concerned about the same thing. One is the diameter of the stem. Did you graft it?
so that's what I was going to. So if you want to know, sir, if you want to know whether the stem size is correct for this case or not, what is the intraoperative test that you want to do? Siddharth, do you have any?
What is the intraoperative?
Intraoperative test.
No, the way the reamer goes in,
Huh?
the way while you're reaming the shaft,
Yes.
the way it goes in, the scratch that you get, that's the
Yes.
only appropriate judge. Of course, there is C-arm.
So there is something called as a lift-off test, especially when you're doing a.
No, it can dangle, right? When the base plate.
So once you pass the stem, and when you are trialing that, you have to lift the tibia. And
Right.
if you are confidently able to lift the tibia as a whole, then that can tell that this is enough.
Yeah, that is also a valid test, but CM has to be used in such cases.
Yes.
What about any bone grafting? Have you done any bone grafting?
Yes. So that is an interesting point which we can debate, sir. Should we do the bone grafting or not? Is a very interesting question. If you want to do a bone grafting, ideally, we have to open the fracture site, nibble off the entire fibrous tissue, take the bone graft from the iliac crest or anywhere and add that. Would
No. I'm not talking about the iliac crest bone graft.
Yes.
You get so much of bone while you do a cancellous bone while you do a TCAR itself.
Yes.
So that there are a couple of papers which say that the bone graft harvested from the tibial and the femoral bone cuts
Yes.
can be very well utilized for the non-unions like this.
Yeah.
And additionally, your incision is almost till the fracture site.
Yes.
So a couple of another centimeters wouldn't really matter.
So yes, so here the ideal thing was what the school of thought was, we are doing intramedullary reaming. The reaming itself will act like as a bone graft. That was the initial school of thought. So I thought not to open the fracture site, and if it still there's a chance of this going into non-union, then I thought maybe after 6 weeks or so, if it's 2-3 months, I can still open the site and treat it like a non-union.
Yeah.
So now, given a choice, would you use the tibial and the bone cuts as a bone graft if you are given a reverse?
Even retrospectively, sir, I would still think that I would do this first. And if this fracture site goes into non-union,
70-year-old, all we are trying to is make him walk and don't again see me.
So the point is, once we open the fracture site.
The point is I'm making is, I don't want to throw that tibial and femoral bone cuts in the dustbin.
You just want to put it there.
Stuff it inside.
Okay. It can be.
one
So
more
this
thing
is
is-
the X-ray at 1 year. So this is the thing, sir. Are అయిపోయిందా ఒకటి జస్ట్ స్లైడ్స్ రన్ చేసి పడేస్తా ఒక్కటి అయిపోయింది ఇది ఒక్కటే అయిపోయిందా ఇది పంపిస్తావా So I will just run through the slides because I think everybody is waiting there. So this is a case of infected TKR, sir. You can see the frank pus in the joint. So we have removed it and putting a articulating spacer, used a palaco based on the antibiotic susceptibility, where I have used a different set of instruments to remove the cement and all that. And this is the initial X-ray, followed by this is a revision TKL stage 2, where I've employed the sleeves and stems along with the, this is debut, my debut.
Thank you, Dr. Arun. Excellent case demonstration, and thank you, panel, for your valuable inputs. Now let's move on to the live surgery there. I think Dr. Sunil sir is already on the way doing the cuts. So over to you, Sunil sir. I would like to invite Jagan Mohan sir and Ramesh sir to join the stage to moderate the session.
Dr. Jagan is there, is it?
Yes, sir. Yes, sir.
Try to be very careful.
Yeah, just going to give the mic to him. So.
Right. Okay, fine. So we take off the osteophytes. No.
Sir, good afternoon, Sunil.
Good afternoon, Dr. Jagan. You're right.
Sir, your hands are like a robo, sir.
Right. So I usually want to use both the white side line and the transepicondylar line when I place this. My suggestion to all the juniors is, please don't go with the time. Don't say I do knee replacement in 20 minutes, 15 minutes. Tell us how successful your knee replacements are. Okay. Timing doesn't matter. With your experience, slowly you'll get. Always have checkpoints, white side line, transepicondylar line. See, because once you've cut and there is an imbalance, then you're gone. You'll have to have revision instruments for that.
Hello, Sunil.
Hi.
Yeah, I'm Dr. Ramesh.
Hi, Dr. Ramesh. Yeah, hold on to this.
Yeah.
I want to come that side.
You are taking the femoral cut first or?
Yes, sir. Yes, sir. I usually take the femoral cut first.
Any advantage or any or?
Nothing like that, sir. It's just my training. When I first started in Liverpool, my first training was to go with tibia. No, first.
Yeah.
But somehow when I moved over to Wrightington, everybody there were like femur first. That's the only difference. So it's just a training, sir. Because anyway, immediately after femur, I'm going to cut the tibia, check my extension gap, then move over next.
The only problem with this, if you do that femur first,
sir,
if you want subluxate the tibia,
sir,
don't you think that you are putting pressure over it, femoral end, and that may cause
You mean to say the cut surface of the femur? Yeah,
Yes.
I mean, that's what I'll be very careful whenever we do. Just want to make sure that my assistant is well trained, or usually I explain to them not to put all their force there.
So
you try to put the hinge of your force on the bone contact point rather than onto the femoral side.
Now, for that, do you have any advantage by doing the femur first?
No, sir.
No. Okay.
Sir, Mr. Sunil, you said it is, you are cutting the distal femur now, I think.
Yeah, Jagan, yes.
Is there any point to check for the distal femur, to check for the transepicondylar here?
Yeah, exactly. Like, I've shown you the jig before, isn't it?
Yeah.
So we are looking at the transepicondylar. I don't know if you can watch me.
Yeah, that's correct, sir. But we'll do the transepicondylar.
Yeah.
When you do a femoral sizing.
Yes.
Not at the distal femur cut.
Now, if you see there also.
Yeah.
You can see two points there. So that gives me, I don't know if you can see me.
Yeah, yes.
These two buttons.
Yeah, that buttons.
That gives you a fair idea how you're placing.
Yes.
Okay, because this is a distal femur cut.
Yeah.
Okay, so we're not cutting the rotation yet.
Yeah, that's
but
correct.
at least it gives you a fair idea as to how it's going to be. And then even before you put your pins, always check how much you're cutting. And then place your pins, because once you place your pins, you don't want to keep meddling with that. So please.
This is 9 mm cut, I think.
Yes, it is 9.
Okay. Do you put any cross pins, sir? Just only putting 2.
Couple of pins is enough.
Okay.
It just goes by time, isn't it?
Yes.
See, when initially I was doing my first joints, there used to be a lot of black soot around there. That tells us you have touched a lot of metal. But I'm sure, Jagan, as we progress, that's what we learn. Keep your hand there, please. To make sure not to touch the jigs. If you see the black suit around, that means you're cutting more of the jig than the bone. Can I have the posterior spike, please? So Ramesh sir, now I've cut the femur, I'm coming to the tibia now. I think probably this is the point you asked, if I'm putting too much pressure there. Is that what you mean, sir?
Yes, yes.
Yeah, yeah. So if you see there, this is the natural bone, what we are holding on to. So there's not much force on the cut surface of the bone, forceps please. So at this juncture, whenever you try to see and whatever you want to take out, but always have economy of the steps. You don't want to repeat the same steps again and again, and don't want to waste time there. So whenever you see the meniscus, take it off. And the lateral, as we all know, we have to be very careful about the popliteus. Right. So, okay, let's go with the tibia, please. Swab.
Sir, there is a bit overhanging osteophytes on the middle side.
Yes, it is.
If you nibble it, your jig will go and sit nicely.
Yeah, I'm about to do that.
You are about to do it. Okay.
Yes, yes. Thank you. Thank you. That's why I'm scared of Jagan being there. See?
Rudraj is my friend, sir. He has given.
Take off your hand. Thank you. Right. Again, the alignment. You want to use the system that you're familiar with and also see. And this has 3 degrees inbuilt on the tibia. And quite often we also see tibia vara, so you have to be careful. And usually this tip touching go in the direction of second or third metatarsal, and you're in line with the tibia. Okay. So once you're comfortable, C blade, please. Or if you have the stylus. From
So do you put additional 3 fingers at the ankle level?
Yes,
to
yes.
check the slope.
To see the posterior slope. Yeah,
Yeah,
you can see.
Okay.
My 3 fingers there. Yeah. So we're about 2 millimeters off the affected site. You can see there, we're almost there. Right. Can I have the pins, please? Tighten. Hold this one. No, you hold this to make sure it doesn't move along the direction. Yeah, thank you. Right. So here, I'm not going to go less than this. So I'm just spinning in the -2. It's an individual choice.
Yeah.
So I know I'm not going to go up any further. So only if at all, I'll be cutting more of the tibia. So this is the beauty about Merrill. We have a nice holder. Once again, checking, making sure we're not cutting too much of the lateral. Come, saw please. So always have some balance onto the body. So it's just about scraping the medial side. So that probably tells us it's a good cut. Can I have osteotome, please? Okay, got this. Cockers ready? Diathermy. Sorry, you're right. Diathermy, please. Yeah, okay, thank you. Right, okay, fine. So let's see everything nicely. Nibbler for me, please. So now, Jagat, what you said.
Yeah.
Now you can still see the osteophytes in spite of me cutting off.
Yes.
So at this stage, then I want to take out the osteophyte because, like I said, economy of your steps. Sometimes you spend time taking out the osteophytes, and then which would have gone in the cut itself.
Yeah.
So that's why I would usually do at this stage. Right. Okay. So that seems reasonable. Right. Okay. So now can I have the extensor gap, please? So at this stage, we are checking the extensor gap. Take out, please. Put this one there. Yeah. Take off everything. Take this off. Fine. Thank you. Right. So now, usually I try to put my fingers. So still not yet that chubby. So if at all that fits in, can you pull it? If at all that fits in, I'm happy that it's reasonable size. Langen back for me. So at this stage, I'm also taking off whatever extra meniscus is there on the medial side. Guys, can you see that? Force it for me. Okay, so I've got most of the menisci, the ACL, PCL out of the way. So we've got decent cuts there. Pull this. I don't know if they can see. One second. So we can also pull this way, and I'm sure my colleagues can see there. You can appreciate the rectangular space there, isn't it? So you want to get a rectangular space. If it is not, then probably that tells us you have to do the releases. So that's size 9. Okay. So at this stage, I'm putting size 9. Let us go. Okay, so that's decent extension, not hyper extension. Can I have a rod, please? Rod. Easier is to put from the bottom. Fine. No, this is not fitting that. Okay, okay. So this is not the right one for this. So at this stage, normally the system I use, I go through that, just make sure it's going through the center. Now you can see that's nicely straight. Right. Okay. So extension, we're happy. So we don't want any more cuts. Nibbler, please. So I'm going to take out the pins out. Get ready for the femur, please. Okay, for the initial surgeons. So medial epicondyle, you want to put a mark there. And lateral epicondyle, like Dr. Jagan was asking. So you want to connect those. That's your white side line. Okay, so whatever you're putting now, so we have to be watching those lines. Can I have line and back homons, please? One more homons. Right. Thank you. Right, fine, come. So we have this femoral jig there. Lateral surface of the femur. Make sure you're flush with that. Okay, so I'm flush there. Size is C. So we are size C. Yeah. So here, one point I want all of you to see is whenever you're putting this, make sure this center is along the white side line. You won't be able to see now, but if I had a camera that side, I would have shown you. Otherwise, you might want to change the rotation, the axial rotation. Some jigs do have built-in where you can change. Some of the implants have built-in axial rotation. So you want to know your system very well. Yeah, go mark the pin space. So here we are lucky. Everything is falling in good position. The white side line, transepicondylar line, and you can see we're actually nice and parallel, even almost to the tibial cut. That's other way of checking. So that's size C. Okay. I don't know if you can see there. So that's the white side line I was talking about. We're in the center. Right. Okay. Can I have pins, please?
Sir, do you double check? Is there any notching here before putting the?
Thank you.
Before
I was
putting
just about to ask for that before I put the pins. That's what, like I said, always before you put any pins, always use your C blade. So here there is no notching. Okay. So what would I do if I have notching? Any answers? Let's ask the budding ortho surgeons. Dr. Jagan, do you want to ask them?
Sir Jagesh, sir.
He's not budding. He's a mature orthopedic surgeon.
Sir, what he said is, there is an option, sir. You can upgrade it. You can dial it and move it up. The jig can be moved up.
Yes, 2 millimeter.
So you always put these 2 screws and 2 pins.
No, that is with this system.
Yeah, this is a system. Yes.
Yeah. Pin system.
Sir, that pins what you are removing, You can still keep it to cut the anterior and posterior cuts.
Yes.
And
we
then you can take it off, sir.
True, but actually there are already 4.
Oh, yeah.
These 2 6, and for me to adjust
Okay.
my saw, they'll come in the way.
Okay.
And also always, I usually go on the medial because usually we don't notch.
Yeah, if you
So,
go medial, if you any chance of notching, you can still, there is a possibility of correction.
Yes, we can still adjust that.
Yes. That's a good point. So starts on the medial side and then cut on the anterolateral side.
Yes. So we want to see the grand piano sign.
Yes.
That's beauty. I should thank Dr. KJ Reddy sir. Yeah, he's given a very nice patient and everything
Yes.
working well.
Sir, some
Can you
from
put-
the audience, they said it's an Australian shape. Do you accept it?
What size?
No, you said grand piano shape.
Yeah.
One of the audience is telling that it looks like an Australia shape.
Australia. So probably he likes Australia more than.
Yes.
Huh? No, my medium. Medium blade one.
Sir, the lot of shaking is coming. Is shaking from your hands or the blade, sir?
It's still not night, so it's not my hands.
Yes. Okay. Dr. Sunil, while cutting the posterior chamfer, sir, is it advisable to keep a broad osteotomy over the tibia?
Yeah, you can do that.
Because sometimes it will go and hitch the tibia.
For
Risk of fractures.
usually we get a curved osteotomy.
Yes.
Somebody
that's
holding and
yeah.
also onto the sides
Yes.
when we're doing cutting. Nibble up, pin pull up, please.
Sir, you didn't cut the trochlear.
I'm good doing that.
Excellent.
So Dr. Jagar is one step ahead of me always, yeah?
No, sir. Sir, there is some problem with the saw blade and this when cutting the trochlear groove, the jig is vibrating.
Shaking a lot, yeah.
That means the blade is not matching it.
Yeah, we are using a medium blade.
Yes, you should use a thin PCL cut blade actually.
Yes.
The screws you have to remove. In reverse direction, sir.
Forceps for me. Tell me. Forceps, please. Osteotomy ready, please. So, Dr. Jagan, I want to ask everyone, what is the individual choice of the patella?
Patella replacing or not to replace, sir?
Yeah, that's one question.
Yeah.
And how do they do non-replacers? Do they do patelloplasty? I know some people cut to 80.
Yes.
Some people take off just the edges.
Yeah.
Do you want to ask?
Yes. Sir, what's Srinivas 30? What is your opinion, sir? Do you replace the patella always?
Nibbler.
So, mic, please. One mic to him, please. So, do you replace the patella, sir? I think in Indian setup, very less. I think less than 2% or 5% of patella replacement.
Yeah.
Sir, over Srinivas 30, sir.
Thank you, Jagan. Good work, Sunil.
Thank you.
So I don't usually replace the patella, and I
But
do
what do you do?
patelloplasty. I do extensive patelloplasty. I take a lot of osteophytes. I'll remove the lateral facet as well. But more importantly of anything else, to reduce the antennae pain, I'll ensure that my femoral component rotation is perfect and sizing is perfect.
Do you cauterize the patella all around?
Yes,
You
I do.
cauterize the patella
I do.
and use the saw blade to decompress the patella, reduce the
No,
size?
only I'll take off the osteophytes and remove the
Osteophytes.
lateral facet.
Okay.
Okay, so you don't cut off a portion of the patella, Srinivas.
No, only lateral facet. I'll take off the lateral facet.
All right. Okay. So is there any calculation or just whatever is prominent?
Whatever is prominent, I'll make sure that there's nothing hinging or it is curving down into the trochlea bit.
In Sunil, in severe arthritis of the patella, you have undulant surfaces.
Yes.
But if you take a saw blade and cut it into uniform space,
Yeah.
the less chance of post-operative crepitus
Yes.
is there. Even after TKR, if you don't replace the patella, you may have some crepitus, noise in knees.
Yes.
They may say, I'm getting still crepitus.
Yes.
But if you smoothen and uniform space of that patella, the chances of crepitus will be less. What is your thought, sir?
You're asking me?
Yes, yes, sir.
I'm a patella person actually. When I just came from UK,
you replace patella.
You won't believe 80%. No, it all depends. It's not 100% though.
Yes.
But whenever needed, majority were patella replacement.
Yes, yes.
So
No.
I had to request the company guys because every time they come, they won't bring the patellas.
Yes, correct.
So now I've come to a stage where now I'm being forced to think my choices.
Okay.
But now what I also do is, like you rightly said, take off the prominent portions and make it smoother.
Smoother, yes.
And sometimes probably if it's too bulky,
yeah,
you can decrease the bulk.
Yes.
And that's what I'm doing a study right now on.
Yeah.
We are naming that as patelloplasty so that I know my patients who have taken away a piece of patella. So we say TKR with patelloplasty so that I know I can compare the results.
Yes. The other thing is some school of thought, if you are doing a PS knee, you have to replace the patella to overcome the patellar clunk syndrome. What is your thought, Srinivas Thati?
I don't do the PS knees, so I don't see the clunk at all.
No, in severe deformities, gross varus, you have forcibly you have to do to balance the knee. Do you replace the patella?
No, I will take the call at the time of trialing.
Yeah.
I'll trial and see. If the trial is perfect, then I don't have to do anything with the
Patella,
patella.
yes.
However, if there is a clunk while doing the trial, then I would do it after the
Patella replacement.
patella replacement.
So if you are replacing the patella, always replace with a small patella. And this is the only thing you have to keep medial, rest lateral, like femur lateral, tibia lateral, but only the patella higher and medial.
Sorry, what did you say again? Can you say
No,
that?
no. Patella replacement. If you want to replace the patella, always choose a smaller size and at a higher and on the medial side.
Yes, higher and medial. True.
That's the thing. Rest of the femur, rest of the knee always works on the lateral. You have to lateralize the femur, lateralize the tibia.
Watch your fingers.
I think there is a lot of evidence in the research to say the difference between the patello resurfacing and non-resurfacing, and most of them are going off without resurfacing.
Yeah.
Because it doesn't make any difference.
Frankly, the revision rate is 5% on either side.
Yes.
So it's just individual choice. But where you have significant arthritis, obviously we just can't get away.
Yes.
So that's the only conditions now I'm doing my patellas.
They said there's no strong evidence. There's a papers are there. They said no difference at 5-year outcome and 10-year outcome.
Next. Yeah,
Severe patellofemoral arthritis.
When there is a severe patellofemoral arthritis with the subluxation of the joints, it gives the trouble. There you have to look a wide.
Okay.
James, sir. All you take.
Yeah, there is one paper from Dobby, Tim Wilton paper. He said there is no difference between the patellar replacement and non-replacement, but he has recommended in few conditions you have to do, like patellar subluxation and osteophytes, severe arthritis, where you have to do, where you can't balance the patellar tracking is not even after adjusting the femur and tibia, you have to replace the patella to overcome the patellar tracking. I think he has done a box cutting.
Yeah.
Do you use any file, sir, to make it smooth?
It looks smooth actually. Yeah, if it does, it's rough, yes, obviously.
Yeah, because your hands are very smooth.
No, my hands are rough. That's why it became smooth.
Okay. Your hands, your fingers are like a rasp, sir, or like a file, I think. do you recommend to use the handle, sir, to put?
Yes,
this one?
I do.
Better to keep with the handle.
Easier, it's
Yes,
very
easy.
Yeah.
Well controlled.
Size correct. CR ఇస్తున్నా.
I think on the post-medial, you have some bony spurs are there.
అవును మరి. See right. దీని హ్యాండిల్ అంటుందా? ఇది జిగ్ కరెక్ట్ ఉందా?
Dr. Sunil, who is Mr. Sunil, who is why I called Mr. Sunil? He's a.
I know. We're all from barbers, aren't we?
Yes, sir. Yes. Even Mr. Thati is here.
Yes.
So,
So people might be surprised.
yes, he is not doctor. He's a Mr. Dachapalli. Sir, who is assisting you? The scrub person wise, Dr. Sunil.
We
Mr.
have
Sunil.
two fantastic guys, Raghu and
Raghu.
Prashant.
Okay. Is Naresh is around?
Is what?
Naresh or Badri?
These guys are trainees, orthopedic trainees.
Oh, no. I'm asking about scrub person, sir. Who is the company person, Merrill persons? Karunakar, okay.
So
Karunakar Verupula, I think. Yes.
You know him very well.
Yeah. He used to come for our cases, but he used to come very late.
We're trying to fit the jig now.
Yes, sir. I think lug holes, that pegs. Sir, I think just into middleize it a bit.
Jiggy ఒకసారి first 3-in-1 jig. So here you can see the cut is perfect.
Sir, Sunil sir, just check on the posterolateral condyle.
Yeah. I'm taking out everything. If you see
That,
there,
sir.
see there.
Yeah.
I can insinuate my fingers very easily.
Okay.
I feel there's a mismatch of the jig. Give me the first one, 3-in-1 cut.
Actually, the posterolateral femoral condyle.
Posterolateral femoral
still
condyle
looks round.
Looks
Just
some
check on
bone,
that.
sir.
Okay, can I have the screws, please? Hold the jig. Can I have 2 pins, please? So I'm just trying to check my cuts, like you rightly said, by posterolateral is still underway. So we're just trying to redo that. Come, one more pin, please. Any pin. Thank you. Can I have the saw, please? Guys, can you hold it up? Okay. Hold it that way. Okay, Surya Kalagari, just pull it that way. Thank you. Yeah, keep it pulled. All right. Okay, there we are. Stay there. Thank you. Right, okay, screw down. You can see a nice chunk of bone that has come out.
Yes, sir. Yes. That's why after cut, sir, we used to check the posteromedial femoral condyle and posterolateral femoral condyle.
Yeah,
And with the vernier calipers, we used to measure it. Dr. Arun, do you check your bone cut, sir, after cutting?
Pass it on for me.
Sir, just give it back, sir.
So you measure your bone cuts, is it?
Yes. Yeah, we got Arun Reddy from Continental, sir.
Sir,
So-
yeah.
Yeah, after your bone cuts, sir, like chamfer cuts and posterior condyles,
Yes.
do you take that bone pieces and measure yourself?
Sir, no, sir. I generally don't do that. So first I'm a tibia first surgeon.
Yeah.
So I cut the tibia and I cut the femur.
Yeah.
And then I put a spacer. And the same goes when I'm checking with the flexion gap also.
Okay.
So before cutting the posterior condylar cut, I again check with the spacer.
Spacer only. Okay.
And I see so whenever, most of the times when you're cutting distal femur, the angel vein has to be flush with the notch.
Like,
Most of the times in some systems, it's going much more proximal than it has to be.
Okay.
But I'm regularly not checking anything.
Okay. So I think it's sitting nicely, sir.
That's sitting perfect, actually.
Yeah, you did some magic, I think.
Actually, no, the words that I said, everything working smooth, so that's why it didn't want to work.
Oh,
Okay, so just relax on your.
no, for the
movements.
benefit of us, I think it has like that.
Thank
So
you.
always check it, don't force it.
Yes.
So
And
thing is, if
also-
you force it, it will go into mal track, risk of fractures.
And take off your track.
Compact,
the
and
spike.
see, put a jig again and cut it
Okay,
again.
okay. Always take off your spikes when you're putting this, because otherwise you'll have undue pressure on the lateral. So you might feel tightness, then you'll end up, cutting off.
Correct.
So if you all, I don't know if you can see there.
Yeah,
You
come
can see?
back, a little bit back, sir. Yeah, zoom
forward.
out, zoom out. Yeah,
I'll do one
good.
thing. Can you see
Excellent.
there?
Yeah, it is facing second
So
toe.
we are perfectly the center of the ankle, second toe. Okay, so that's nice. So now I'm going to check my extension. Okay, so that extension again, I'll go
Yeah.
down a bit.
It's a
So
full
perfect.
extension.
So no hyperextension,
Yes.
no flexion deformity. Then I'll go to 90 degrees. I want to show you the stability. You can see there, that's nice and stable. Anteroposterior, medial lateral, you can see that's rotating as one unit. Then again 30 degrees, you want to make sure there is no mid-flexion instability.
Excellent. Yes.
The next thing you want to see is the patella.
Patella tracking. Yeah.
So that's beautiful. There's a little bit of lifting. You can see it just as lateral sliding,
mild
subluxation, but that will get off once you suture it.
Yeah.
And if you look at the patella,
At
like
this
we
stage,
discussed-
Mr. Sunil, do
Yeah.
you put any single stitch or single thumb, use it and check it?
No, towel clip. I usually put a towel clip.
Okay. towel
And
clip.
also, as you can see, I was telling the guys here, Raghu and Prashant, huh? Towel clip or anything, artery clip.
Who are they, sir? Raghu and
So I
Prashant?
don't know if you can see there, I usually make a sharp cut. So it
Yeah.
comes exactly where it belongs to.
Yes, 90-degree cut.
So the guys are saying yes. You should say yes loudly. Okay, so it's a sharp cut so that you know where to match it exactly. And then we are checking there. Usually I use a towel clip in place of this
Yeah,
artery clip.
it's sitting
Okay,
nicely, sir.
so that's sitting nicely. No thumb technique. Okay, so that's nice and stable. So here we are done with most of things. And if you look at the patella, I just have a little bit of bump here. So more of this cartilage rather than that.
Yeah, there is a central ulcer is there, sir?
Yeah,
Central
it's actually
ulcer?
more of prominence rather than ulcer.
Okay.
Can I have nibbler, please?
From our side, it is looks like an ulcer, sir, because probably we may got little bit of astigmatism.
See, I've taken off that prominence.
Yeah.
Just now, so that seems fine. So I'm going to just circumcise and take off the edges like Dr. Tati was saying. Okay, so here, now we'll mark the center. You want to make sure on the medial side it's sitting nicely.
Yes.
You're in the center, your medial 1/3, lateral 2/3. Okay.
Sir, you are aiming the tibial tubercle?
Yes, the tibial tuberosity.
Middle 1/3 or lateral
Lateral
1/3?
tibia, yeah.
Okay.
So now we'll plan for the tibia preparation. Come.
Sir, here, once you mark with the diathermy,
Yeah.
aiming the tibial tubercle,
Yeah.
but sometimes when you put the tibia,
Yes.
it may not cover fully.
Exactly.
So
I
what
agree.
you will do, sir?
I
What
agree
is
with
your?
you. See, this is just a fair idea for me. You have asked a nice question, Dr. Jagat.
Yes.
Because see, there are times when you follow that, you'll be in trouble.
Yes.
So you want to have this just as a
Just
no,
as
an
a
idea.
guidance. Okay.
So now I'll show you what I'm going to do. Okay, hold this there. What?
Just for a navigation, sir.
Can
that
I
is-
have 4
yeah.
minutes?
There are some gubbings are there on your left side, sir. Are you going to take it off, that one?
Which one, sorry?
That material, like,
This one?
yeah, remnant of the meniscus.
Yeah,
and
I'm going
other
to take
things.
it off.
Yeah,
hold this
okay.
One, hold this one.
You want to, I thought you will preserve, act like a PRP or something.
We can use for later.
Orthobiologicals, no?
Future. See,
Sir-
nowadays we are having lots of doctors saying you don't need replacement. Just an injection is enough. Isn't
Yes, yes, that's
it?
correct.
So
Daily
it's
over
not-
the newspapers and radio channels.
they're coming up like mushrooms nowadays in Hyderabad.
Yeah, one of your favorite heroine is also promoting Suhasini.
Yester here.
I
Okay,
think
so
both
now,
are- both you are all colleagues, sir, Suhasini and you.
now I'm at least 20, 30 years younger to her.
Sir, don't cover up, sir.
Okay, Dr. Jagan, coming back.
Yes, sir.
So always I tell my colleagues, You have seen medial nicely.
Yeah.
So at the same time, you want to release a little bit, probably about a millimeter or two
Yes.
on the lateral as well.
Yes.
So at the most, you are releasing a bit of your IT band.
Yes.
But here, you will know exactly where you're putting your tibia. Can I have central spike, please?
Yes. Sorry, I got one question from the audience.
Yeah.
They're asking, the surgeon will bit struggle, especially while seeing on the lateral aspect of the tibia after putting an implant. It is difficult to see whether to extract the cement on the posterolateral aspect.
Yes.
So can you give some technical pearls how to see that posterolateral corner after implantation of your real tibia?
So once you have done, what I do is when I put the cement,
yeah,
I use only the anterior 2/3.
Yes.
Posterior 2/3, I don't put much cement.
Yeah.
Once you impact and compress, that cement will go.
Yes.
So that takes off most of the problem.
So mostly we used to put 2 spikes on the lateral side, sir.
Yes.
One on the anterolateral, one is on the posterolateral, so that you can see round the margin of the all around of the posterolateral of the tibia.
Yes. Okay, boys, can you have a look now?
Yes.
So I've done the marking there. So sometimes if you just blindly follow this also, might not be a good idea.
Yes, correct.
So you want to check where the PCL is. So that's my PCL.
Yes.
Okay. So you want to draw a line that gives you a fair idea as to where is the center.
Yeah.
So then can I have the handle, please? Then you come back to this. Most important things. You don't want to come
overhang
anterior.
or,
Yeah, medial and anterior. These are the 2 overhangs you don't want to do. Posterior
Yes.
little bit is okay. So now I'm perfectly in the center where I want it to be. Pins, please.
Correct.
The most important thing is you want to know your company very well.
Yes, yes.
Because if you keep changing your companies, you don't know. This, see, if you see this prominence also, the tibia, sometimes you think that might be coming up to there.
Sir, who is hitting the mallet, sir? What is his name?
Your friend from the company.
Company man. Okay. Oh, Karunakar.
Mm.
Sir, when you put that pin, sir, it is a bit dangerous because it is a sclerotic part. When you try to put that pin without drilling, risk of it may slide off it with this. Always use the drill. Karunakar, you should use the drill, sir.
Agree with you. Here it's not that badly sclerotic. I also check when I put the pin, if it's really hard, take it out and put the pin.
Yes, correct, sir.
Yes, agree with you. If it is like really hard,
yes,
you want to go with drill.
Drill, yes, correct. You are using the fat drill now?
Watch your finger. Can I have a saw, please, the small blade? Again, one more point, like you said, Dr. Jagan. Again, doing the transfers of the Christmas tree. Again, you don't want to bang your Christmas tree down.
Correct.
You want to use the smaller blade, just make a small dent there.
Correct. So always, this is a technical point. Medial side is a thick osteosclerotic bone, a stony hard bone. If you try use the Christmas tree, it may change your track, and use the saw and make a pathway, and then use the Christmas tree 3-4 times, sir.
Yeah, stem.
Bang it, lift it up, bang it, lift it up, so that the track will be formed. Otherwise, if you put a real thing, it may slide towards the lateral side.
Yes. Okay, so now the difficult part. I'm just kidding. This is much easier for all the trauma surgeons, I guess.
So why you are doing, sir? You are putting a long stem?
Put the stem.
Long stem?
No, about 100. That's what we discussed, isn't it?
Okay, we were not there.
We are bypassing the fracture by 2 times the width of the 2 times the width of the tibia.
Okay.
Size.
So it is a complex primary. But Mr. Dachapalli is telling it is a very simple fracture, simple case.
Sorry, Dr. Jagan, what did he say?
No, it is a complex primary, sir.
It is, yes.
Yeah, but in your hands, it looks simple.
Ah, thank you. So sweet. 9. 9 is the thickest.
So you are planning for uncemented stem or
Yes,
cemented
uncemented.
stem?
What size?
Uncemented stem. Okay. Do you use often any image intensifier, sir, while doing
Yes,
this?
I've got it ready, Dr. Jagan.
Okay, stand by.
Yes.
You all wear the lead aprons?
Yeah,
You
that's
don't
a
need.
good question.
You are radio resistant, I think.
I've completed my family now.
Okay.
My son is sitting in the auditorium.
Yes. Here, yeah. He's waving his hand, sir.
Is he?
Yes.
So is he? I feel the clever man out.
He is next to me.
Is it? Okay.
I think we both are classmates, sir, somewhere in ninth class or somewhere. Your son and me both are classmates.
Are you talking about KJ Reddy, sir?
No, no, no.
You and KJ Reddy, sir, are classmates, is it?
So what is the length, sir? Length of the stem you are
Length
planning?
is 100.
Okay.
So that's my 100.
100, okay. Sir, do you have any offset stems here?
No.
No?
Not in this setup.
System, okay.
But yes, you need to plan for that.
Yeah,
if you have
sometimes
a bad
if,
deformity.
yeah, especially if you are putting a long stems,
Yes.
the tibial base may not sit.
But this is 10.5, no? The thickest 112. Then we'll go. Yeah. So you want to fit in the best possible because we are going for uncemented.
Yes. Cemented the proximal and rest is uncemented, yeah?
Yes.
In this type of scenarios, do you allow full weight bearing immediately or any
Yeah.
restricted weight bearing? Sir?
No, no. I mean, because see, it's more like a transverse fracture. It's not a complete fracture though.
In fact, weight bearing will helps in healing.
Yes.
So
Sir-
compression will.
Sir, this is Dr. Arun speaking.
Hi, Dr. Arun.
Hi, sir. Sunil, sir, I have a small doubt for you.
Yeah.
So you have first taken the tibial cut and now you're putting an uncemented stem. Is that the plan, sir?
Yes, I'm doing a
Yes.
uncemented stem.
Yes.
And cement for the proximal tibia fixation.
So in this
Please.
technique, sir, the problem, what I generally noticed is your stem, your uncemented stem is going to decide the plane of the tibial cut. Because always the tibial could not be very straight perpendicular to the tibial base plate.
Agree.
So would you prefer using an intramedullary jig in such kind of cases, or you want to use some kind of cement augmentation, or if there is some, because the plane might be definitely different than the cut that you have taken.
Yeah, that's why we need an offset stems. If we don't have an offset stems, if we are using a short stems, we can get away. But if you are using a long stems, it is difficult. Always trial with the base plate, with the stem, and put it really inside.
Yes, excellent point, sir. So, but I don't think this system has the.
Yes, if it is not there, use ream the over diameter, put a under diameter stem, cemented stems.
Yes.
Yeah, yeah.
That we can get away.
See,
if we
that's
don't have.
like Dr. Arun was saying, you can also think of doing intermedullary jigs.
Yes, yes.
So that will help to solve
Yeah,
this
correct,
problem.
correct.
So 12 stem, no? Okay.
I think it is the system specific. If you know what tibial tray you're using, if you know the angle between the stem and the tibial tray, then the extramedullary jig go reasonably well. You don't have to actually use the intramedullary.
Yeah, true. That's what I'm saying. If you know your system well, because you've been playing with the system for so long.
Correct, absolutely.
Sorry. So touch wood, Dr. Arun, nothing happened.
Yes, yes, sitting nicely, sir.
Okay, so that's nicely seated. If you can see there.
Yes.
We're in the center and exactly where we have marked. That's one of the good things. You can see there, that was my mark and it's sitting there. No overhang medially, anteriorly. So we still have a couple of millimeter actually. So that's nicely seated. Okay. So probably we'll just go for the last trial. Just make sure. And at this scenario, it's up to you whether you want to go for a check X-ray like Dr. Jagan was suggesting. I mean, for me, I feel confident because it was fitting in nicely and I could feel the grating of the bone. Malik, for me. Okay, right, let's go on. Malik. X in the tail, right? Okay, fine. Right, okay, so final check again. Boys, you can see there, nice extension.
Yeah.
And then flexion, no lift off. Obviously, you won't have much here in this scenario because you have a stem.
And patellar tracking has also improved after
Yes.
putting your tibial stem.
Patella is fantastic. Again, 90 degrees, little bit of anti-movement. There 30 degrees, no mid-flexion deformity or instability. Medial lateral. So,
Mr. Sunil,
yeah.
do you prefer very, very tight knees or little bit loose knees?
if at all you want to be a little bit lax on the lateral because majority of your patient want deep flexion.
Yeah.
So if at all, I don't mind a little bit of laxity on the lateral, but not medial.
Not medial, okay.
So that helps in flexion.
You are cauterizing the all around the patella, sir?
Yeah, circumcising, sir.
Circumcising with the coagulation with or
Cutting.
cutting
Yeah.
with 50-50, I think.
So, Dr. Jagan, at the end, you said Bob's your uncle. What does that mean?
What is that?
In your United Kingdom, people keep saying Bob's your uncle.
Yeah, means if any PS,
Nibbler.
he had to replace the patella, sir.
No, I'm just kidding. I mean, see,
Yes.
once you say you're done, we keep saying, yeah, Bob's your uncle.
Yes.
So that says that we are done.
Yes.
Okay, you guys want to watch the cementation or you want to continue with your scientific programs?
Yeah, we'll just carry on, Sunil sir. Probably we'll come back after your cementation and look at if you're taking an C-arm picture.
Yeah, I'll take one.
Yeah, so please let us know when you take that so that we can switch it back.
Probably we can do one now so that you can continue with the scientific session.
Yeah, please, sir. If that's okay, then please let's do it. I think meanwhile, we'll like to ask Dr. Anjaneyulu sir to give the mementos to Srinivas Thati sir, Dr. Arun and Ramesh sir. Is it ready? Okay. So would like to invite.
Yes, sir. I request our
Can I have
Ramesh sir.
Anjaneyulu sir.
Drill.
Yeah.
Drill.
Can you
Sir,
please come?
Anjaneyulu sir, please come on to the dais, sir.
Probably.
Thin drill.
It better
So
here,
just,
sir.
we're doing like a microfracture.
My request,
Just like that.
Dr. Arun
Chinna
Reddy,
dandy.
to please.
Normal drill. Chinna.
Thanks for participating
Pin bettandi.
in this event.
Nice, no? Come out very well.
Yes.
Arun.
Oh, yeah.
Okay. Right.
Yes, SVS Medical
Nice.
College, yes.
Nice. Yeah, decent. Good. Okay, let's go for this system, please.
I think,
Ayari చూసుకోరా నాన్న మళ్ళీ అన్నీ చూసుకోడా నువ్వు దా సిఎంఎన్ ప్లీజ్
give a big hand, please.
అప్పుడే
Ramesh sir is from Professor of Orthopedics
Srinivas.
from Usmana Medical College General Hospital.
Arun, please.
Congratulations, sir.
ఓ ఇక్కడ ఒకటి ఉంది కదా కెమెరా
Arun was born in this medical college, SVS Medical College, as an orthopedic
ma.
surgeon.
Sorry,
As an
sir.
orthopedic surgeon, he was
Yeah.
born here and brought up
Okay.
here. He was a
Again,
direct
sir.
student of Dr. Anjaneyulu sir. Sir, Anjaneyulu sir, you want to
Yes,
ask
sir.
a question, sir? How to examine the hip joint now? No.
Sir, Srinivas Thati sir, please.
Srinivas Thati sir from
So I think
Hyderabad.
let's switch the camera theater to probably we'll see the C-arm picture. I think Dr. Sunil Dachapalli sir is ready with the C-arm picture now.
No, not yet. We're just taking the picture now.
Okay.
What's the tourniquet time?
Thank you, Anjaneyulu sir, for giving the momentum. Thank you, Srinivas sir, for joining us.
Thank
It's okay. Fine.
you.
Da.
Rudrateja sir, I think you should receive one memento, sir.
No,
Yeah, please. So may I request Dr. Anjaneyulu sir, please give a memento to our dynamic hoster, sir, Rudra Raju sir, please. Anjaneyulu sir. ఇంకా రెండు ఉన్నాయి సార్ అయిపోయింది సార్ ఇంకా అయిపోయింది యా ప్లీజ్ కమ్ సార్ రుద్రరాజు ఈజ్ ఆస్కింగ్ ఐ వాంట్ షాల్ బట్ వీ డోంట్ హ్యావ్ సార్ ప్లీజ్ ఎక్స్క్యూజ్ మీ Give a big hand, please. Thank you.
Yeah, I think we are.
He's showing the femur side, sir. Femur.
Keep going, keep going. As high you can go.
I think you are surprised where the
Also,
stem
why
has
don't
gone. So that is on the other side of the this called
as
femur.
much as you can.
Yeah, come down, sir, a little bit down.
We want almost that touching.
Okay.
Because the magnification decreases.
Okay.
Height కింద పోతుందా ఇక లేదుగా? That's great. Thank
Sir,
you.
if you
Fine.
know-
Thank you. Right. Okay. Hold there. Okay. Picture. Okay. Go south. South. P2.
Caudal end, sir. Caudal end.
Picture. Right. Okay. A bit more south. Kinda. Stop. 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 Picture now. Towards you. Picture now. Turn it round. Turn it
Beautiful.
round. That looks nice. We have surpassed easily the double the diameter. Double the diameter. You can see.
I think.
Mallikarjun, can you point out with your finger where you can see the flakes there?
Yes.
Point out with your finger. No, up. No, in between. Where you can see the flakes. Budget కిందికి రండి మధ్యలో. ఇంకొంచెం కిందికి. Yeah. So that's where the fracture ఇంకొంచెం పైకి. That's where the fracture is. Okay. You can see that we have got the length more than double the diameter. Okay. కొంచెం పైకి వెళ్ళనా north.
I think Mr. Dachapalli, it is better to go a little bit lengthier stem than the existing thing.
Bit more this side. We have given enough length, Jagan.
Okay.
కొంచెం
Means if you see the callus,
yeah,
it is from the tip of the stem to the callus.
మీరు అందరు జరగండి కొద్దిగా. Yeah, I don't know if you can see me.
Okay.
So I'm just pointing out. I don't want to touch. See, that is the height. That's where the fracture is.
Yes,
you can see
correct.
the new callus there.
Yeah.
So we easily surpass the diameter 2 times.
Anyhow, it is a transverse and compressive fracture.
Yeah, we're
It
almost
is
like
enough, I think.
3 times.
Yeah, that's very good, sir.
So that's nicely balanced. And yeah, take it off,
Beautiful.
please. Thank you.
Excellent demonstration, sir.
Thank you so much.
Thank you very
Sir.
much.
Amazing job. Just, I think Dr. Arun has a question for you, sir.
Please, yeah.
Sir, do you want to straight away mobilize the patient or do you want to use any patella bearing brace, something like functional brace, something like that?
No, because it's a transverse fracture, Dr.
stable.
Arun.
Yeah.
You know, it's going to be a compressive force. So weight bearing with walker.
Okay, straight
That
away.
should take
Okay,
care of it.
Yeah.
Probably knee brace in extension for first
Well,
few
yeah,
weeks.
that's a good idea. We can
First
use
few
a
weeks.
knee brace, hinged knee brace for initial phases because as we know, she's osteoporotic as well.
Yeah.
The most important thing is here, we want to give the supplements.
Okay.
Post-operatively, not only calcium, probably you can think of teriparatide
Excellent.
to increase the bone stock.
And do you use the denisumab also, sir, here?
Well, that is a good question, Dr. Jagan, because
Ready,
the
yeah?
studies say, first is you have to always give for a period 1 or 2 years of bone forming this teriparatide, then think of anti-bone resorpting activities like denisumab.
Deni or zoledric
Yes.
acid.
So
or
first
alendronate.
always you should give bone forming. Otherwise you'll end up with secondary fractures.
You don't
The
need to
lots-
give both simultaneously. You can't give, sir.
Yes, you can sometimes, but always safer. Initial at least 3 to 6 months, give only teriparatide.
Teriparatide. Okay.
And then you can mix. Otherwise,
Excellent.
after 1 year, give denisumab.
Denisumab. Okay.
Thank you so much, Sunil sir. It was an amazing, excellent presentation of complex knee surgery. We'll be moving on with a next case. Switch on to the, I think KK sir is here. Hi, sir. Good evening.
Hi, can you hear me?
Yeah, we can hear you, sir. We have been eagerly waiting for you since morning.
Yeah, so they have kept a case which is very interesting.
So,
So
yeah.
both hips are fused and both knees are fused.
Yes, sir. So thank you so much. And let's start the show. So thank you, Jagan sir and Ramesh sir for
Thank you.
moderating the session. I would like
Welcome,
to invite
KK.
Srinivas Sati sir and Arun to come onto the stage and moderate the session. KK sir, over to you. Please walk us through the case and then
Yeah.
we'll go with the surgery.
So can somebody focus on the X-rays there? Can you see the X-rays here?
Yes, sir. Yes, please. We can hear you.
So she's an 18-year-old girl with juvenile rheumatoid arthritis with both hips and both knees fused. So generally when they arthritis starts at a younger age group, there are different varieties of juvenile rheumatoid arthritis. You can have isolated coxal or polyarticular variety, or sometimes the spine is also involved, which can also be labeled as juvenile ankylosing spondylitis. So this case, fortunately, the spine is not stiff. So there is a little bit of pelvic obliquity, but the SI joints as well as the spine seem to be okay. We got the lateral view of the spine with the pelvis. And you can see that one side is abducted, other side is flexed and adducted and internally rotated. So we are operating on the right side today, and we'll see how the surgery goes. So the surgery is through a posterior approach. Any questions here?
No, sir, you can please go ahead, sir. Sir,
Yeah.
this is Dr. Arun here, and Srinivas Thadi sir is also with me. Pleasure
Right.
having you, seeing you, watching you perform surgery, sir.
Okay, so you can you give me a marker film, please?
So you got the masterpiece today, KK,
Yeah.
for the master. So everything for the surgery will be a challenge. Can you walk through us what is your position wise? What are the
So
precautions you take?
the patient is in lateral position, and you can see that the knee has got around 120 degrees of hyperflexion, and it is fused in that. So there is
Yeah.
no movement in the knee.
Correct.
And the bone is very osteoporotic because this patient is not walking.
Yeah.
So I have requested Chandrasekhar, my friend, to come and help me with this case, because it will be requiring a lot of gentle assistance
Yeah.
to avoid any intraoperative fractures.
Absolutely.
I think he must be exhausted, sir. We have been involving him as a moderator. We have asked him to do a live surgery, and now he's assisting you.
Yeah, yeah. So he's full of energy. So not a problem at all. Okay.
They both are popular pair in our college. KK and Chandu, they're always together. And yeah, it's glad to see you together here as well.
So this is the posterior border of the femur. This is the anterior border. So this is probably the GT. So I have make a generous incision, because what we must remember is that there is no play here. So everything has to be seen properly before we can do anything.
Do you do anything different in your approach compared to normal?
So this will require more soft tissue releases, Srinivas, and it will have a longer incision.
Correct.
Because we have to get the knee hip to extend as well. Because we are also looking to do a knee replacement at some point in time for this patient.
Yeah.
So the soft tissue releases will be much more than a standard THR. So we are just going through the skin and the subcutaneous tissue. This is pretty straightforward.
Sir, in cases like these, how would you want to place your acetabular cup, sir? I mean, do you classify it preoperatively and put little more
So
anti?
this will be anatomic, because the pelvis is not fused. But if it
Yes.
were a stiff spine as well, then we would have to assess whether the pelvis is stuck sitting or stuck standing. Based on that, make changes to the acetabular inclination and version.
So before this surgery itself, you take this sitting and standing X-rays in such kind of cases, sir?
Absolutely. So you have to assess whether the spine is stiff as well. In this case, if you see, there is good intervertebral disc space. The spine is not stiff. So these are relatively forgiving with respect to instability as such, as compared to the other where you had a fixed
Yes, sir.
pelvic obliquity with a sagittal plane as well as a coronal plane imbalance as well.
Excellent, sir. Thank you.
So you have this just for the sake of juniors. This is the fascia lata, and we will always start from inferior to superior. So I'm just incising it inferiorly. You can see the vastus lateralis there, and then you go up. And you can split the gluteus maximus in line of its fibers. Okay. So that's about the exposure. And then we will put in a Chanley retractor.
Sir, in your primary hips, are you always using the posterior approach, or nowadays people are more talking about anterior approach and all, even for primary hips? What is your take on it, sir? And do you do these pyriform preserving approach, sir, anytime when you're doing a posterior approach for primary hips?
Okay. So our primary go-to approach nowadays is the direct anterior approach. So most of my hips, if they are simpler, would be through the direct anterior approach.
Okay.
So
any
last couple of years we have changed a little bit. We find that the early rehab is superior with direct anterior approach, and even with small diameter sockets, we are not worried about instability at all.
Okay. Any line about the pyriform is sparing approach, sir, when you're doing posterior one?
Piriform is sparing approach. I had done a few of those cases for fracture neck femur. It is a good thing to give us a idea about the leg length, but it is I find it not that different from the posterior approach as well.
And also, I had a chance to see direct superior approach when I was in Melbourne, sir. But I think exposure-wise, it is a bit difficult to.
They are all okay. Like when you're doing avian hips, where there is no deformity, no shortening, you can do any sort of minimally invasive approaches. But if you had soft tissue contractures, they will need to be addressed. And we have written an article on how to balance the hip in American Academy. So this is the gluteus maximus tendon, which I am releasing a little bit, partial release. And the first perforator comes there, just underneath the gluteus maximus. So this is the first step in any complex hip surgery. Now we palpate the tip of the trochanter and identify the posterior border of abductor. So that is the second step. So this is the externally rotated hip. Correct. So the nerve will be quite close to the hip joint. Yep. So you have to be careful here. So sometimes you may have to do a dual incision and try and identify the neck from the front, and then do the neck osteotomy in situ. So this is the fat pad you can see, and that's the sciatic nerve here. It's actually very, very close. Okay. You can see the sciatic nerve here. Very clear. So if you're not cautious about that, you will end up cutting the sciatic nerve. So since this is fused in external rotation, we will go anterior to the abductor and then do the neck osteotomy there, and then come back and do the surgery from the front. Lift it up. So you can see here, this is the abductor. Okay. Yeah. This is the anterior border of the abductor. This is the posterior border of the abductor. So I will put in a retractor underneath the anterior border of the abductor. Spike this,
So sometimes they call this a stent approach, no, sir?
You can call it whatever by whatever name you want.
Yeah.
But it is again. Yeah. Right. So you can see here. So I'm just dissecting anteriorly here between the tensor fascia femoris and the Can somebody focus here nicely?
The capsule is also completely adhesive, right? So you can't.
Yeah. So
see
we
any
don't
point.
know what is capsule,
Yeah.
what is not.
Yeah, that's
So
true.
somebody can focus there. So this is the gluteus minimus, which I'm splitting.
Yeah.
Light అసలు లేదు. Can you just put the light on properly? So you can see that I am already on the femoral head neck. Okay. Right. No light.
Can somebody focus? The
Yeah,
light?
just give us a second. We also can't see anything. లైట్ ఇక్కడ అడ్జస్ట్ చేయాలి. అది అక్కడిక్కడ ఉందండి. ఇక్కడ వేయాలి. జస్ట్ 1 second. I also can't see anything. Right. Can you see that now? Light. Focus చేయండి. Light on చేయండి. Yeah. Can you see that now?
Yes, yes, sir.
So this is the intertrochanteric line. That's the neck, and that's the head which is fused there.
Yes,
So
sir.
I'm
yes.
excising the part of the anterior capsule here. Can you see that?
Yes, sir.
So this is the head neck junction,
Clearly.
and clearly the entire hip is completely externally rotated.
Yes.
Okay.
Yes, sir.
Okay. So now this is the acetabular margin here. Okay.
Yes, sir. We can see.
And this is the intertrochanteric line.
Okay.
Okay.
Yes, sir.
So we will make our neck cut in between these two. So this is around 5 millimeters. So now this is broken. Now I will just take out a section of the.
Take a wedge of the neck from the subcapital area.
That's right. It's a sort of a napkin ring we are taking out.
Yeah.
So that it gives us some leeway to mobilize this femur. Sorry, my mistake. Cocker is kuch. But we must refrain from cutting too much of the neck as well, because it will allow us to have some flexibility with respect to the positioning of the cup. Right.
Yeah.
So the superior neck is probably the strongest cortical bone. So if you cut that thing off, sometimes you cannot position the hip properly.
Your retractor placements for this exposure, are you worried about the nerve anywhere? Because the superior
The
one.
nerve is right here.
Right here. So
right, the nerve is right here.
Okay.
Very close, and we don't have much of a play here.
Sir, in which cases do you prefer the sleeve osteotomy, where we remove the entire abductors as a sleeve and then fix it with a screw?
You can do that. If this doesn't work, then we would transition to that particular sort of a system.
Okay.
We would do a sort of a transtrochanteric approach, because we're not able to mobilize it.
Okay.
So it has to be a sequential process. Okay.
Okay. Sir.
So now, as you can see, it's very difficult. Even though we have made the neck osteotomy, we are not able to mobilize the femur because the structures are all stuck.
Yeah.
Other lesson. Right. Lift it up. Now I am putting my finger on the sciatic nerve. So this is the sciatic nerve. It's pretty close, and then I will go close to the posterior border of the GT here. Okay. And I'm cutting the short external rotators.
Okay. Are you able to rotate it internally after
No.
you to cut the?
At this point in time, we are still not able to
Not
rotate
able
it
to-
internally at all.
Right.
And this is the posterior border of the abductor.
Okay.
So I'm putting my finger on the sciatic nerve,
Yeah.
and I'm releasing the short external rotators. You can see here.
Yeah. How far down you go? You take off entire quadratus, or you?
Yeah,
try
we
to-
take out the quadratus.
Quadratus, yeah.
These cases, there is no way we
No.
can
Preserve any of them.
yeah, preserve the quadratus. And as long as I'm staying close to this border,
Yeah.
the nerve should be safer.
Safer, yeah.
So there is absolutely no rotation which is possible actually, despite cutting the neck. That's the challenge. So this is the abductor. I'm putting my spike underneath the abductor there. చిన్న స్ట్రైట్ తీసుకో మనది ఉంది కదా స్ట్రైట్. Take a Langen back there, that's all.
Would you raise the origin if it is really difficult, the abductor origin?
Yeah, so there's a that's the part of the posterior head which we could not cut from the back.
Yeah.
So Langenberg this one, the posterior retract. So that is preventing us from internally rotating it. So that's okay. We can wash it. So you can see that
Yeah,
which we could not cut from the front. Okay.
correct.
So I'm just making that. So now the entire thing will be mobilizable. Okay.
Yeah.
Right. So now you can see that the neck is cut there. So I'm now releasing the anterior capsule and the internal rotation.
The anterior capsule is you go for all the way down to the lesser troch, all
Yeah,
around.
so the sequential release, I talked about that.
Yeah,
So what we will do is we have already released the G max.
yeah.
Now I'll go a little bit down
Mhm.
and release the adductor magnus origin from the femur.
Right.
So that's the adductor magnus.
Mhm.
Now you can expose the uh, iliopsoas there. You can
Yeah.
see that.
Yeah.
Okay. Scissor isko. So between the iliopsoas and the femur is the anterior capsule. So this is the anterior capsule.
Correct.
And if you remember, we have already released the anterior capsule from the
From.
anterior side.
Yeah.
And the last release is the psoas release.
Hmm.
So this is the psoas. So 4-step release.
Yeah.
Step 1 is the release of the gluteus maximus tendon.
Yeah.
Step 2 is the anterior capsule release, which we already did from the front in this case.
Correct.
Step 3 is the adductor magnus release.
Yeah.
And step 4 is the psoas release. So now we have already released all that. And now you can see that we are able to get to 90 degrees position.
Yeah.
And this is the lesser trochanter.
Mhm.
And this is the tip of the trochanter, and then this probably is the center of the
Piriformis
head.
fossa there.
Yeah. So now once we do that, we make our neck cut.
Yeah.
So definitive neck cut. 132 చూపించు. So this is a valgus type of neck. So we will use a 132 neck length.
Okay.
And you can use this as a sort of a surrogate marker.
Mhm.
Although you can play around with the head size from minus to plus. So I'm making a definitive neck cut.
Yeah.
And we are being cautious here because it is very osteoporotic and we cannot fight against osteoporosis.
That's the last thing you want. You don't want actually. Not even the last thing.
Correct. So now the no, he is pulling the femur is in 45 degrees of flexion.
Yeah.
And internal rotation of 50 degrees. Now I am identifying the anterior superior iliac spine.
Okay.
And my anterior column retractor goes into the
Right.
Okay. So now he will flex and externally rotate the hip.
Right.
Okay, let's see. So
Would you release the rectus as well?
Yeah,
Part of the
I will
rectus?
release it. If it is tighter,
Hmm.
in this case, probably we will have to release.
You have to, right?
So you can see the inferior transverse acetabular ligament, everything here
Yeah.
nicely.
Very interesting, right? Most of these cases, you have a preserved TAL.
That is right.
That
In
is
in-
leaky. We should not be losing that.
correct. So this is the ischium. So I'm putting my pin in the ischium here.
Yeah. That's a very good exposure now.
Right. So you can see the whole thing.
Whole acetabulum.
Quite a decent exposure.
Right.
Spinal angle. Is it down there? So you can see the TAL here actually nicely. I
Yeah.
will try and show you. So that's a transverse acetabular ligament.
Sir, the inferior capsule is also very thick, no, sir, in cases like this.
Yeah, capsule and all we have excised, right? So now we have preserved the anterior column, the posterior column, and this looks okay. Give me a small reamer.
It's a circumferential release all around the base of the neck.
So now we will take a small reamer
Yeah.
and see.
What are your markers for your anteversion and inclination here now?
So we will just look at the body position and then go with that because there is no other marker.
Yeah.
So I'm already on the medial wall. You can see that's the transverse acetabular ligament.
Mhm.
And it's a very small acetabulum. Isn't it?
How do you define your anterior?
So this is 90 degrees.
Yeah.
And I'm bringing it down to around 45 degrees.
Okay.
Okay.
Yeah.
And then this is the body axis.
Yeah.
And this is around 15-20 degrees antiverted to the body axis.
Okay.
But I'm also looking at what is the thickness of my residual column.
Yeah.
And I will keep on enlarging till I don't, cause more damage to the column.
Posterior column. Yeah.
And you can see the transverse acetabular ligament here.
Yeah.
Although it may not be a very reliable landmark.
How far do you think you can rely on that? No, you said it's not reliable.
Cannot rely on that. So we will do a real component and a trial reduction.
Yeah.
Anything?
Do you try to overhang the posterior wall or you just go in flush with the posterior wall when you're doing your cup?
No, we will not overhang it. It depends on the situation. Sometimes it's a good idea to overhang.
Yeah.
Right. So now we are coming closer to
the floor.
We are coming closer to the thing. So now I will ream in reverse.
Yeah.
So just to size the acetabulum. Okay.
Yeah.
So this looks okay. 46. 46. Next
Do you do line to line or you try to under rim?
For Merrill Cup, you will have to over rim by 147.
Over rim by 1. Okay.
So we are coming closer. 46 trial this one. So you can see this is the medial wall.
Correct.
And this is the transverse acetabular ligament and this is the pulvinar fat pad.
Can you show with your left hand?
Yeah, you can show the TAL. Yeah, this is the TAL.
Yeah. Okay.
This is the pulvinar fat pad.
Yeah, yeah.
And some part of it is part of the head.
Okay.
Okay. So which is okay. We don't need to remove it.
Don't need to remove that. Yeah.
Yeah. Because even if it's a little bit lateralized, it's fine.
Yeah.
But as you have seen, it doesn't seem that much lateralized. Looks
Actually, that gives you some bone stock as well, right?
Correct. He's 18-year-old.
Yeah.
Right. So now this is gone in. And if I'm rotating, there is still a little bit of rotation.
Yeah.
So I can go one size up for this, and that is about what it is. And then we will put few screws and get out of this situation because we will not get because of the osteoporosis. Isn't it?
Yeah. Nicely done.
40. 49 this one. 48.
Sir, your ideal implantation system would be uncemented in this case, or you prefer using a hybrid, or in very rare cases, if you're not getting a good cup alignment, did you ever do a reverse hybrid when you are entirely stuck and not able to place the cup properly? Did you ever do a reverse hybrid kind of fixation?
So this is a 48 cup. You can see now we have AP capture and you have superior inferior stability. So I will not increase by any more than this one. So this is okay for me. And regarding your question, 48 real cup this one. Regarding your question, we can never say never, but these sort of situations you must be prepared for anything.
Yes,
Sometimes I have seen one patient where the acetabulum, I just put my hand and it was just going into the pelvis, something like that. So I had to abandon the case.
Okay. So what is your take on reverse hybrid fixation, sir?
So if you don't have any choice, then we have to, do. So if we have no choice, we have to do it. That's all. So sometimes you may have to abandon. You just do a osteotomy of the neck and
Leave it as a girdle stone probably.
yeah, leave it like a girdle stone. They'll be much happier.
Much happier, yeah.
With range of motion. So
True.
With these cases, I have seen that we have to swallow our pride.
Yeah.
It is not related to how good we are. It is how the bone quality is and all that. Okay. So even in this case, there is a little bit of posterior superior bone. Despite being so careful,
Yeah.
we have created a small defect there. So these patients, you cannot say that okay, this is it. This is what it will be like that. So you may have to improvise. Sometimes run away to fight another day.
Yeah, in spite of being cautious, still you can have issues, right? Plan A, plan B, plan C.
Correct,
Should
correct.
always be there.
Absolutely, absolutely. So now you can see that we have got a good fixation with the cup.
Yeah.
Between the columns, but we will always protect it with screws. So the screws also will be in the direction of the anterior superior iliac spine.
Yeah.
So generally 30 screws. So this spike will dictate the division of acetabulum from ASIS to ischium. Okay. And that divides it into 4 quadrants, right? Anterior superior, posterior superior, posterior inferior, and posterior anterior inferior. Because of the lateral position of the patient and the acetabular anteversion, this appears to be the 12 o'clock position. But actual 12 o'clock is somewhere more in the front.
Correct.
So that needs to be appreciated. If you appreciate that, you will always get good quality screws into the acetabulum.
Yeah.
And whenever we have complex situations, we must always not shy away from putting a few screws. So this is very good hold with the screwdriver.
That looks like a good bone over there.
It looks like a good dome bone.
Yeah.
This fellow has not removed this.
Sir, you always prefer 1 screw or 2 screws?
2 screws always.
Yes.
Having said that, I have put one screw sometimes. So 25. So this patient, because of this complex situation, both in the pelvis and in the knee, we are planning for a dual mobility cup.
Okay.
But you can also put a 32 millimeter head in this particular situation, since it's a young patient.
Yeah.
But I'm more comfortable. These patients don't put too much of load on their joint. So I'm okay putting a dual mobility in this particular situation. I can live with that. So nowadays, the standard of care for patients with high risk of instability is to use dual mobility socket or some sort of an anterior based approaches.
Yeah. What is your opinion on using the dual mobility in normal hips like in avian?
I don't think you should use it.
Correct.
So this looks okay. Trial liner.
Would you remove the anti-osteopathy? Looks like a little bit of a proud bone in the front, or you leave it?
I'll leave this one.
That one. Okay.
This is anterior column. Okay,
Yeah.
so I'm not worried about that. So I'm putting in this modular dual mobility adapter.
Okay.
Now I'm ready to remove my pin. And use this as a femoral elevator. You can see that actually the anteversion on the femur is much more than which we noticed when we dislocated the hip. So I intentionally reduced the version on the cup
Yeah.
to somewhat neutral because the combined version will still be acceptable.
Correct.
These cases are actually ideal for a modular implant because of the childhood pathology.
Yeah.
The femur tends to go into either retroversion or excessive anteversion, and because of their deformity, we cannot assess them really before the surgery. So it's a reasonable idea to do a modular implant in these sort of situations.
Would you do a CT preoperatively to know?
Yeah, it is a good idea, but we have noticed, we have published on that as well, that because of the grotesque positions, it is not possible to actually position them in the CT scan gantry.
Yeah.
Drill this. So this is a standard femoral preparation. So we are trying to go as lateral as possible. And I have opened the medullary canal laterally. Right. So we'll use a proximally coated stem in this particular patient because it gives us multiple offset options.
Yeah.
So this, we cannot change too much.
Proportion.
Yeah, we cannot change too much. And you need to be gentle as well because you can end up creating a femoral fracture.
Correct. When it comes to the offset, lateral offset, what options do you have here?
So we have a 128
Okay.
neck shaft angle and we have a 132.
Right.
So we can see here that the implant doesn't go any further in.
Correct.
So there is axial stability, there is rotational stability, and there is no interface mobility. So 4 is probably a correct size for this patient. This is the first step. It will be okay to do a trial reduction at this stage.
It is so important not to really bang the trial in, right? So
Yeah, you
have to
need
be very
to
careful.
take care of the hoop stresses, take the stem in and out.
Yeah.
So we are using a small neck minus 3.5.
Okay.
Take down. And we can reduce this nicely.
Yeah.
Okay.
Yeah, looks very good, right? Went in easily.
And we are able to extend the hip
Okay.
almost to 20 degrees. Flexion, adduction, internal rotation looks stable. So this is what we will go ahead with and complete.
Would you release the channels before you do that, or you are okay with the channels being stretched out, soft tissues?
We can release it. It won't make too much of a
Doesn't make much difference.
too much. Won't make too much of a difference.
Not much of difference.
We can
yeah.
see that we can get the hip
Yeah.
almost from this position.
Correct.
We're able to get it straight.
Yeah.
I'm taking it flexion, adduction, internal rotation, sleeping position, abduction, external rotation looks very stable. So I think that's about it from us. It's done.
Fantastic. Well done, KK.
Yeah, you
Thank
can go on with the program and we'll complete our thing. Yeah.
Thank you, sir.
Thank you. Thank you.
Every time we watch you performing surgery, we learn many interesting points, and this has been the same today. And thank you, Chandu sir, for also being here.
Sir, KK sir, thank you so much.
Thank you.
Excellent
Thank you.
demonstration, and then we really don't expect you to finish that early, but since you finished it, we have to look for the other theater. Audio visual guys, can we move on to the next theater?
పిల్లలు కొంచెం డల్ గా స్లో ఉన్నారు సార్. అంతే. ఏంది ఇది ఉందమ్మా మనకి అయోబ్యాండ్ లేదా?
Jaganmohan sir, we can hear you clear and loud. Please.
Yes, Ravi Teja.
20 minutes.
So
Thank you, sir. I forgot to take beta blocker propranolol. I have stage fear.
Can you walk us through the case, sir?
Yes, sir. Can you show the X-rays here, please? The patient is Mangama. She's 45 but looks like 55. She's having bilateral knee osteoarthritis. Left is more than the right. She's struggling, difficulty in walking. She has tried all non-operative management. She's struggling with activity of daily living. On examination, she got full extension to full flexion, no distal neurovascular deficit. Everything is fine. So that is our X-rays. And this is the patient. Spinal was given, epidural supplementation given, antibiotic given, sir. Dual antibiotics, cycloplanin with Supasef, the dual antibiotics. Prepare sterile chips, neo wood rape. We put an ioband, suction is ready, diatherm is ready. We got one senior postgraduate here to assist me. We got one scrub person. We got a second postgraduate is here, and the sister is preparing the drapes and instrumentation. We are going to start in next few minutes, sir.
Okay, sir. Sir, this is Dr. Arun here.
Hi, Arun. Thank you.
All good.
Don't
Sir,
take any revenge, sir.
Sir, what is your antibiotic of choice, sir?
Antibiotic is dual antibiotic, sir. Tycoplanin and Supasef, third generation cephalosporin and tycoplanin. My preference of choice for a joint replacements, either hip or bipolar or knee replacements. That is my choice, sir.
Excellent.
But that depends upon hospital to hospital protocol.
Okay, sir. In the pulse lavage, do you mix any antibiotics?
In the pulse lavage, no.
Okay.
Never, sir. Why? Because it is difficult to maintain the sterile aspect with the pulse lavage. If you put anything inject into the pulse lavage like a 3-liter bottle, there is a chance of contamination. So don't try any antibiotic unless it is a manufactured one. You can try.
Yeah.
But not custom made.
Yes. So there is a very interesting research paper, sir, by Javed Parviji.
Yes.
That local antibiotics, even in TKR,
yes,
they are very good in controlling surgical site infections or or any PGI incidents of PGI.
Yes, that's correct, sir. But theoretically, yes. But the logistic issue, sir, if you want to mix an antibiotics outside and changing the needle, contamination, inject onto the 3-liter, there is a very, very high risk of chance of infection. But if it is readily available, antibiotic loaded one, I'm happy to use, sir.
Excellent, sir. Excellent. Thank you.
Sir, my one technical advice, small tip is you mark the skin incision, show this with the marker pen and do a horizontal thing, sir. That will help for closure of the wound. So if you want the closure to prevent the dog ears at the end of the wound, it is better to put marker pens.
Yes, sir. Yes.
With this incision side.
Sir,
so we are about to start.
Yes.
We can all set go. You are ready? So tourniquet, please. We are using tourniquet at 300 mm mercury. Blood pressure is around 140, 150, I think. So, sir, okay, sir. Tourniquet on, please.
Sir, do you also do the same drawings on the patella tendon also? Because what you told makes totally sense, that the skin edges can be approximated exactly.
That is the inside. Once I open it, we mark it. There are two things, sir. Once Sunil Dachapalli has nicely demonstrated a step cut of patella tendon. If you do a step cut, you can match the repair. Or you can use the marker pen. You can mark it, the patella tendon. at the time of cutting. So we are starting, mark the incision time, please. So the incision will be in the flexed position. So starts from here, this is the left side. Adjust the light, please. There are sterile handles. No, it is not sterile. No, petaledama. So Dr. Arun, I am audible.
Yes, sir, you're audible.
Okay,
Perfectly.
sir. Anything, just let me know, sir.
Sure, sir.
కొంచెం క్రాక్ ఉందంట ఏం కదా స్టేబులే ఉంది కదా ఫిక్స్డ్ ఉంది కదా.
So skin is given, change the knife. Forceps, my preference is not to put the fingers into the wound.
ఎక్స్టెండ్ చేయవా?
Especially joint replacement, sir.
అట్లుంచి
Better not to put.
కిందకి తీసుకో.
This is the lateral side. Just I will release it. That will helps you to avoid the patella.
కొంచెం ఎక్స్టెండ్ చేయవా?
Amma tooth forceps, please.
ఎక్స్టర్నల్ రొటేట్ కొంచెం అయితే.
Given non-tooth amma. Okay.
కొంచెం అటు
So just I am reflecting the medial side, sir.
సీఎం కొంచెం ఇట్లా తిప్పండి.
I am doing a medial parapatellar approach.
చూడు.
Nicely, you will see the tendon.
ఉల్టా
Here
ఉల్టా
the top technical tip is, if the incision is skin incision is
Next time
here, your incision should be much
కదా, ఉల్టా
distal to
ఉంటది
the skin incision, so that it is easy to close. If
బానే
the
ఉంది
patellar
కదా.
tendon cut and your skin
Optimally అంతే
incision is
ఉంది.
at the
White
same level,
అక్కడ
it is
white లేదు
difficult to
కదా.
close.
Audiovisual guys, can you increase the sound from Dr. Jagan Mohan Reddy sir's?
Okay, sir. Please
theatre?
increase.
ఓకే ఉంది
Increase.
కదా, పైన ఉంది.
Also, Jagan sir, we are inviting your friend Professor Javan J. Krishna onto the stage as a moderator.
Oh yes,
So
yes.
he's ready with the questions for you
My
since the
God.
morning. So
Sir,
I think
I thought this morning I have a good time, but
Ahmed,
Jai Krishna comes means I have to rethink again.
Thank you.
Sir, please
Latest.
consider me.
Hello, Jagan.
Think me as your younger brother or your son, sir.
ఆల్రెడీ ఉంది. క్రూస్ కూడా మంచి ఫోల్డ్ ఉంది. జ్యూస్ కూడా బాగా.
Section, please. So my technical tip, I told you, no, sir, the skin incision and the patellar tendon cut
అది మనకు
should be
కనపడదుగా.
distal, so that it is easy to close. And any bleeders to identify, just cauterize it. That will help in post-operative bleeding. It will control the post-operative. Next knife, please. Langenmax, please.
ఎలా వెళ్తున్నావు మంచిర్యాల?
Langenmax. Don't put
Train.
any hands into the wound, sir.
ట్రైన్ బుక్ చేసుకుంటే
Langenmax, keep a 2 Langenmax here.
మంచి ఏపీ ఎక్స్ప్రెస్ ఎక్కి వెళ్ళిపోవచ్చు. రిటర్న్ కూడా అందులో వచ్చేచ్చు.
Yes, sir. Take 1 Langenmax here. Yeah.
So
this is the lower end. This is the tibial tubercle. Knife, please.
టేబుల్ ఉందిరా, ఏం ప్రాబ్లం లేదు.
So I am just doing the medial parapatellar approach.
మనం ఏం చేయలేదు కదా, అది ఉట్టి
There
దీంతో
should be
అయిపోయింది.
enough cuff on the patellar side for the reattachment. So there is a big effusion is coming up.
మళ్ళా
So
దొరకకపోతే
go up to that. That's all.
తీసుకో, లైనర్ తీసుకో.
అమ్మ కొంచెం లెంత్ తీసుకోండమ్మా.
వాష్ తీసుకో, లైనర్ ఇచ్చేసి వాష్ తీసుకో. జీరో వేసుకోవచ్చేమో హెడ్ కదా, జీరో హెడ్ వేసుకోవచ్చు.
Somebody is speaking on the.
Sir, after getting, just extending and release the medial release. It is a varus knee. Put a Langenmax here, please.
hello, can
Yes, sir.
someone from Krishna Kiran sir's theatre, can you please lower the volume so that we continue with Dr. Jagan Mohan sir's surgery?
Sir, can you give homens, please? Small homens. Small homens, please. Baby homens. So this is one top technical tip here. On the medial side, if you want to release the medial side, put at the this homens and just retract. It will all nicely, it will stretch. And the sister or assistant can externally rotate so that you can easily release it. Don't over release it. Section, please. Just release and check it. So this is okay. Okay. So take a knife, please. Just I'm releasing on the inner side. Right. Come on. Carefully flex, please. Excellent. So now we opened it. I'm putting 1 homens on the middle side, 1 more homens on the lateral side. Any spiky ones there? Spiky ones ఉన్నాయమ్మా? Spiky ones తీసుకుందాం. So again we have discussed, అమ్మా ఇది వదిలేయండి, నాకు it's obstructing me. So this is a fat pad. We discussed in the past that whether to remove the patellar fat pad completely or partially or not. So I release partially, sir. That will help you for your better vision and better placements of the implants. Jay Kishan, sir.
Yes, sir. Yes, sir.
Can you hear me, sir?
Yes, sir. Jagan, yes, absolutely
Okay.
right. Very clear steps. Very clear steps.
Yes, sir. Be kind enough for me, sir. I will buy some chocolate for you. You like Cadbury, sir? So first, the next thing is, in India at present, we don't have a bicruciate knee replacements. So this is an ACL. I'm going to cut the ACL with the diathermy. Why? Because there is a genicular artery, middle genicular artery, which supplies to the ACL. Risk of bleeding will be there. So using the cautery is advisable. With the cautery, cut the ACL. Okay, just Homan, please. Spiky Homan. So put in the spiky Homan on the lateral side. Okay, just hold this like this, sir. Nicely flex it. Take the diathermy. Forceps, please. Cut the lateral meniscus a little bit so that it will release it nicely. Right, sir. So I do femur first, then followed by the tibia. No, that's fine. Yeah, you can come on this side. One should stay on this side, one should be on this side. So this is the knee is exposed. I put a spike on the middle side. Ask the assistant not to lean on that. If you lean on that, MCL will be stretched. They should hold it. Whenever required, they have to show it. So next, I will go for the entry point. Before that, I will little bit dissect on the superior aspect just to see the distal femur. Release this synovium. Take this in. Amma, I need a McDonald's, please. McDonald's. Leda. Any straight instrument, Amma, chinnadi. You don't have McDonald's here. Give an autoclave. So ideally, you should have a McDonald's. What I will do here is, this is one technical tip. You pass this instrument along the shaft of the femur. Why you required is to assess the direction of the shaft so that your drill will go in parallel to that. Ideally, you should keep a McDonald's instrument. Unfortunately, we don't have here, but doesn't matter. So next thing is marking the entry point of the femur. So as we have discussed, this is a PCL. Above and medial is the PCL. And with the diathermy, you can create a crater so that it won't slip. If it is a very arthritic knee, once you put a drill, it will slip off. So can you show me, sir, this one, please? This one, so I burned nicely, made a crater so that the drill will go easily, it won't slip. No drill?
Yes, sir. Nice point.
It's coming?
Sometimes if it's very hard,
Yes, sir. If it is very, very hard,
we have
you
to
can
do
take some small pins.
pin. Yes, sir. Yes.
You can put it
Yes.
like diathermy, give it a, what do you call, mallet? Yeah, mallet, sir. What this is a hammer or mallet, sir? Mallet. What is the difference between mallet and hammer? So take this small pin, mallet, and make a small crater, sir, like this. We are waiting for a drill, sir.
Yes, sir. Nice point. Sometimes, yeah, as you said, it just slips away, especially
Yes.
if it's very hard.
Yes. Give a small nibbler, please. Small nibbler. So we got a time because we are waiting for a drill. Drill has to come from Delhi. No. Calcutta. Bombay. I think the flight is a little bit delayed, sir. But just keep it there, sir. I'm just meanwhile utilizing the time, just nibbling the osteophytes. Take a what do you call those pieces? Take it, please. Clean my nose. Nose means nose of the enabler, not my nose, sir. So this is the osteophytes I'm taking.
because I got some time. Okay. Right, sir?
Yeah, sir, as you rightly removed the medial and lateral osteophytes if there are there.
Yes.
Do you also remove the anterolateral osteophyte because
yes,
sometimes it becomes
yes,
difficult when you are
Yes.
sizing.
Ideally, you should remove the osteophytes and do it. That will help you in proper sizing and also helps in positioning of the jigs in a correct position.
Yes, sir.
So you should follow the basic steps, sir. If you follow the basic steps, you won't be wrong. But once you become a senior, you can do. So ideally, you should expose. Show me this point, sir. Brother, show from here. Yeah, show this one. So you should expose and you should see this area. Why? Because that will help this area, sir. That will help in identifying the correct size of the implant. The second thing is whether it is notching or not, we will know it. Okay. Not there, amma. Drill raleda. Drill load cheskoma.
So you always remove the fat pad anterior of the femur.
Yes, sir. Sometimes these osteophytes will give trouble in the flexion extension gaps. Yes, yes, absolutely. So that's why we'll remove it, sir. Why they are struggling, amma? ఎందుకు డ్రిల్ దాకా ఏం చేస్తున్నారు? Hey, brother. Rishan. Hi, madam. Just asking about you. Thanks, Shamala, madam. Yes, you are from my place. Jamal Madagu. Yes, I am from Jamal Madagu. Teru Vidi. Yes, I know Arthur, Rameshwaradu, Arthur Samuel, Ishwar Reddy, ML Narayan Reddy's son, daughter, my classmate, and Ishwar Reddy's son is my classmate. I visited Jamal Madu several times. Yes, I told sister, where is he? She told if you want to meet.
Sir, Jagan sir, whom are you telling to, sir? Jamal Madgu, whom are you telling to, sir?
We got one senior sister here, sir. Theater sister.
Oh.
Show me. She said.
Hi.
Say hi to our audience.
I thought your friend Chavan Jay Krishna sir will ask questions to you, but he's not asking anything, sir.
Yes, I've given big Cadbury silk, sir.
No, actually, the very step is very good and excellent, marvelous. You are
Yes, sir.
coming like a 1, 2, 3.
Yes, sir.
It is something like a very spoon feeding.
Yeah, I'm just waiting
excellent,
for
marvelous.
Jairam sir. Drill ఒకటి రాలేదు సార్ కొంచెం చూడరా. I know you are doing so many cases. You have to do rapid sterilization.
Jagan sir.
I can appreciate. Yes, sir.
Badri here.
Badri, where are you?
I'm here very much, sir.
In auditorium?
Yes, sir. Very much. Very
Yeah,
much.
I know the Badri since I was in LKG or UKG. The last, when I was in school, I used to see Badri. He was in DPO at the time. He used to sell Johnson & Johnson, PFC like that. He's roaming around nursing homes.
Thanks.
In before independence, sir, that is?
No.
After independence?
After independence.
Yeah, just show me. So I'm using this drill. Bit careful. Hold it nicely. Control always. So first go in an angle, then parallel. It's a little bit hard bone. So once it's done, go up to there, come out. There are two schools of thought. One is irrigation. If you irrigate, it reduces the chance of fat embolism. So, but do you have water, 50 ml saline? If you don't have, just suck the intermedullary canal. So that will prevent the fat embolism.
Sir,
So next one, please.
Sir, do you want to put a bone plex inside the medullary canal?
Bone plug at the end of the procedure, sir, not now.
Not now, yes.
Yes, end of the procedure. Do you have a long rod? Yeah, please. Always use a long rod. Never compromise with the short one. Why? Because it has to go and snugly fit at the isthmus. then only we are referencing the anatomical landmark. If we are using a short one, it will dangle in the metaphysis and large diaphysis. Hello, hi, Rajagaru, ela unnaru?
Yes, sir. Nice point, actually.
Yes, always use a long
Long
rod,
one.
sir.
Yes. Otherwise, it dangles there, and the flexion of the component and also the varus would also be
So,
different. Otherwise,
yeah. Here, also very important point. This jig should be parallel to the transepicondylar. Wait, the transepicondylar things. Just hold it. Just retract here, sir. Just hold it. You should hold and ask the assistant to bang these pins first. You bang this one. Shakti ledu. Yes, once you bang, double check again. If the distal femur cut is going wrong, everything goes wrong. So we are doing on the left side, again double check it. And how much is this? This is a 5-degree valgus. Focus here, sir. 5-degree valgus. These are touching on the distal femur and it is parallel. So once you fix these pins, it won't move anything. Then there is no FFD. I am going to take standard distal femur cut. That is 9 mm. You come this side, sir. Focus here. So I'm going to put these pins over the 0. So what is the advantage? You can go for +2 or -2. Okay. So I'm just using this. I'm using the lateral side. Why? Lateral bone is bit softer than the medial bone. Then on the medial side, if it is too hard, always use a drill. But because of the time constraint, we don't have quick coupling. We are using the hand mallet. But ideally, you should use drill for all pins. Okay. Once again, check it again. Left 5-degree valgus. The condyles are touching. Okay, just give a pin, sir. I think it has moved up. After putting, it has moved up. Pins up. Amma, Mali, sir, go to drill load. Just go. Yes. Hit it here. Got a number. Beautiful. Pin it, drill it, because after putting, the jig is lifting back. Right, sir. Spend some time on the critical event, sir. Yeah, one more pin, please. So 0, 0, 0, 0. Okay, sir. Take it off again. Check it. Left 5-degree, left 5-degree, and here it is 9 mm. Right. Take it off, please. No handle, please. It is not gripping. Faulty instrument. Yeah, good. So once you are exposed here, take an angel wing. Angel wing, please. Yeah. So check, put it here. How much you are taking? It's okay, reasonably okay. Yeah, reasonably okay.
Jagan sir, you usually take 9 mm.
Yeah, if there is no FFD, sir, we will take 9 mm. If it is FFD is there, then we will take additional 2 mm. Up to 4 mm we'll take, sir.
Thank you.
వేరే బ్లేడ్ లేదా మనకి మరి వేరే బ్లేడ్ తీసుకో ఏం కాదు పెట్టేసేయండి వేరే బ్లేడ్ ఇచ్చేయి మనం చెప్దాం మళ్ళీ యా క్యారీ ఆన్ కమ్ ఆన్ దిస్ సైడ్ సార్ క్రాస్ పిన్ ప్లీజ్ అనే క్రాస్ పిన్ వెరీ హార్డ్ బోన్ ఉందమ్మా డ్రిల్ ఇచ్చేయి ఆల్వేస్ డ్రిల్ ఇచ్చేయి చిన్నపిన్ ఇవి లేదు కదా రైట్ చలో Right. Take a broad osteotomy, please. Broad osteotomy. Right, Amma. Broad osteotomy, you should keep it here. It will protect the tibia. Otherwise, there is a risk of tibial fractures. Flex it, hyperflex it, and protect the MCL, protect the LCL, and soft tissue protection is very important. Start in the middle. Right. Once you cut the distal femur cut, just take one seesaw blade, put it like this, whether it is a parallel cuts or not on this side, sir. This is a one. So it's almost parallel. There is no undulation, no bumps. It is fine. So take off the central pin. Come this side, sir.
So that's a nice butterfly, sir.
Yes, sir. Thank you. Come this side, sir.
Sometimes just looking at that shape, we can also
Like
judge
this?
whether we have taken extra bone or
Yes.
less bone.
Curved osteotomy, please. Yeah, at this stage, just I will put a curved osteotomy. Just open it like this, sir. That's fine. Looks okay. Pin pull up, please. Take it off. Sorry, you want to take? Yeah, you assisted TCAP before? Yeah, take it off, please. No. Short liver arm and pull like this, sir. It will come out. Size rechanama. So here, I think Dr. Dachapalli and previous surgeons like Chandrasekhar Dana has already demonstrated about the white side line, which is the lowest part of the trochlea and transepicondylar lines. But this got inbuilt, where modern surgeons are very lucky. We got inbuilt instrumentation are very good in dealing with the 3 degree of external rotation. So even the first year resident can do easily nowadays. Okay. If hit it. If it is too tight, we'll do a tibia cut and then we'll come back. Yeah. Settle spike, echo. You should not put more pressure on that, sir. Otherwise, MCL will relax. Yes, sir. Settle spike, please. Yeah. Koncham sharp lekunda round unda. So first dislocate sublux. Yeah, it has nicely subluxed. Then take that one. Do you have a PCL retractor, sir? No, double prong. Right, sir. Right. Jig, please. Forceps, please. Yeah, put a jig, please. Right, here the small technical point is the tibia cut is more technically demanding than the, no, just hold it, sir, here. So focus here. It should be center of the ankle. Sir, excuse me, focus here. So this should be center or the ankle. And in the varus knees, I will move the jig little bit medial, sir. If you see this central mark here, normally they give center, but in varus, I will move towards little bit medial and lock it.
Very nice.
That will prevent the varus cut.
Excellent, sir.
So always put your 3 fingers, brother, bit careful, Amma. On the lateral side of this one, the tibial shin should be here like this. So your fingers should be on the outer side of on the lateral side of the jig. Put it here. This should be like this. So that will prevent the varus cut.
So your preferred medialization is 3 degrees or 5 degrees, sir?
Medialization
Of the tibial jig, the thing that you have done just now.
It is degree now, sir. 3 mm. 3 mm medially will shift it. Right, sir. Right. So how much is that? 2 mm. Yes. Yes. 2 from medial. Lock it. Again, check it. Center of this. Put first lateral pin.
Jagan, actually TKR is a macro presentation. It is the eyeball surgery. So everything can be calculated, or you want to add some more point to that?
What is that?
Actually, TKRs are eyeball surgeries. So do you want to add some more to that?
Eyeball surgery, yes. So we can take a angel wing, we can use it. Different techniques are available, sir. This is bend pin. Anything. Beautiful. So once I put a 2 mm from the affected side, that is on the medial side, sir. That is a medial tibial condyle. This jig was kept. This is at the center of the ankle, and I moved 3 mm or little bit more on the medial side because it is a varus. I put my fingers here. This should be parallel to the tibial shin and little bit medial to that. Okay. Once done, take off the stylus, hold it, put a cross pin, sir. Always put a cross pin, and check with the angel wing how much you are taking. Don't take too much, especially females. Even you think that you are taking very small, but once you cut, you will have a massive. At present, we have only 15 mm. If you take more, we can't get away. We don't have a backup of revision system. So once you are done, cross pin done, we are double check again. This is very, very important cut, protection of the things. Nicely sublux. One should hold the leg here. Yeah, flex it, deep flexion, until subluxation. That will prevent the vascular injury. Okay, soft tissue protection, and take this saw. What is it? The bone is stony hard. Right? Take only the cross pin, please. No, wait, cross pin only. Right, sir. Right, take the jig off. Take this off. Broad ostratum, please. So flat one is better rather than the curved one, if we have one. So just lift it off. Are you okay? Think you are sleeping? No, not sleeping. People are watching if you sleep. So normally in my setup, if we do sometimes, if it is a prolonged surgeries, assistant will sleep. You have to wake it up. Like that, tap his hands. Okay, cocker ivada, please. This is very good. This is a very good cocker. We used to call this as a mother-in-law with a nice. Can you show me this, please? Focus this. This instruments.
Why, sir? Why?
It's a mother-in-law. Yes, you know that. Jay Krishna knows. Right, sir. Hold it nicely. Take a diathermy and cut it nicely.
Do you check your cuts with caliper, sir, usually?
A caliper, sir, I don't have a calipers, but I'm not experienced like a previous Mr. Dachapalli to check, measure the sizes with the eyes. I don't have that capacity, sir. I have to use the instrumentation to check the size of this. Sure, yeah. So this is a medial side, taking very small, lateral side, reasonable amount.
Yes, sir, we can see.
I think we are okay.
Yes, we can see.
Yeah, but we are going to keep these pins here till we get the something. Yes.
Sir, Jagan sir.
Yes, sir.
The ultimate goals of management in TKR depends on the tibial cuts or femoral cuts.
Both, sir. In my thing, it is a both. Cocker, please. Cocker. Diathermy, please. So I'm cutting this remnants of medial meniscus. There's a big medial meniscus, nice medial meniscus. I think this can be used for allograft meniscus transplantation. Right, sir, come out. Right. So the one nice pearl came out, sir. I'm going to give this to our theater sister.
Fell down, sir.
Loose bodies. Yeah.
Yeah, it is a nice pearl. Show me, sir. Yeah.
You can see it, sir.
Arun Reddy, sir, shall we
Yes,
give
sir, we
to this
appreciate
to
it.
Jai
Yes,
Krishna
sir.
Reddy, sir, or my
Yes, yes,
sister?
yes, sir, we appreciate it.
Yeah, I want to give to my sister here.
Okay, sir.
Must be a countermeasure. Okay. Sometimes we'll have the loose bodies.
Ah. Yeah, sizing ichese. So I'm going to put this femur sizer. I told you white side line and transepicondylar line you have to check. The posterior flange should touch the posterior condyles nicely and put a pin here, sir. Yeah, head pin here, bottom. Very hard bone. Yeah, this side, sir. So you should fix the jig here with the pins. Yeah, once you have fixed this one, then you can measure the size easily. Otherwise, it is difficult to get correct size. Rama Judu. I think this is B, C anukunta. Gallo undi kada. This is a C kada. No, this is A, that is B, that is C. Kindiki unnadi C. Yes. కొంచెం పైకను. Right. Pins, please. So I'm getting C here. So 3 degrees, 3 degrees. Yeah, one more pin. Yeah, take this off, please.
Generally, when you have taken the both distal femur and proximal tibial cut, generally don't you check with the spacer whether the enough cuts have been made and complete extension?
We can check the flexion extension gap, or we can finish it off, cut it and check it, sir. Both ways. Yeah. So give a C jig, please. Size C. Just put it. Again, give an angel wing, please. So again, focus here, sir. Focus here. Angel wing, please. Angel wing, please. Thank you. So this is the medial side, sir. What's your name, sir? Ali. Mr. Ali is here. Is a second year postgraduate. On that side is a medial side. What's your name, sir? Huh? On the Abhinav side is on the lateral side. Abhilash side, Ali side is on the medial side. If you see, I'm taking more on the posteromedial, less on the posterolateral. That means my component is externally rotated, not internally rotated. And also check whether there is a notching is there or not. Put it here and check it. From the top, Evan Ragalava. So there is no notching here. Yeah, put it, show. Okay, can you show? Okay, that's fine. There is no notching here. So once you are confirmed that there is no notching, you are happy that position is externally rotated, then you can commit. So while committing, put a Homans, please. Okay, sir. So while committing here, check the process on the mediolateral side. So don't put on the medial side, don't put on the lateral side. This got an additional advantage of moving this jig on either side. That is a positive advantage with this implant system. So I'm putting this exactly at the corners If at all, if you want to overhang it, overhang on the lateral side, not on the middle side. Very good.
That's for the patella tracking, sir.
Yes, sir. Yes, for the patella tracking, you need to lateralize the femur. Okay, sir. I am holding at the center point. Put a pin, sir. Yeah, on this side. Yeah, screws, please. You don't have quick coupling, sir. Very nice. Just ask. Meanwhile, Jay Krishna, sir, why you are so silent, sir? I was surprised.
Jay Krishna, sir.
You are getting post lunch hypoglycemia or hyperglycemia or something, or
Professor Chavan Jay Krishna, sir. Sir is asking you that you're not asking questions.
Sir, Jagan sir.
Yes, sir.
Sir, the role of robotics, they talk about more about soft tissue balancing or bone cuts.
Yes, sir.
Which is better?
There are different schools of thought, sir. Robo is better or not? That is a big day topic. Robocon recently, Mr. Dachapalli, Sunil Dachapalli has conducted nice robotic workshop. We have attended there, highlighted. That is a big topic, sir. Robos may be useful, may not be useful, but still under evaluation. My advice is, as a technical savvy, my thing is you should go forward towards the robo. Langenbachs here, please. So always careful, sir. While cutting, don't damage the soft tissue. So as I mentioned, I'm going on the middle side, sir. Why I'm going on the middle side? If at all any notching, still I have a chance to correct myself. There is no notching. The blade has exited smoothly. There is no notching. So I am confidently, carefully, I can cut anterolateral aspect.
Sir, if there is notching now.
Yes, sir. You're telling something?
Sir, if you're notching, for example, you have taken this cut and if you're notching.
Yes, sir.
Generally, what I do is I don't put the screws that you have put.
Yes.
Because if you put those screws, we are basically fixing for the size that you have already chosen.
Sir, I told you, I checked it notching. I checked it, double checked it. Then I'm confident that it is notching.
Yes, just for the sake of
Yes,
audience.
yes, correct, sir. Surprisingly, this lady got a very sclerotic medial femoral condyle, sir, and tibia also medial side. Probably fluorosis is more prevalent here in Mahbubnagar.
Sir, some of the...
So show me here, sir, on the top.
Sir.
So you can see nice grand piano sign or Australia sign here on the top. That means it is external rotated and your cut is perfect. Here. Any idea?
In some of the parts of the Mahbubnagar where they're drinking the bore well waters.
Yeah, that may be the reason, sir.
Yes, that is one of the causes. Other one is
hold
your
it, sir. Hold it nicely. Hold
zonority. Zonority is also consist of lot of jowar.
Ah, yeah.
Yes, these are the 2 points.
So I'm cutting the posterior condyle, sir. Next. Blade correct ga undi idi. ఇది బ్లేడ్ డయామీటర్ ఎక్కువ ఉంది. బ్లేడ్ ఉందా? రైట్, చలో అయిపోయింది. రైట్, డన్. ప్రస్తుతానికి ఇచ్చేసి. So once you cut the anterior and posterior, I'm going to cut the posterior chamfer rather than the anterior chamfer. Why? Because for anterior chamfer, you are going to take a lot of bone stock. That will destabilize your jig. So I'm going to do a posterior chamfer first, then the anterior chamfer. Put a broad osteotomy here, please.
So you have nicely placed the homens, sir, during posterior cuts.
Yes.
You have to be very careful at the placement of homens, otherwise there is injury to the MCL and.
Done.
Hello, Jagan sir. Sorry for trouble.
Done. Come this side, sir. Amma blade marchali. Next is anterior chamfer. Right, sir. Next is trochlear groove, small blade.
Hello, Jagan sir. Sorry for disturbance.
Yes, sir.
The ultimate longevity, the lifespan of the TKR also depends on tibial slopes.
What, sir?
The ultimate longevity of the TKR depends on the tibial slopes.
No. It is a multifactorial, sir.
Yes, sir.
Multifactorial. Multifactorial means there are 5 basic steps. One is restoration of the joint line, stable fixation, balance in both sagittal plane and coronal plane, well, soft tissue balancing, then your joint will be long lasting.
Yes, sir.
It's not only depends upon the tibial slope, sir.
Very good, sir. Excellent. Especially in cases of unicondylar knee, that says the tibial slope plays a very great role in longevity of the unicondylar knee
Yes,
replacement.
I will tell you why,
compared
sir.
to the total condylar knee.
Yeah,
replacement.
because unicondylar knee is a different concept, sir. It acts like a ball and socket joint.
Yes, sir.
This is a hinged joint. That is a ball and socket joint. Where is this? Yeah, I want to highlight this one, please.
Very good, sir. Excellent.
This again, focus, please. This is a medial. This is a lateral. See the thickness.
Light, please.
Yeah, focus
Light.
on me, please.
Lightectomy.
Lightotomy. Yeah, are you okay, sir?
Yes, sir.
Yes, sir. We
So
can
this
see.
this is a medial side.
Yes, sir.
Nice, thick one. The lateral side is very thin.
Yes, sir. Very good, sir.
Yeah?
Excellent. Yeah.
So that
Well
means-
appreciated.
So step by step. This one, sir. What do you call? Right, sir. Nibula. Right. Right, sir. Any posterior osteophytes? X-ray. Yes.
Sir, every system has its own advantages and disadvantages.
100%.
So
push it here.
let's first talk about some of the very interesting advantages that the system is offering you. This Merrill, what are the advantages that you think that Merrill is offering?
Yeah, femur is very good, sir. But femur is good. Trochlear notch, it sit nicely. We can adjust medial lateral. Scoop, please. Medial lateral, we can adjust it nicely.
Yes, sir. Excellently. So I'll just point out some of the very interesting design concepts that the Merrill has used. First of all, at the end of the surgery, the femur fit is excellent.
Excellent.
It's because of the lug holes and the system we can medialize, lateralize for the when we are doing the cuts, and also the immediate post-operative flexion is very good with Merrill. That's what I have noticed.
Yeah.
They are mostly anterior referencing jig, which is also a very interesting concept.
Yeah.
Their trochlear groove design is really good, which is more patella loving kind of design. And anterior stuffing of the knee is less when compared to the other designs. Do you agree with me, sir?
Yes, sir. Yes, correct.
And coming to the disadvantages,
yeah,
the one only concern that I have is sometimes whenever we are doing the anterior cut, we should be little careful when compared to the other designs. Do you have any experience on this?
What, sir? That's fine.
When
on this side, sir, put a broader stratum here.
When you are doing the anterior cut, with this system, there is little chance of getting anterior notches since it's an anterior referencing one.
Yes.
Did you ever notice it, sir?
Yeah, anterior notching?
Yes.
I don't think, sir.
Okay.
Usually, notching is not a problem for here, but I noticed on the tibial side, sir.
But usually with anti-referencing system, Arun, notching is not thing, right? Usually it doesn't notch.
If the design, with the design, you're basically referring on doing anti-reference. If the design
Right,
is
copper
little
piece.
different, It will notch.
Tiger. And when your joint replacement is going on, there should not be any too much flow inside, and the door should not be open or closed. It will disturb the laminar flow system. I'm sorry to say. Okay. Diathan, please. Yeah. Theater discipline is very important. What do you think, Jay Kishan? Jay Krishna, sir?
Yes, sir. Yes, sir. Yes, sir.
Because in the laminar flow theater, if you open the what you call door, the laminar system will disturb and it won't affect it. So try in some institutions, we used to lock the door. Nobody should leave the theater. Nobody should enter the theater.
Yes,
Come
sir.
on, file, please.
Yes, sir. Yes, sir.
So that is very, very important, sir.
Only 5 members are allowed into the theater.
Yes.
Not more than that. Green room theater policy.
Correct, sir. What you are telling is absolutely correct. The nibbler is Chinna nibbler, amma. Excellent.
So it's just for a debate, sir, healthy discussion and funny discussion. So there is a very recent paper where they compared laminar with laminar airflow theaters where the number of door openings are less than 10 and more than 10.
What is, sir? What? I didn't catch the point.
Number of door openings in a laminar airflow theater less than 10 and more than 10.
Okay.
And the rate of prosthetic joint infection. They told there is no difference.
No difference. Okay.
Just for a healthy discussion.
Now, how quality is the paper, sir?
So it's published in the Bone and Joint Journal only.
Okay.
So, but however, now as you told, there are many.
I think definitely it will distract the surgeon, sir. So first and foremost, I think should not.
But as you rightly mentioned, the laminar flow system will be disturbed definitely.
Yes.
Looks like you have achieved a nice balance,
we
sir.
put a nice femur.
Yeah.
We got a full extension.
Yes, sir.
With the 9 mm. Stable medial lateral.
Yes.
And see, there's some lateral, little bit patellar subluxing. I will release this. One clamp, please. What you call Alice?
If you're okay with the extension, you can remove that lateral pin, sir.
Yes,
Tibial,
yes.
tibial pin, you can.
I will remove, sir, in a minute. Just hold it, please.
Yeah, it looks tracking very well, sir.
Yes. Pin removal, please.
Stable in both flexion and extension.
Yeah.
So there is no fixed flexion, 5 degrees, 10 degrees, nothing. Complete free. There is no flexion contracture.
Yeah, there is no FFD, pre-operative, no FFD post-op. It is fully straight, full flexion, and no lift off. Mild, that is okay. When you put implant, that's fine. There is no lift off. Okay. I think we'll prepare the tibia.
The collaterals are good in position.
Yes, sir. See.
All is well. All is well. All is well. Yes.
Yeah, full extension, stable, 15 degrees, stable.
Flexion, extension gaps are well maintained.
Well maintained.
Yes, sir.
So what I'm going to do is, I will prepare the tibia. With the 9 mm, we are okay. Femur teppinchukowa. Extract the femur, 2 homens, please. Thank you.
Sir, you know.
Yes, sir. Jai Krishna, sir.
Yes, sir. In cement mixing.
Yes, sir.
Do you prefer vacuum or laminar flow or deep? 16.
Yes, sir. Ideally,
16,
I should follow
18.
the 3rd generation cementing technique.
Yes, sir.
Like vacuum mixing, bone preparation, absolute dry, hydrogen peroxide, and clean field, and ideal room temperature. Then I use the mixing, vacuum mixing.
So you use 3rd generation mixing, sir?
Yes, sir. Yes, but not here.
No, yeah.
Yes, ideally 3rd. Here doesn't matter, but mainly if you do a cemented hips, it will matter, sir.
Yes.
If you see the X-ray, the barracks grading should be absolute, chalky white. It should be barracks A, grading A. Right, sir? Double prong, please. Homens, PCL retractor. ఇది కదమ్మా బ్లంట్ ఇవ్వా బ్లంట్ అక్కడ ఇక్కడ ఉంది మీ దగ్గర ఉంది రైట్ వెరీ గుడ్ రైట్ అమ్మా మాప్ ఇవ్వా ఒకటి బిగ్ మాప్ సో ప్రొటెక్ట్ హియర్ just leave it sir protect here just lift it up yeah flex it nicely just put one more here can I have one more homens small homens please baby homens if you have baby homens right sir hold two please small nibbler please sir you have to flex it hold it like this sir small nibbler please. So when you implant the tibia or prepare the tibia, you should see 360 degrees, sir. If you can't see the 360 degrees, you can't put the tibia in a correct position. So that is a very, very important. That I'm going to take it the osteophyte, sir. So take the diathermy, identify the margin nicely all around the tibia, sir. Right? Okay. So I'm going to see these are the edge osteophytes on the anterior. Just nibbler, please. Yes, sir. Right, sir. I'm going to nibble it out. That's fine. Nice, beautiful. Tibia. What is the size, sir? So size 2 is nicely sitting. I think. Give it 3, please. We can try with the 3 also. There is nothing wrong in testing the 2 and 3. The paper shows that you should put maximum size of the tibia possible without hanging, overhanging. What is the size of this, sir? 3 koncham overhanging avutundi posterior ga. We'll go for a 2. So always try, nothing wrong. Ali, nothing wrong. So what you need to do is first rod petali. So move the straight, sir. Amma, itla straight petkondi. Right. Lift it up, sir. Idi pai kanandi. Right. Right. So shin, center of the ankle, second toe. Right. So bring the what you call amma piniva first. First we'll put anterolateral pin. Wait, sir. Wait. Yeah, put anterolateral pin. Don't put all the way down so that you can have some play. So now you can check the 2 points, the center of the ankle or the tibial tubercle. This is the tibial tubercle, middle third of the tibial tubercle. Right. Oh, wait, Amma, wait. Covering. Yes. Yeah. Yes, please. Yeah. Right. అవును ముందే sclerotic bone. Yeah. Beautiful. Nicely sitting. Yeah. Yeah. Give a small blade, please. So in a varus, this is a varus. I told you the medial femoral condyle is more what you call sclerotic. Just I'm going to give a small what you call yeah, again Christmas tree. Mallet. Okay. Three, 4 times if you keep, otherwise on the middle side is a more sclerotic bone, it will lift off. Yeah, size C left, 2 tibia. Yes, good. And poly also open, please.
What is the size of the stem, sir? Tibial stem?
Tibia is size 2, sir.
Femur, sir?
Femur size, C means 3. Load a pin, please, small pin.
So Jagan sir, I think we'll go on with the closing ceremony. I
Okay.
think it was an excellent demonstration, sir. We could see the implants in place with full extension and
Yes, sir.
very good tracking.
Okay.
Thank you so much. And,
Thank you. Thank you
really
for giving
appreciate
this
for your time.
opportunity. Thank you, moderator, sir.
Thank you, sir.
Thank you.
You have explained very well, especially for the
Thank you,
residents
sir.
and junior surgeons. Step by step, that was an excellent demonstration. Thank you, sir.
Thank you.
Thank you, Dr. Chavan Jayakrishan sir and
Sir,
Dr.
Jagan, sir?
Yes, sir.
It is excellent, marvelous surgery.
Thank you. Thank you very much.
Very good, excellent, marvelous. Sir.
Sir, Jagan sir
Thank you,
should
sir.
be very happy. Your friend has given a great appreciation for you. Okay, thank you so much.
Okay, thank you, sir.
Thanks everyone for joining the orthoplasty course today, and it was an amazing show of surgeries. And thank you everyone once again. We'll see you next year the same day.
You are closing, sir?
Yes, Jagan sir, we are closing.
All right. Thank you, sir. Pulse lavage, please. Itla cheyandi amma. To put some pins that will help in interdigitation. Right, sir. Chalo. ఆఫ్ చేయండి అయితే ఇంకా అవసరం లేదమ్మా చూద్దామా సిమెంటింగ్ రికార్డ్ చేయి ఎందుకని ఎనీహో వీఆర్ రికార్డింగ్ హియర్ కదా అట్లాగా సార్
Jagan sir, we are recording. Let it be recorded.
Yeah, that's the thing. Just I said to continue. Amma, 7.5 gloves, pulse lavage, 3 liters pulse lavage. Sir, oksari angel wing iva. Angel wing you. Poly తీసేసుకో. Amma, continue recording, please. We have not yet finished the surgery. Battery finished? Amma, pin oksari iva. Pin తీసేసావా? Pin తీసేసావా? 2-3 pins వేద్దాం ఇక్కడ. Right, sir. Pulse lavage connect చేయండి, sister. Are you okay, Ali? Dr. Abhinav, thank you for helping me. You are great. So, because surprisingly, this bone got a sclerosed bone.
Jagan sir, we are still recording your presentation and it is running live.
Okay, sir.
Okay.
I'm just putting a small multiple holes in the tibia because it's a very sclerotic bone that will help in good interdigitation of the cement, sir. That is only the main thing. You have loaded the cocktail, anesthesia cocktail, I think. What is this, Amma? Anesthesia cocktail. Anesthesia cocktail you have to give it now only. Sir, lift the femur. So this is also very, this is the one somebody has checked. What is this? Madam, who has checked this one, sir? What you are giving? Morphine. Okay, anavin is 0.5 anavin. Okay, that's fine, sir. So this is a local cocktail. You push it. So we have to give at the different space. At this moment, I'm going to give in the posterior capsule. Posteromedial, posterolateral, not at the center. If you put at the center, there is a risk of vascular injury. So lift the femur. Like that, sir. I'm giving a corner on the posteromedial. Always aspirate and give a nice injection. That is the one thing. Whole volume intana inka unde. This is a posterolateral. Some amount will give a medial side. And some on the quadriceps tendon. This is a local. Okay, sir. Nice. Take this off, sir. And give a cocker, please. There is some remnants of meniscus. I'm going to take it off. Pulse lavage ready amma. Pulse lavage చూద్దాము. అన్ని implants open చేసుకో. చెప్పేంత వరకు మిక్స్ చేయొద్దు. రైట్ అమ్మా, మెనిస్కస్ తీసేసుకోండి. రైట్ సార్, ఓకే. Pulse lavage please. All should stay in the gloves after pulse lavage. Suction connected, both sections. So very good advantage with the pulse lavage. It will remove the bone debris, fat and blood. That will give a clear dry bone for your cementation. Endama? Yeah, all should change them. Nibbler. అమ్మా, హోమెన్స్, చిన్న మస్కిటో ఇవన్నీ క్లీన్ చేసి పెట్టుకోండి. ఫ్రెష్ షీట్ వేద్దాం ఇక్కడ. ఇవన్నీ క్లీన్ చేసుకోండి అమ్మా. నాకు నిబులర్ ఇవ్వ, చిన్న నిబులర్. సార్ అనస్థెటిస్ట్ సార్, ఐఎమ్ గోయింగ్ టు సిమెంటింగ్ ఇన్ ఫ్యూ మినిట్స్ టైమ్. So you should warn the anesthetist while implanting the cement. Why? There is a risk of bone cement interaction syndrome. Diathermy please. అమ్మా సర్జరీ అయిపోయిందా ఇంకోటి? ఏది హిప్? హిప్ నీ కూడా చేస్తున్నా అన్నారు. ఓన్లీ ఇదే? అచ్చా అచ్చా అచ్చా, సారీ సార్. రైట్ సార్, ప్లగ్ ఈజ్ రెడీ. పైన ఉంది ప్లగ్, సరిపోయింది వద్దు. రైట్ సార్, చలో అమ్మా. ఫస్ట్ ఏం చేద్దామంటే చేంజ్ ద గ్లౌస్, పుట్ ఏ న్యూ షీట్. అమ్మ ఇది బయటకు వెళ్ళిపోండి. కొత్త షీట్ తీసుకోమ్మా, తీసుకో, కొత్త షీట్ తీసుకో. ఇది ఇచ్చేసి అమ్మ ఇది క్లీన్ చేయండి. ఆల్ షుడ్ చేంజ్ ద గ్లౌస్. యూ ఆల్సో చేంజ్, యూ చేంజ్ గ్లౌస్. అమ్మ రామ్మా, అంత పెద్దది వద్దు, చిన్న చిన్నది చాలు, చిన్నది తీసుకో. రైట్ సార్, ఇట్లా పట్టుకోమ్మా. రైట్, ఇక్కడ ఇక్కడ మార్క్ చేసేసుకో. వాటర్ క్లిప్ వేసేసుకో, వాటర్ క్లిప్ వేసేయి.